ये जो हो जाएगा सब। देखो ऊपर लाइव स्ट्रीमिंग का लिखा हुआ आ गया। दिस मीटिंग इज बीइंग लाइव स्ट्रीम।
ओह, आ गया।
लाइव स्ट्रीम अभी तक आया नहीं है।
अरे
जस्ट
सर,
अ
वही
सेकंड,
तो हम लोग
जस्ट अ
कर रहे हैं।
सेकंड।
वही तो कर रहे हैं।
ओके ओके ओके।
आशीष,
हाँ।
ये लो। आई
आई
फ्रेम
फ्रेम
ई।
आई फ्रेम उधर डालिए ग्रुप में। हाँ।
दे दिया, दे दिया।
हम्म।
तुम डाल दो कि मैं डालूं?
नहीं, मैं डाल रहा हूँ, मैं डाल रहा हूँ।
डाल दो ना, मैंने अभी लॉगिन ही नहीं किया उस पर।
मैं लॉगिन करके बैठा हूँ, पेज ओपन करके।
हाँ, हो गया।
हाँ।
जो मेरा ऑनलाइन लिंक है ना उसमें नहीं आ रहा है।
एक मिनट, यहाँ पर दोनों चालू है।
हाँ
पहले
हेलो।
हाँ, हो गया।
हाँ हाँ, हो गया।
मैंने इधर डाल तो दिया। आ रहा है। आई आई इन डी 2024।
आशीष,
हम्म।
वो यूट्यूब का म्यूट करके रखना, नहीं तो अपने को उसका भी सुनाई देगा ना, तो अपने को कंफ्यूजन होगा।
ओके।
यूट्यूब वाला जो यूआरएल ओपन किया ना, उसको म्यूट रखना बस खाली।
अभी आ रहा है ना?
हाँ, वीडियो तो
लाइव हो
दिख।
गया है सर।
हम्म। वो लोग है ही नहीं, वो लोग गए अपना करके, अपने लाइव कर दिए बस।
सूरज सर।
Association, with the goal to create an educational platform to disseminate high quality medical education in diabetes and endocrinology to national and key opinion leaders. The goal is to bring these experts under the banner of India Diabetes Endocrine Association and to reach out the primary, secondary, and tertiary healthcare providers with education being a primary objective. In addition to which, we also discuss the latest research in plenary sessions and case discussions. At the outset, we would like to thank the following companies for their active participation, without which this event wouldn't be possible. Our deepest gratitude to Novo Nordisk, Johnson & Johnson, Novartis, Sun Pharma, GSK, Eris, Cipla, Sanofi, and Bayer. Without any further ado, I would like to hand over to Sir Altaf Patel to take the pleasure to introduce all our speakers. Thank you.
Good morning and welcome to India 2024. I hope we have a much better online audience than we have here. But it's good to see Professor Date sitting there. He's always there in every conference. And we should give him a standing ovation, actually, for always being here. Right? Well, having said that, the first speaker is Professor Dr. Prateet Samdani, who is a senior intensivist and internist. He was advisor to the COVID-19 task force. He orchestrated the largest human biobubble in human history, acknowledged by National Geographic. He's a principal investigator in many drug trials, and he is associate professor at the JJ Group of Hospitals and consultant physician to British Candy and Saifi. And he's going to talk to us on herpes, and I will ask and request him to keep within the time spans and limits. So we have a little time for questions at the end of it all. More learning is done by question answers than by questions.
Good morning. Audible? Can I get a pointer? Okay. So today I'm going to be talking about herpes zoster, its natural evolution, and what it does to humans, especially as you age. And I'm going to be brief on my slides. We'd rather have an interactive session as requested by Dr. Vishal Gupta. So let's see the epidemiology. And it's important to know that the incidence of herpes zoster is extremely high, almost 4 cases per 1,000 people a year. And if you cross the age of 60 and above, the number of cases rise to more than 10. We have limited incidences. General US population about 32%. That means almost 30% of people in the US suffer from herpes zoster sometimes in their life. And people who survive above the age of 85, and as we age, we know our longevity today is increasing. The incidence could be as high as even 50%. Recurrence rate of 8 years after initial herpes zoster vaccine, after herpes zoster infection is also well documented. In immunocompetent people, it's about 6%. In immunocompromised individuals, it's much, much higher, about 12%. And overall, it's about 6%. That means if you get herpes zoster infection once, you can still get it the second time. And this follow-up is about 8 years after the first thing. What are the real risk factors for herpes zoster? It's increased. The most common, I think, is advancing age rather than anything else. So the older you are, the more likely you are to get it. As I repeat, if you're above the age of 85, the chance is almost 50%. And from epidemiological studies, we know the incidence of herpes zoster increases above 50 years of age. And I'll tell you why that's happening. Female sex, females are much more, unfortunately, likely to get infected than men. Physical trauma and immune system compromise, of course. So this is something that's done from India. And if you see, there are 27 studies. Above 50 years, the incidence is somewhere between 15 to 80%. And thoracic dermatome is the most commonest site involved. And the incidence is almost 40 to 70%. Post-herpetic neuralgia, I think that's the one biggest complication that people suffer from. That's our fear for our patients too, is about 10 to 55%. And people, if any one of us has suffered from it, we can only realize how bad it is. What does aging do? So aging is a gradual physiological process, and unfortunately, cognition. This is something so common. As we age, I think our cognitive decline is going to increase. So memory and processing speed deteriorates rapidly and interferes with the ability of maintaining daily activities. So that's one unfortunate thing, something that we really can't reverse. We can delay. I wouldn't say we can prevent it. Hearing loss, very, very important again, most noticeable at higher frequencies. Once you have hearing loss, the communication, the ability to social activities decline significantly. The skin, the physiological largest organ, genetics and external results cause deterioration. Risk of skin condition and tears increases. Then, of course, vision, that's another big problem. Ability to focus decreases, risk of cataracts increases, there's macular degeneration as you advance in age. Limited mobility. So imagine if you can't hear, you can't see, your skin is bad, you can't feel. I mean, your all senses are almost declining. Capacity to respond to new infections, the immune function deteriorates with age, and we know that because of T lymphocyte deterioration. And the muscle mass, bone density all decline with cartilage tears, which cause significant structural changes as you advance. So there are frailty and resilience. What are the frailty, if I call them indices or the frailty factors? Excessive alcohol, cognitive impairment. So they're modifiable and non-modifiable. Alcohol excess, of course, is modifiable. Frailty, polypharmacy, social isolation, and smoking. Nutrition, physical activity, good access to healthcare, vaccination, and prevention of chronic diseases like coronary vascular disease or cerebrovascular disease is something that we can have resilience to. Now, why does the incidence of herpes increase with age? So we all know that herpes zoster is the same thing as chickenpox. So when you have varicella infection, that's varicella, it induces a primary varicella specific cellular immunity, and that's chickenpox. Whether it's you've had the vaccine or you've had a natural infection, I'm talking about the natural infection here. Then you get varicella specific cellular immunity, which may be boosted periodically by exposure or subclinical infections or reactivation from latency all through your life. But if you're above 50 years of age, varicella specific cellular immunity declines. So if you see this has been studied. As you go above 50, there's a decline in this immune system immunity, and that's why the incidence is higher. There's decline in cellular immunity, which is associated with a higher risk of shingles. These are for immunocompetent patients. The people who are immunocompromised, they get infections much, much earlier, and I'll give you the reasons later. The burden is also extremely high. As you see, the incidence really increases above 80. I'm going to skip this. I think this is an interesting slide. In addition to age, a variety of other factors can actually further elevate the risk of herpes zoster. Female sex, 20% higher likely to get it. Family history. So it's been now found in several studies that if one person has got an infection, there is a higher chance that the second and third and fourth person living in the same house or of the same family have a 2 to 3-fold higher incidence. Stress, I mean, stress is something that every one of us goes through every single minute. 50% increased risk. COVID-19, I'll touch on it a bit, 15 to 20% increased risk of infection if you suffer from COVID-19. HIV and AIDS, 3 times, malignancy twice, autoimmune diseases, 1.2 to 2 times. So when I tell you all these factors, we must be very, very vigilant with these kind of patients. Post-surgery risk, steroids use, cardiovascular diseases, and respiratory disease like COPD and asthma at a very, very high risk of getting herpes zoster because they are on corticosteroids, whether inhaled or orally. And diabetes, of course, the forte of this morning, 40% higher risk of getting herpes zoster. We've seen that patients with immunocompromising conditions have a higher risk, and the incidence is highest in patients who had bone marrow stem cell transplants. And then you have all the other malignancies, autoimmune diseases that follow it. Clinical aspects. The primary varicella infection, varicella zoster infection, usually occurs in childhood and manifests as general vascular rash. We've seen this. Then there's a latency. This period of latency is established and the primary infection induces cell-mediated immunity, preventing subsequent infection and reactivation. I've taken thoracic spinal cord because dorsal thoracic are the commonest sites. And then there's the virus actually sits latent quiet, silent in the dorsal root ganglion. And then when it gets reactivated, it affects the sensory neurons. And that's how you get zoster lesions and severe pain because the sensory neurons are affected most. And then you get reactivation of herpes zoster later in life. And we've seen herpes zoster rashes. Let me tell you that it's typically taught, remember that herpes zoster can only be found in one dermatome, doesn't cross. That's true. But you have we've had many patients who get multiple lesions of herpes zoster. They can be thoracic, foot, eye, all together at the same time. So, but the real clue is it does not cross the midline. So you can have one dermatome on one side, the other on the other side, but you can get multiple lesions of varicella zoster. The pain of varicella zoster and post-herpetic neuralgia is compared to any other kind of pain, including myocardial infarction, terminal malignancy pain. So I'm going to skip that. It's terrible. And it can persist for months, as long as 5 years. I've had patients who still complain of pain even after 20 years of her. We've done nerve blocks, root blocks, pain management, steroid injections, everything. The pain just doesn't go in a small subject of patients. And what I've seen is most of these patients, unfortunately, are female, not because the incidence is higher, but that's what I've seen practically. It impacts the quality of life. Everything is affected. All the symptoms, all the organs are impacted. Any organ can be impacted. General activity, mood, walking, everything is debilitated. So your normal quality of life deteriorates significantly. And if you get into the post-herpetic neuralgia, you've had a real roller coaster of a time. Let's look at this COVID patient. 55-year-old gentleman with a history of childhood chickenpox and COVID-19 infection. So this point is very important when we explain our patients about herpes, that if you had chickenpox in them, because most patients ask you, what is herpes zoster? Then you tell them in the colloquial language, it's this, you get a rash. It's like chickenpox, but I've had chickenpox in the past. Should I need a vaccine? Why should I take a vaccine? I already have that infection. As I said, I told you the pathophysiology. If you've had chickenpox, obviously it's dormant and it's going to get reactivated. The chance of reactivation is higher. COVID infection 21, present with severe burning, stabbing, shooting pain on the forehead and nose. He subsequently developed fluid-filled skin lesions, which then formed erosive ulcerative lesions on left side of his forehead. You can see the picture, left side of the tip of the nose, along the considerable swelling on the left side. So the full left face was affected. You can see the picture very, very well. Patient developed severe pain in the left eye with blurring vision, and soon after that, he could not see from the left eye. The patient visited a dermatology clinic 4 weeks later with the ulcerated lesion on the nose and over the upper lip. I don't know whether he took some tablets before. Assuming he did take some tablets because this was so painful, he would have visited a doctor. He would have taken some antiviral. Tip of the nose and left forehead was scarred. Eye was red and suffused. He had conjunctival congestion with corneal opacity. So his vision was almost zero. He was unable to see from the left eye. The patient was neither immunocompromised nor did have any comorbidities except for his age, 55, and a past history of COVID-19. He was not diagnosed and not treated correctly. So he did go to the doctor, but some doctor said it's just some infection, just wait, don't do anything. Antivirals could have prevented this severe morbidity, and I think the role of antivirals to start early is very, very, very important. The moment you see a lesion that looks like herpes, there are some tests, and the best test is your eye test. Look at the lesion with a magnifying glass in a clinic, and you will find a vesicle. The moment you find a vesicle in a dermatomal presentation, this is herpes zoster. In spite of supportive treatment with topical and systemic antibiotics, he was left with scars. It took almost 3 months to recover with conjunctival congestion. He may benefit from corneal transplant surgery in the future. We'll have to wait. Patient was the sole earner, so he had a social problem. There was a financial issue, was a bread earner. And this dreaded complication probably could have been prevented if he was vaccinated for herpes zoster. So I'm just going to take some patients or some cases where herpes is very, very common. The first one being herpes zoster itself is reactivation, as I've told you. Common complication is ophthalmicus, the patient that I just showed you, and post-herpetic neuralgia. These are the two most dreadful complications. And we've had patients who had a cognitive decline post-herpes, social inhibition. If you get it on your face and your eyes, there's a lot of social inhibition. They don't want to go out. Age, and as I've told you, about 50 and more than 85, certainly. and the incidence has increased all over the world. These are some of the risk factors, some of which I've already told you before. If you are a diabetic and if you have cardiovascular disease, the incidence of herpes zoster is high. If you're a diabetic, vis-a-vis diabetic and heart failure, again, the incidence is higher. If you have COPD and diabetes, vis-a-vis just diabetes, the incidence is much higher. And if you have COPD and heart failure, vis-a-vis just diabetes, the incidence is higher. Just to tell you that diabetes alone, vis-a-vis another comorbidity, has a higher incidence of herpes zoster. So what about diabetes? Why do diabetics why do they have a higher incidence? Of course, we know diabetes, there's a disorder of humoral immunity. Incidence of getting herpes zoster. When you have ESRD, you're on any kind of renal replacement therapy, whether you're on hemodialysis, peritoneal dialysis, or you've had a kidney transplant, the incidence increases much, much more. And the highest is in patients who've had a transplant. As I've told you, hematopoietic stem cell transplants had the highest incidence, and then any other solid organ transplants had a higher incidence. Autoimmune diseases, you can see that there's almost a 2 to 3-fold increase of incidence of herpes zoster when you suffer from any autoimmune disease, even a simple autoimmune disease like basic rheumatoid arthritis without an overlap. So again, the incidence is high. Today, we have a vaccine that can actually decrease the chance of getting herpes zoster, and the efficacy is excellent. We have two parts of the vaccine, the antigen called the glycoprotein E and the adjuvant. The antigen actually elicits a specific immune response against the zoster, and then you have the adjuvant which enhances the immune response to the vaccine antigen. I will not speak about the studies. I will just tell you that the efficacy of these 2 shots of this vaccine is more than 90%. And the efficacy is astonishing good. If someone can tell me how long can you get immunity from if you take 2 shots? Guess? 5 years? Anyone else? Take a number. Yeah, it's almost 10 years. So the efficacy is more than 90 to 95% for as long as 10 years. This slide shows that. And it also decreases the post-herpetic neuralgic complications. This is it, 90% efficacy against shingles up to 10 years. It's very, very safe. It's been compared with other vaccines and placebos, and the incidence of side effects is similar. These are the 2 trials. One was supported by GSK, who makes the vaccine. The other was not. And the vaccine efficacy was both against prevention of herpes zoster and against post-herpetic neuralgia. So I'm going to ask some questions. We all know that this has been approved, and we can have this now interactive, Vishal. Yeah. So when would you give a herpes zoster vaccine, and who would you give it to? I've given you most of the data, but I'll give you some specific instances. Above 50, 100% to everyone. Yes. All diabetics.
With no obvious risk factors. These are the people who are following up.
So I think because it's so safe, if you have one risk factor, as you said, even an autoimmune thyroid, or if you have a risk factor, I mean, I would consider a risk factor also living with someone who's had a transplant or is immunocompromised, because you're not only going to, it's like COVID-19, you're not only going to infect yourself, you're going to infect the family members too. So I would also take heed. But the issue here is you'll have to explain to the patient that the guidelines is above 50, you're at high risk, so we are giving it. I also use this sentence to every patient who I prescribe vaccines. Like vaccines are like marriages. It doesn't mean happily ever after. He develops GBS after 6 weeks or 3 months. He gets fever. I'm not going to be held responsible for that. So you must tell them that all vaccines have side effects. The typical side effects is 1 in a million for any vaccine. So that's something that I keep telling them. Yes, any other patient, any other specific consideration? What happens when someone is on chemotherapy? So we don't have an immune assay to measure the IgG levels, but typically I think 10 years, like the flu vaccine is used once a year, but for those high risk patients like COPD, I actually tell them 10 months because the last 2 months the efficacy really reduces. So at least 10 years, 8 years, yes, certainly 8 years for some high risk group patients. Suppose you've had herpes zoster 15 days ago. What would you do to this patient? And when I say what would you do to this patient, it means this patient and the family members. And that's interesting because we often try to treat the patient and not the family members. The family member should be given, especially if they're above 50, as I told you, household contacts, and is much, the incidence is 2 to 3.2% times higher if you're exposed to herpes with a family member. So will he ever require it? Okay. So the natural infection immunity actually fades off within 6 months to 1 year. So the earliest he can take the vaccine is 1 year later, and not he should take the vaccine at least a year later, and that'll give him protection for about 10 years. What about someone who's on rituximab for lymphoma, for autoimmune diseases? What is the timing of giving him herpes zoster vaccine? So this is a slide that I've showed you. Immunosuppressive treatment not to be interrupted for administration of inactivated vaccines. So you should continue immunosuppressive treatment because that's life-saving, not the vaccine. Continue immunosuppressants except rituximab and glucocorticoids, and I'll tell you when do you stop them. In patients who receive rituximab, immune-mediated diseases treated with rituximab require optimal vaccine immunogenicity, immunization, and should be deferred for up to 5 months after the last dose. So if they're taking cycles of 3 monthly, 6 monthly, wait for 5 to 6 months before you give them. CDC recommends, CDC says something else, that for patients receiving anti-B cell therapies like rituximab, administer dose of RZV approximately 4 weeks prior to the next scheduled therapy. So they say that you can give this patient 1 shot of the vaccine, which will also protect you as much as 70 to 80%. That was there on the slide. I just skipped it when I showed you the 90% efficacy. So you should give it 4 to 6 weeks, 4 weeks before the next chemotherapy. Patients who are on corticosteroids is an important point. If they're more than 20 milligrams of prednisolone equivalents, defer vaccination until taper to below 20. So usually use more than 20 and 30 and 50 milligrams if they have an acute exacerbation of a disease or you're treating them acutely. And then of course it tapers down. So you should wait until this happens. Any other questions? So the immunity is certainly badly affected, but if the dose is about 20, the incidence of complications because of the vaccine is higher, and the immune response of the vaccine will not be so great. The issue is the immune response rather than anything else. So there is no study. So that's exactly what Dr. Vishal asked. Would you want to give a third dose or something like that? So at least not for 8 years at this moment, according to what studies we have, earliest 8 years. But yes, after 10 years, you'll have to take another 2 shots. Can you give the vaccine together with combined with any other vaccine? That's a practical question for people who administer vaccines. I have the slides. I don't want to read them. So just suppose you're giving influenza vaccine, pneumococcal vaccine, Tdap. So these are dead vaccines, all of them. You certainly can give all of them together on the same day. But the shingles vaccine is more painful. It causes a little redness and you can get fever for up to 48 hours. You should warn the patient that if he has an important meeting or he's traveling, don't take it. So usually I like to give them over the weekend, Friday, Saturday, so they're okay. But you can combine together on the same day. All vaccines should be given on the deltoid, please. My first patient who I wrote Shingrix and I wrote IM, took it from somewhere else, gave it on the buttock. It's happened to some other people also. Yes, no, so there's no direct epidemiological study to say, but if you have an inflammatory process, the incidence of any viral infection certainly will increase. It will increase. So I will, okay, so that's another good question. I'll give you a live example of a patient who I saw 3 weeks ago. She's been having, she lives in the US, abdominal pain for a long time. And she had lower abdominal pain. United States of America, did an upper GI endoscopy and nothing found. But she had colonic pain. To me, it looked like IBS. She came to me, she saw me. And I said, you need a colonoscopy and a CT, not an upper GI endoscopy because you don't have upper GI symptoms. She said, but I have this pain on the right side near the liver, right hypochondriac. I said, oh, since when? She said, this pain keeps and goes and comes, but in the last 5 days, it's much, much more. And this patient's been suffering from abdominal pain for 2 years and 3 years. So obviously, one would have just left it and said, you know, this will settle. This is a part of IBS. I just told the sister, let me examine her skin. And there I found a small little rash. I took the magnifying glass. I took a picture and I showed her. I just saw a small 1 millimeter vesicle. And I actually treated her with antiviral valacyclovir. And that pain went away. Of course, the lower abdominal pain didn't go away. My answer to your question is, pain starts before the rash. So the pain starts 4 to 5 days before the rash. Anyone complaining of a sharp shooting dermatomal pain, please ask the patient to be vigilant for any rash and inform you. You can't just start antivirals. You know, many patients, practically we get complete tingling, ringing in the ears, ringing in the ears, ringing in the ears. And you can't see anything. But if they've had a small vesicle inside the ear, which was never diagnosed, this is like a post-herpetic pain. It's a post-herpetic neuralgia. So I often give them gabapentin and pregabalin because now the disease is over. This is PHN or whatever. And they improve over a period of time. Not on suspicion, but I saw the rash, I saw a vesicle with a magnifying glass and I gave it to you. The side effects of hepatic and renal toxicity, it's a major side effect, but otherwise it's well tolerated besides the nausea and vomiting, very well tolerated. I won't take a chance. I'd tell the patient, come back if you get a rash. No, rash, they'll notice. The pain is so agonizing that you'll actually come to know. Thank you.
What talking about is very important.
Shit.
Thank you for I hope you're not referring to my age when you said old friend. I am old, so I acknowledge, and one of these days all of you also become old. The topic that's given to me is about NASH, and I have taken liberties to bring it to the context of current terminology, but we'll use both these words, at least initially, interchangeably. I don't see many people, but do you have your internet on? At least some of you. So I will ask you to calculate the FIB score, and that should be a practice. So please go to your Google this thing and go type FIB4 score. So this is a lady I saw just the day before yesterday. She's 54 years old. She's diabetic, hypertensive, has dyslipidemia, has primarily come to us because the ultrasound showed a grade 2 fatty liver. She did her SGOT, which was 24, SGPT 24, these are within normal limits. Her platelet count was 1.59. So I would draw your attention to this, and look at the platelet count also in future, not just at OTPT, and we'll tell you why. We calculate the FIB score for her. Do you have that thing with you? Have you tried to log in? So age is 54. SGOT is 24, SGPT is 24, and platelet count is 1.59. You got a score or something? I think it will be identical to what I have calculated, because the FIB score is 1.69. So it is 1.69. So this is important. Imagine this woman has nothing. OTPT is normal, but the clue there is low platelet count. And if she's not had any recent fever or dengue or anything, this has been going on for quite some time, and she's not treated for ITP either. So what is your next investigation? And we will take you through this in this conversation. The next thing is transient elastography. Anybody whose score is more than 1.3 should be stratified. And if her score is 22, what will you do? If her score is 18, what will you do? We will talk about this shortly. And there again, the platelet count will come, but we will see that slide subsequently. So this is something which is not unknown. If you go through papers in diabetes care, they say that liver diseases are sometimes more frequent than the cardiovascular disease, which we are quite fancy about, and we keep on trying to treat them. And the unfortunate thing now is that there is no treatment. You might ask us, why should we learn about a disease for which there is no specific treatment? The answer is very simple. Till the early 60s, we did not have even diagnostic criteria for diabetes. We did not know its pathophysiology. There were only 2 drugs and 1 injection. And we still learned and we were taught about diabetes. So first we have to understand the disease, its prevalence, importance, what it causes, learn the pathologic mechanisms, pathophysiological mechanisms, search for drugs and apply. There's no point having something which you do not know anything about. And as things come, you realize that our emphasis as clinicians is more to things which have got therapy, but we also have to understand that we need to understand the pathophysiology of certain diseases for which the work is still in progress for therapy, and the biggest therapy is lifestyle modifications, which none of us wants to do. So the definition of this particular disease is a chronic condition which was previously called NAFLD, characterized by accumulation of fat in the liver more than 5%, displaying macrovascular steatosis, and this is diagnosed of exclusion. You have to rule out drug intake in our country, and especially in Telangana, alcohol intake. And also, in the past, people who were defining this had defined as non-alcoholic. And that actually is very stigmatizing to some people. And there also, they said that with increasing consumption of alcohol across the world, including the Western countries, they would say that if somebody is consuming less than 20 grams of alcohol per day for women or 30 grams for men, then it would still be considered non-alcoholic in that part of the world. And it could range from steatosis to steatohepatitis to cirrhosis And the non-alcoholic steatohepatitis was a condition wherein there was fat accumulation and inflammation and hepatocyte injury, like ballooning. So this diagram is something that you might have seen. This is a question of diminishing returns, which is good for us. That not all people will develop hepatocellular carcinoma, but that's at the fag end of it. Normal to steatosis, 25% people will go. Some steatosis to NASH, 60%. Another 40% will go to fibrosis. 22% will go for cirrhosis, and then hepatocellular carcinoma. But this was a purely hepatocentric approach. What's more important, relevant now is the epiphenomenon that it has in terms of diabetes, in terms of coronary artery heart disease, and why that happens, we shall see shortly. The new nomenclature, which has come up and has been adopted by major societies, is a metabolic dysfunction associated steatotic liver disease. They have just changed the name from N to MA. Now, why is that? You do not stigmatize people, and also you have included the term metabolic, which means that you're looking beyond liver, you're looking beyond cirrhosis. The gastroenterology colleagues are interested in it, but they are wanting to prevent HCC, which is a very important component. But as physicians, which I am also a practitioner, we are interested in how well we can treat these patients, how well we can manage their metabolism and risk factor for coronary artery heart disease. Now, this has two components. The MASH, which is metabolic dysfunction associated with steatohepatitis, and MET-ALD, that is the metabolic dysfunction associated liver disease and increased alcohol intake. This includes people who are taking alcohol, and then of course the intakes are as we have discussed earlier. This is a terminology which will be used henceforth by most people, so we need to know what this means. Now, the adverse outcomes, of course, as we said, are hepatic, all right, but they are also in terms of relation to obesity, in relation to prediabetes and cardiometabolic risk factors. If you remember correctly, last year when we discussed that as long as the fat is in the normal locations, that is subcutaneous tissues, it's okay. As long as your money is in the banks, it is okay. When you put it elsewhere, and the fat goes to the liver, to the pancreas, to the muscle, to the heart, that causes problems. So many people feel that it is not the fat in itself, but the ectopic location of fat that causes dysfunction. So liver is the first hit. So when you have that, you should, even if the person doesn't have diabetes, think of diabetes, think of obesity-related issues, think of cardiac problems. And of course, I'm not saying that this is not a risk factor for hepatic decompensation. It is, but we have to look at CVD and we look at also the liver. So how do you screen? There are, of course, various factors, but you should know, and we are looking at diabetics. It's very simple because already one risk factor is there. But in population in general, if you have got fat, which is generally picked up by the ultrasound people, and one out of these following, which are simply the metabolic syndrome factors: obesity, impaired fasting glucose, hypertension, hypertriglyceridemia, and low cholesterol. So this is the MASLD. If you look at who should be screened, then all these factors are there. But look at these. You also look at people who have got elevated transaminases. Though that is not the commonest thing. You can have MASLD without elevated enzymes, and that we saw in our patients. So if you have got obesity, features of metabolic syndrome, pre-diabetes, diabetes, persistently elevated transaminases, and people who are going for bariatric surgery. There are many screening tools. Transaminases are not good. If they're elevated, they might mean. If they are not elevated, it doesn't mean that person does not have, as happened in our case. Ultrasound of the liver is done by almost all the common master health checkups. And usually the patient comes to you that you've seen everything, sir, but you didn't see this. And we use that as a focus and fulcrum to leverage advice regarding diet and exercise. So you tell anybody about diet and exercise when he has a myocardial infarction, he listens to you. If you tell him that the only way you are going to treat this is through lifestyle and drugs are still work in progress, he listens to you. And the chances that he's going to listen to you is more. So that's important. And who has challenged the role of my lifestyle in metabolic syndrome? Everybody says it's the first line, but this is an additional motivator for patients. Sorry. And then you do the MRI studies, which I will not recommend that you do. Of course, the MRI is very good, but even whether you're in Bombay or anywhere else, you have to look at the cost effectiveness. The FIB score, which I just told you how to use it, please use it for every patient. All you require is an LFT and a platelet count. Platelet count in our distance given in lakhs. So whatever the three numbers are, that 1.56, you put it 156. That comes as platelet count in 10 to the power of 9. So use this age, everybody tells nicely. Hopefully the women also do, at least when they come for the checkup. Platelet count you have OTP, you have a score. So that's the simplest thing. Elastography is the next step. And then you have got the ELF test. This is the formula that I think you just saw on the screen, and you have used this. So it is very, very simple. The elastography, I am not a ultrasound kind of a guy, but you can then stratify people into kilopascals, what is the way in which liver is having its issues, and it is quite painless. The problem is it is so infrequently used, and that it is not the cost effective thing right now, but that is the only way you can find out how stiff your liver is. So what are you going to do? There are various guidelines, but the simplest one I chose is the latest one, is that you look at the FIB score. It is less than 1.3, unlikely to have advanced liver disease. It's more than 1.3, you measure the liver stiffness. If the liver stiffness is less than 10, again it's okay. Then you come down to 10 to 15, it is possibly compensated advanced chronic liver disease, requires monitoring, and you refer to hepatologist. If it is more than 15, you assume that the patient has got chronic liver disease, consider surveillance, and here you look at these small numbers. If you have got a platelet count less than 110 or 1.1 lakhs, and your stiffness is between 15 to 20, the risk of this person having liver is 60%. Whereas if you have platelet count of 1.5 or more, that risk is not so much. But for 20 to 25, less than 150. So the stiffness accompanied by or clubbed with platelet count gives you a risk. So if your elastography score is 20 to 25, and your platelet count is less than 1.5, you have the same risk as a person who has a lower score, 15-20, but the platelet count is 1.1. And then, of course, if it's more than 25, this is definitely a significant portal hypertension. So you stratify as FIB score less than 1.5, 1.3, more than 1.3. The elastography score less than 10, nothing. 10 to 15, very mild. More than 15, up to 25, you go by the platelet count, and if it's more than 25, it is a clinically significant liver. This I thought is a very simple slide, and that tells you everything that you need to do. Of course, we are not hepatologists. The moment we find that the liver stiffness measurement is more than at least 15, we refer people, but people with lower platelet counts, we are more careful. How do you manage these people? This comes the most important. This is the only thing that works. If you lose more than 5% of weight, and I'm sure that there are lectures today on weight losing strategies, by anything that you do, you are going to decrease hepatic fat, and to decrease the hepatic fat, that means that you are decreasing the fat elsewhere in the body. Also, this is the most effective method. But as things are, we all want drugs. To tell a diabetic to do diet and exercise, and he said, but this is very, very important. And you need to do exercise, and there is no difference between aerobic and resistant exercise. This is being told by ACE group also, that we should do weight loss, and weight loss for this people. If it can be done by lifestyle, fine. Otherwise, choose drugs. Most of our patients are diabetics, which make the person lose weight. You want to choose SGLT2, you want to choose GLP, that's your choice, but do something. None of these drugs is FDA approved. You've got, we'll just discuss therapies based on whatever evidences we have, vitamin E, bio, Lyra, SEMA, tirzepatide, SGLT2 inhibitors, and some novel therapies, but none of them is FDA approved. Now, when we look at the vitamin E was superior to placebo. Pioglitazone was not superior to placebo for the primary outcome that they have in terms of hepatic improvement in hepatic histology. Secondary outcomes were there, but that's where the pioglitazone is. Pioglitazone causes precipitation of heart failure, can cause fractures, can cause weight gain in and bed cell. Therefore, it's not the preferred treatment, but there is some evidence. And then vitamin E long-term use has been known to cause increased risk of prostatitis. There has been another randomized controlled trial where it was better than placebo in achieving resolution as well as fibrosis. So there are a group of individuals who are using pioglitazone. You may use it, but you should be careful about its side effects. Liraglutide has also been used. Individuals who are using pioglitazone, you may use it, but you should be careful about its side effects. Liraglutide has also been used in higher dosages, and in a biopsy-proof study, it showed that it was well tolerated, safe, and there was histological resolution of NASH, warranting some more research into this. Semaglutide has also been used in something like a 1.5 year study, wherein they found that the primary endpoint was no worsening of fibrosis, and secondary endpoint was improvement of at least fibrosis stage and no worsening of NASH. And we look at that you did have some improvement which was incremental based on the therapy or the dose that was used compared to the placebo, and there was improvement in the secondary endpoints also. Sorry. There is an ongoing study based on this 1.5 year study, which is called the Essence study, which is going to look at the effect of this on the non-cirrhotic, non-alcoholic steroid. SGLT2 inhibitor, there has been work from our own country, which has shown that they are useful, but they are not being studied in terms of histological evaluation, and they may be considered adjuvant therapy. Now, this is not really important for us because practically, as my professor used to say, show me a patient whom you would not give SGLT2 inhibitors today. They are cheap, they are effective, and they have the many pleomorphic effects. So, you are not giving it for NASH, but it is going to benefit NASH. There is also this molecule which is available for weight loss therapies and diabetic therapies, at least in the US, the tirzepatide, which has also shown, compared to insulin, the effect on the hepatic fat. They found that there was a significant reduction in the hepatic fat content, visceral adipose tissue and abdominal subcutaneous tissue, showing that this might be also another agent which might be useful in showing a reduction in the NASH and NASH-related outcomes. Saroglitazar, a compound manufactured in our own country, has some, sorry, I don't know what happened. The data is also very fuzzy and the picture is also very fuzzy. But this is not done on purpose. This is somewhat, but there is some evidence that it does work. So when you have nothing else and you have got atherogenic diabetic dyslipidemia, I'm sure if the company people were there, they would have shot me. But at least the saroglitazar is shown very nicely over there. There is a novel, no, I'm sorry, I don't know why that particular slide got corrupted. There is a FGF21 analog, which is also known to regulate the lipid and glucose metabolism. This is also being used for treatment of NASH. And there is a trial which looks at the fibrosis improvement without worsening of NASH, and they have shown that newly diagnosed type 2 diabetics or any illness that affects the results of the trial, they should be having some limiting factors, but they did show that it led to improvement in the fibrosis compared to the placebo. So in conclusion, we keep on listening about elephants in the room. That is something which we have ignored. Previously, it was heart failure. Now it has changed to liver. This keeps changing, but this is relevant. MASLD is a new terminology, but it is not the old wine in new bottle because it tends to encompass non-hepatic related illnesses in its definition and widens the scope of screening for people with this particular disease. It tells us about detrimental impact of obesity on the body. Please and please calculate FIB score in all your patients. And because numbers are very convincing, if you tell someone that somebody says I am asymptomatic and you show him that his LDL is 150, his fasting glucose is 170, HbA1c is 9, he's more likely to get convinced for therapy or intervention or action on his part than saying that I think you have got diabetes, dyslipidemia, take some treatment. Till we have drugs that address these particular pathways, please focus on weight and lifestyle modifications. Intensify approaches, sorry for the typo, for cardiac and renal protection. Because these individuals are at risk not just for liver but also other problems. So don't just send them off to gastroenterology, say that मेरे हाथ धो लिए अब आप वहाँ जाइए. You have to treat them for the other factors. Choosing drugs that do not cause weight gain or promote weight loss is probably one step in that direction, and all of us are doing it. Do it more aggressively. So the points there are: do not ignore an ultrasound picture, calculate a FIB score, stratify patient, do elastography if it's more than 1.3, stratify less than 10, more than 25, 10, 15 to 25, look at the platelet count again and again. That tells you that something is going on with the body. Thank you very much for your patience.
Thank you, Vipin, for an excellent presentation. Are there any questions?
Thank you. I'll tell my wife.
If you were to reduce only the fat in the liver, for example, if the patient score is say grade 3 USG, and if it comes down to say 0 or grade 1 maybe, is it sufficient or do you have to reduce weight also?
Yes. I think I did not go into those pictures. I have those as to which is grade 1, which is grade 4 because I am not a sonologist. But any improvement, you will see it more, sir, in weight of the person. The patient has lost about 5% of the weight. The likelihood that his grades of hepatic fat are going to come down is definitely there.
No, sir, if you give only saraglitazone, for example, now his weight may not come down,
yes,
but the grade may come. I mean,
no. So I said the primary treatment is lifestyle modification. On top of that, you can give other drugs. You know the success and failure as a senior person of lifestyle modification.
No,
anybody.
that is a different issue, sir.
But
I agree
since we
there
do
entirely.
not have any drug, you might use some drug, and in these two, vitamin E, pioglitazone and saraglitazar are standing out. SGLT inhibitors, GLP-1 analog, they have sufficient and more indication which are increasing by day. So we can use some things, though at this moment liver biopsy criteria in long-term trials for these are not there. That's why they are conducting a trial with semaglutide.
But which is the drug which is approved by the FDA?
FDA has not approved any drug. DCGI has approved the use of saraglitazar for diabetes and also for management of
And pioglitazone?
Pioglitazone is not approved because in the study that was done, the PREVENT study, they did not find it better than even vitamin E. It had only secondary endpoint. It is something like this. No, you know, somebody came to select the boy, that is me, and say that कि चलिए DM endocrinology भी है, color भी ठीक है, इन पसंद नहीं आया. That is what is the story of pioglitazone. Secondary endpoints are met, but primary endpoint is not met. Therefore, they have done another study which shows that it might, but pioglitazone is not approved for use by FDA.
Yeah, and pioglitazone can increase the weight also.
Yes, that's what I said. Weight, fractures, macular edema, and it can, these are all relevant issues for this elderly population. Yes, sir. Weight loss has to be there.
Any more questions? Thank you so much, Bipin, for a very illuminating presentation. The next speaker is Dr. Kalyan Kumar Gangupadia, who is consultant endocrinologist at Peerless and CK Birla Hospitals in Calcutta. And he has several prizes to his credit, the Stephen Whitaker Prize, Owen Wade Prize, Endocrine Society Prize, numerous publications in international and national journals. And he's going to talk to us on optimizing LDL, ApoB, non-HDL remnant cholesterol, and HSCRP in diabetes.
major studies which showed that ApoB was a more accurate marker than non-LDL. Big studies in reputed journals. But there were a couple of studies which showed that they were equal. The majority shows that ApoB is better, couple shows it is equal. But this ApoB was picked up by the European Society of Cardiology, the only guideline which gave a lot of stress on this ApoB. So what they said is 20% of patients there might be disturbance between LDL and ApoB. So if you ask a biochemist, ask our biochemist consultant, I said, which is ApoB is better. No. ApoB is much easier to measure. It's a protein is much easier. Let me do the ApoB. It is actually not costly either. It is inexpensive and easier to measure than the LDL. And because all these levels will be the same whether in the postprandial or fasting state, you don't require the fasting levels. For triglyceride, you require fasting levels. Because when you eat, your triglyceride will go up, chylomicron will go up. So when you eat, the triglyceride will go up, chylomicron will go up, triglyceride will be high. But when you are not eating, it will go down. So this will vary, triglyceride will vary, but this will not vary. So ApoB is not affected in the postprandial state. That's the big advantage. And what is further said is analytical performances of ApoB are superior to the measurement of calculated LDL and non-HDL. Most of the labs, they don't do direct LDL, they do calculated LDL. So which is like this: total cholesterol minus HDL cholesterol minus triglyceride divided by 5 LDL calculation. That's what problems are there. It may mathematical errors may accumulate if the formula necessitates 3 separate analyses of this. And a constant cholesterol triglyceride ratio is assumed. With high triglyceride value, that level is not constant. So we are assuming a lot of things when we are giving you the picture of non-HDL biochemical. That is not everything happening. So in the European Society of Cardiology guidelines, they have put non-HDL is recommended for risk assessment. But look, they have put a bigger one with ApoB, particularly in patients with high BP level, diabetes, obesity, metabolic syndrome, or very low LDL level can be used as an alternative to LDL as well if available, and may be preferred over non-HDL in patients with high triglyceride and diabetes. So this is the first guideline actually which is posed, and the only guideline which has posed most, which has put most emphasis on ApoB. So there you see the ApoB in the SC. So very high risk should be less than 65, high 80, and moderate risk for 100. Now I've got 3 parts: CRP and the last part is CKD. Now I'll be a bit quick. So CRP, we know we all use it every day, day in, day out. It's an element of inflammation. HSCRP, that is highly sensitive CRP and CRP, they are actually the same. The equipments we need for measuring them, highly sensitive, lower values are a bit different than our reagents is a bit different than CRP. CRP is the same. The one we used to see COVID, one we used to see pneumonia, same CRP. So in CRP, there are few trials. One of these trials in patients who had undergone angiogram and LDL of less than 70. What they showed here is that if your CRP is less than 2, the relative risk is here. If your CRP was more than 2, but now has come down to less than 2, you still have a slight increase there, but it is possible. But if your CRP was less than 2, and now it is more than 2, your risk increases of MACE. And if your CRP was more than 2 and remain more than 2, the risk. This was further highlighted. So this is what they said is even though the LDL is at target, the CRP might give you a disadvantage in telling you what risk. This is a analysis of 3 randomized trials, again with MACE. A problem with CRP is if I have a cold day, go up. If I sneeze, go up. If I have a liver problem, go down. So myself, I'm really not that convinced that CRP will always be, we have to be in perfect health. And then you measure the CRP only when it is there. So I think it's the tussle between non-HDL and ApoB, to be honest. So here, there are a few comparisons. At the end, they said, when adjusted to each other, this seems to track most with ApoB. And it suggests that ApoB may be marginally more important for this than non-HDL. They are highly correlated, but will be marginally better than. And what well, fasting state is not required. Analytical it is easier, simpler, more accurate, and it is inexpensive. So that's why it happens. Now, the last bit is the changes in CKD. In CKD, the triglyceride levels are elevated, HDL is are lower. Triglyceride high, HDL is low. LDL is not that effective, but the LDL size might change. What happens to ApoB in CKD? I don't know. Don't get time to read through it, but I couldn't find anything. So with the CKD, if you see all-cause mortality in ACR, it is surprising that we consider 30 as the cutoff. So even above 10, the all-cause mortality begins to go up. Even at lower ACR, ACR is important in predicting all-cause mortality. And of course, if the eGFR goes down, the infection point down to about 60, then your cardiovascular disease goes down. So very quickly, so what does CKD do? The CKD stops, reduces the LDL lipoprotein lipid activity. The chylomicron is unable to give the free fatty acid. So if a fully laden free fatty acid chylomicron goes in the liver, gives a lot of free fatty acid. The liver makes more of VLDL. And the VLDL, this CETP enzyme, is overactivated. What happens because of that? The VLDL then takes up more cholesterol from the HDL. So these molecules have got more cholesterol. Number might not be more here, they're laden with cholesterol. And the HDL, it suffers because all these enzyme systems, so many macrophages, they cholesterol, fatty acids, which come into the HDL, takes up from the macrophages. That is also the HDL suffers, is reduced. Triglyceride is increased, and this way gets worse. But the statin trials in CKD, if you look, if this is EFR more than 16, this is hemodialysis, there are 3 big trials. Okay? So 4D and Aurora were done in patients exclusively on hemodialysis. Statin using hemodialysis. And in SHART trial, big trial, 1/3 of the patients were on hemodialysis and 2/3 were not on hemodialysis. What was the impact of statin? So the statin impact was for hemodialysis, there was no change. The statin used in hemodialysis doesn't make that much. But not on hemodialysis, non-dialysis patients, there is a clear benefit in CKD patients, including statin. Now, what about which statin to use in CKD? So this is one trial, Planet 1 trial, where they compared head-to-head atorvastatin 80 versus rosuvastatin 10 and rosuvastatin 40. So the lipid lowering is the same. The rosuvastatin 40 is compared to atorvastatin 80. Lipid lowering is the same. But what happens here is this. So if you look at the pooling ACR, with the atorvastatin, ACR is reduced, but with the rosuvastatin, both doses, it is not reduced, it is possibly more. And there is a retinol binding protein, the marker of tubular dysfunction, that goes up with the rosuvastatin. And you can see here that the eGFR with the atorvastatin, there is no change across the time, but with the rosuvastatin, the eGFR actually goes down again. That is why your nephrology friend doesn't like when you prescribe rosuvastatin. So similar LDL reduction, but not much ACR reduction, and eGFR goes down, protein or retinol binding protein goes up. And you can see that acute renal failure is much less with atorvastatin fibrates, because I told you triglycerides are based in CKD. Fibrates will help. It does reduce the triglyceride. It does have some effect on the cardiovascular events and cardiovascular death. Actually, it reduces in CKD. But the problem is the serum creatinine goes up because of the CKD. So therefore, again, the nephrologically, you don't like it. It is not that bad for the heart. Reduces it, but creatinine. But some say that the increase of creatinine with the fibrates, it does go up, but it doesn't stay up. It stays at the same level. It does not keep on going. In dialysis patients, statin has little or no effect on, I told you about the trial. So this is the guideline for lipid lowering in CKD. So really good, you say non-dialysis patients, you give statin plus insulin. Dialysis dependent CKD, previously, this is important, previously not on statin. For them, you should not eat, they will move in. Previously on statin, now patient is in dialysis, no need to stop. Because it's still happening. So I think at last, I've come to the last slide. So in summary, what would I do having gone through minutes of papers here? First, I will target LDL. Now, LDL is a target. If I really want to see whether the patient is at higher risk, I will then look at non-HDL, FOP, and CRP. CRP data is very good, but the problems are told you. Non-HDL and FOP both have got good data, but I've told you the problems, slight problems with the non-HDL. So this is my humble view of what I believe, what I could get out from these various articles. That it seems once you reach target LDL, then I think FOP is the way forward. And I'm sure in the next few years, you will see more and more emphasis on the FOP coming on in the various trials. For CKD, statin used atorvastatin. So with that, I end. Thank you. I'm sorry for the patience.
Thank you so much, Dr. Gangadhar. It was so interesting that I couldn't stop you, all right? But literally, we learned a lot. And those of us who refreshed our things on the physiology that he told us was absolutely brilliant. I'm sure there may be many questions. So let's see. Anyone? Yes, Dr. Date?
will get you quicker to the target. So why didn't you use the car without the brake? The lifespan in India in 1947 was 37 years. It is now 70. What has happened? More pollution is there, lifestyle, but yet our lifespan has increased due to the advent of advances in medicine. We cannot ignore that. The trials which are here are so huge, I don't think we can ignore it.
I think the cholesterol story is far from over. I think without further controversy, let us just proceed to the next talk speaker, which is Dr. Vishal Gupta, who's going to talk to us on SGLT2 beyond diabetes control. He is Director of VG Advantage, several national and international publications, Editor-in-Chief for textbook Beyond Type 2 Diabetes, and author of several chapters in diabetes textbooks and very active in cardiorenal metabolic research. Vishal.
Thanks, sir. Oops. My spectacles are creating issues with me, so okay, so I'm going to confuse you a little. I was hoping that this crowd was a little bigger. I'm going to first ask you a simple question as we proceed. Start karna, please. Kya karoon? Okay. Okay, great. Thank you. Okay, so where's the pointer? I've never not used one in ages. Can which one? Oh, okay, got it. Okay, so I'm going to confuse you a little. I'm going to first tell you that Indians and the Caucasians are completely different. And I think we've been getting a lot of these markers extremely wrong, and I've been trying to find out. So coming to Dr. Date, saying that we are still losing despite a battle, and the question is whether we are following the wrong guidelines, we are following the wrong people, and we should be doing something totally different. Anyways, the story here is basically on the SGLT2 axis. And I'm going to focus, I want you all to focus on the triglycerides. I'm going to make this a completely clinical version of a talk, and to see how we can translate this into our clinical practice. Now I'll just ask two people, or a little show of hands. Amongst all the SGLT2s that we have available in India right now, who would use DAPA-10? Can I just have a show of hands? So probably everyone, okay. Who would use Cana? So we have only one. I think I would raise my hand too. We have three people who raise the hand. Anyone who'd use EMPA? So basically DAPA wins, okay, right? I'm not even talking about remogliflozin and ertugliflozin. I think that doesn't even deserve mention with due respect to the companies, right? So we're going to focus on the triglyceride, and we're going to focus on the adiposity. We're going to focus on the SGLT2 and weight loss. And we're going to focus on the relationship between weight loss, the visceral adiposity, and the subcutaneous or the total body weight, right? Or the subcutaneous adiposity. That's the white fat. So let's first talk about let's focus about the adiposity and the triglycerides. Now, this is what Dr. Ganguly has already mentioned to us. This is a little pictogram from my book. So only three things. The pathophysiology between diabetes and obesity is not very different with insulin in the center. I'm going to ask you to remember only three things from this. There is an upregulation of the hepatic lipase. There is a downregulation of the lipoprotein lipase, which is in the peripheral tissue. There's an increase in the postprandial lipemia because of the insulin resistance. And there's an increase in the ApoC3. And this ApoC3 now, I don't need to go through this because we've got a wonderful explanation of how each one interacts with the other. The ApoC3 is an inhibition or is an inhibitory lipoprotein to the lipoprotein lipase. So what do we eventually get? As Dr. Ganguly explained, we have a tremendous upsurge in the postprandial lipemia. That's the chylomicrons. This is presented to the liver. I said the hepatic lipase is upregulated, which means it's going to break it down faster. We know from the endoplasmic reticulum, the microsomal transport proteins are upregulated for increased package. We have greater VLDL1, which is the larger buoyant triglyceride VLDL1. There is a gross mismatch because the amount presented to the liver and the amount that's thrown out from the liver is discrepant. You know, as this increases by 5% per cell, we start getting the disease of liver. I was using NASH till now, but NAFLDL, but I think I'm going to start using the word MA onwards for the entire spectrum of the liver disease. And I'm going to show you that why the triglyceride, even though all the large cardiovascular trials have been inconclusive, we know the phenofibrate trial has only showed when you reduce the triglycerides, you get protection to the microvascular eye disease, right? So we know that the VLDL exchanges its triglycerides through the CETP to the LDL and to the HDL, making the HDL qualitatively dysfunctional and basically making the LDL very atherogenic, as we explained, and that was the typical type A pattern. Now, a little to the visceral adiposity. The question remains is diabetes associated with a greater version of the visceral adiposity? I also want you to remember something that I'll talk in my other talk, that over 30 years, which I'll repeat myself, over 30 years from the Canadian studies, we know that if somebody had a BMI of X 30 years back, over 30 years, if the BMI was exactly the same for the same man and woman, the waist circumference increased by 1.1 centimeter for the man, but 5 centimeters for the woman. And what you've been hearing since morning, that the woman is much more a sitting duck for a lot of these issues, which I will explain to you how, why, as we move on. So the first evidence, and I thought I'll talk to you about the new target of the epicardial fat. You know, the epicardial adipose tissue is a form of visceral fat. And I don't think you can get a more stereotyped qualitative fat when if something works on that, you know that drug is doing something right. Now, this is the fat that's located between the myocardium directly and the visceral pericardium, right? So it's touching the myocardium and it's bathed by the coronary artery. So it's directly in touch with it. We know that it has endocrine and it has vasocrine functions. The normal epicardial fat in a normal person is between 1 to 4 millimeters. See what happens in a diabetic. In a diabetic who's not obese, this is about just under 6 millimeters. And as the grade of obesity increases from 1 to 4, and this is the conventional WHO score. I wish this was the Edmonton score, which would tell us something different. But the degree of obesity directly relates to the epicardial fat, and you have it going to as high as just under 14 millimeters. So a direct association between the increasing weight on the weighing scale in a diabetic with a gradual increase in the epicardial fat. And this is also associated with a generalized twofold increase in the visceral fat from the non-obese to the obese, right? Remember the Asian phenotype? I very rudely call it the lemon on the toothpick appearance, a very focused fat on the abdomen. And different studies have demonstrated that the average Indian phenotype has about 20 to about 60% more epicardial fat for the same BMI compared to a Caucasian. Telling you again that we are very different, but we are very different from the Caucasian. Now this is a 13 RCT study that confirmed that the epicardial fat is much more in a diabetic. But what this also showed that there were two factors that influenced the epicardial fat. And Dr. Date, I want you to pay attention to this a little because this answers a little of your questions. So the epicardial fat directly was responsible or was influenced by two of the cholesterol fractions. One was the total cholesterol fraction, and therefore the ApoB and the LDL and the triglycerides. And the triglyceride has been a very forgotten story, but I'm going to try to revive this triglyceride concept. So what would the take-home message be for me at this point? The take-home message is I have an epicardial fat that's far greater in a diabetic. It increases as the weight advances. The Indian diabetic has, or the diabetic today in 2024 has much more fat compared for the same BMI compared to 30 years back. Reduction of the total cholesterol and the triglyceride is a hypothesis that I'm generating. Should bring the epicardial fat down. Are we looking at the triglyceride completely wrong? Does the value of 150 that all the guidelines for the Caucasians translate to the Indian? Should we go down to the concept of as low for both the triglycerides and the total cholesterol? And again, we know that, as Dr. Ganguly has pointed out from the PCSK9 inhibitor trials, that an LDL going down as low as 16 increased or furthered risk reduction. As we also know from the simvastatin trial, that an LDL below 40 compared to below 80, there was a gradual reduction in the cardiovascular events. So with those take-home messages, I thought what I'll do is I'll do a literature search. And I'll try to divide this into drugs that commonly reduce triglycerides and total cholesterols. And then I try to see if these drugs had evidence of the epicardial fat reduction, how much percentage, and I try to see this correlation with the cholesterol and the triglyceride lowering. So what we found out was that, so what different RCTs and different meta-analyses suggested, that the two most outstanding drugs for the reduction in the epicardial fat were the GLP analogs. And the breadth of each bar would indicate its relative reductions for the triglycerides and the LDL. There was a study which I'll show you in the next talk between dulaglutide and the epicardial fat. Now, what they found was the two most outstanding reducers of epicardial fat was the PCSK9 inhibitor and was the GLP analog. And this was not only dose dependent, but it was also time dependent. So as the duration of these drugs increased, there was a time dependent reduction in the epicardial fat. This was to the tune of about 25%, both for the GLP analogs and for the PCSK9 inhibitors. The other outstanding thing was, out of all the SGLT2 inhibitors, canagliflozin stood out. We also know canagliflozin, which I'll show you a little later, increases the LDL cholesterol the maximum, anywhere between 3 to 6 milligram per deciliter, but it's also the only SGLT2 with a maximum triglyceride lowering effect. I looked at saraglitazar. We've talked a lot about saraglitazar. Professor Sethi has talked to you about saraglitazar. There was no data of the saraglitazars with the epicardial fat, so I wouldn't be able to comment on its use, but there is a lot of data on the liver. I looked at the TZD. We talked about it's not being approved for by US FDA for the liver, but there is data of pioglitazone on 15 milligrams on the epicardial fat. And this has shown again to directly relate to the triglyceride reduction anywhere from 11% to 19% of triglycerides, translating to a 9 to 11% reduction in the epicardial fat. And a very small thing, but icosapent ethyl, something that we don't use a lot. Now you know from the GELIS study and the REDUCE-IT studies, and I'm only talking about icosapent, that there was risk reduction to the heart outcomes. We know from the STRENGTH study that used icosapent with DHA, that's docosahexaenoic acid, there was no risk reduction. And then there was a study of 1800 milligrams of the use of icosapent, that's omega-3, on the epicardial fat, and they showed about an 11% reduction in the epicardial fat with this drug at a dose of 1800 milligrams, which corresponded and correlated with the triglycerides, again with a reduction of between 11 and 20%. Higher the doses, 1800 milligrams and above, translating for a greater triglyceride reduction. I told you about the PCSK9 inhibitors being the most outstanding with the GLP analogs, and the statin, again for Dr. Date's question. The statin was responsible for the reduction of the epicardial fat in a meta-analysis of about 6%, but these people were older, these people had established coronary artery disease. They studied ezetimibe with simvastatin head-to-head with atorvastatin 20, and simvastatin was 10 milligrams plus 10 milligrams of ezetimibe. they found that atorvastatin was a little better. Rosuvastatin was most effective at the epicardial fat, and when they compared pravastatin 40 milligrams with simvastatin 40 milligrams, they found no difference between the two, even though we know that simvastatin is more effective as much as 1.5 to 2-fold than pravastatin for the LDL reduction, bringing out the pleiotropic effect. And we know that statins do that through the MCP1 chemokine that's secreted from the macrophages as an indirect pleiotropic effect of the hsCRP reduction. So does this reinforce that take the LDL and the triglycerides to as low as you can? To answer Dr. Date's question on the brain anxiety and dementia, there was a very nice meta-analysis done by the ABCD and the UK group that showed that statin in the dose, and they use low to moderate intensity statin. But they found that 20 milligrams of atorvastatin and rosuvastatin, which is actually high intensity, reduced the risk of absolute dementia by 2%. That means for every 100 that you use, 2 people are going to reduce their dementia over a period of time. Now, this is a trial that you all don't frequently encounter, and I thought I'll bring this up. And this was the SUSTAIN 8 trial, which compared injectable semaglutide with canagliflozin 300. And I'll show you data that we are going to be presenting this year, and a few data that I should not be showing, but a lot of our papers that are coming out this year. Now, what this showed, this was 1 milligram of subcutaneous of semaglutide. And you know it's the gold standard when it comes down to weight loss, which we've been talking for so many years. This was a small group of people which compared canagliflozin with injectable semaglutide. And they found that 2.6 kilograms versus 3.4 kilograms in favor of semaglutide was statistically not significant over the period of time studied. The lean body mass reduction was equal in both groups. The relative lean muscle mass reduction to the body fat was in favor of greater body fat than lean muscle mass. Again, no different for both the groups, telling you how outstanding this drug is and how Johnson & Johnson hasn't been able to sell this drug very well. I wish they had a lower cost and they did justice to this molecule, because I've been an absolute fan of this drug. Now, coming down to weight loss and Cana, you know that Cana 300 produces the maximum degree of weight loss, and I've showed you head-to-head with injectable semaglutide. I've showed you it's the most lowering triglyceride drug. I've shown you it's the most reducing on the visceral adiposity, and the epicardial fat being the hallmark fat, being one of the most difficult fats to reduce with extremely high endocrine, paracrine, and vasocrine effects. Now, in this meta-analysis, it was a Japanese study that showed that canagliflozin brought the epicardial fat more than it did on the visceral fat. So there were some independent effects happening from this drug. There were independent effects happening from this drug. I want to bring to you the triglycerides. I think each one of us, when we see a triglyceride in the range of the 169, we don't really react to it. And we are constantly reminded that from international studies and from our own study that we published, and we had an oral presentation at the EST last year, if you focus on the triglycerides, they're all between the range of 159 to 169 in as many as 40% international studies. But this was the average for all our, and we studied Cana-DAPA and we studied EMPA head-to-head with 50 patients each, propensity matched for every marker that could influence the heart and the kidney. So you can see we were very effective at reducing the triglycerides by as many as 50 points, getting it all down to a certain number below a certain number. I want to show you the effects of its metabolic, which I've already mentioned to you, that canagliflozin, obviously being the most effective, would have the most LDL increasing. Now, one point as Dr. Ganguly brought out the Friedewald equation, you know that as the triglyceride starts going towards the 150, 200 mark, the LDL starts getting underrepresented and skewed. So you don't know whether that this is the effect of the indirect LDL or whether it's a drug effect. And that has that has brought some doubts in most clinicians' minds. But the same meta-analysis showed that triglycerides was the most effective at reducing triglycerides. And when people were given statins to the point of 10 milligrams on a baseline when they added canagliflozin, there was no change in the LDL, telling you obviously that drugs that are studied in single arms on certain markers versus drugs studied with background protectors, the data is extremely different. Now, I thought I'll bring this case, and this is a recent case. I had to stop canagliflozin in this lady who had about stage 2 kidney disease, 72, has got diastolic dysfunction, has concentric LVH, was subclinical NT-proBNP being in the 200s. We used therapies, brought it down to a very reasonable range under 125 for her age. We brought the urine protein down to under 30, and as Dr. Ganguly showed you, that even between 10 and 20 is relevant, and I'll give you a number. After 17.3 milligram per gram, the risk to heart failure increases 3.4% for every 3 milligram change in the urine UACR. So this is, I want you to just focus on the NT-proBNP. This is a patient who's been following up for years, about 7-8 years. And we've got all her markers down, and I was forced to, she went on a holiday, she got these recurrent fungal infections of the vagina. I was forced to stop the 300 milligrams of cana. And my fear was what would happen to the heart and the kidney. I called her back after 30 days. The NT-proBNP increased by about 50%. The UACR increased in a similar range. I was worried. I had to readjust her drugs. Her blood pressure tablets, which was originally controlled with just one valsartan, I had to give her 2 drugs. I had to add 2 more drugs for control of diabetes. I had to add finerenone. I had to add other drugs. I followed after 2 months, and the last follow-up that I had was a few weeks back. The BNP shot up to 600. Just tired is what she explained. The UACR went to 300. We had to intervene. We intervened. We got the BNP down to about, I think the last value was about 360, if I remember right. She felt better. But this was the catapulting effect, and this seems too overwhelming for me because the changes were so dramatic, but I can't ignore what's been happening with 4 follow-ups since the last 4 months in this one patient that comes to my light. So this study, I want to show you what happens in the elderly and what does this drug cana do for people. So what they found was that they focused on the BNP, they focused on the SST2. You know, the SST2 is a family of the interleukin-1. Released by the cardiomyocyte, a very good marker of fibrosis and myocardial stretch. Unfortunately influenced by a lot of inflammatory diseases, but a good prognostic marker. And what they found was when they used cana, the degree to which the BNP and the SST rose over a period of 1 to 2 years was reduced by 25% for the BNP and about 10% for the SST2, telling you that it reduces the progression of these markers. I wanted to compare the SGLT2s after what I've just told you. And I routinely get cardiologists who changes the 300 cana to 10 milligrams of DAPA. I refuse to understand this. Either I'm the idiot or the cardiologist doesn't understand the SGLT2 inhibitors. That's just how he's been trained from the heart failure studies that DAPA came out and the companies that have been extremely aggressive in marketing this drug. So I thought I'll give you the evidence. So over 4 days, cana 300 increases the glucose excretion by 25%, so which means that it's excreting more glucose and therefore more weight loss, therefore more caloric loss. Obviously, the kidney needs to have that receptor for the cana to work. But if you're going to have all these markers, you're going to definitely have more osmotic symptoms and therefore greater systolic, greater diastolic reduction, greater weight reduction. And that's what you see in this slide. So it's the most overwhelming compared to all the SGLT2s for weight, for BMI. Systolic, diastolic pressure, systolic around 4 to 5 points, diastolic about 3.5 points. A1C, the maximum. This is another meta-analysis that shows exactly the same. That's an outstanding drug. And this is a little, I want you to focus a little, and this is Indian data where we've showed head-to-head comparison of all the 3. And this was CANA 300, DAPA 10, and EMPA 25. And the CANA group was a little older. And what we found was a statistically significant difference in when we compared all the three groups to diastolic blood pressure and the ApoB, and a trend towards the HSCRP. So we wanted to see which drug is doing really better. And I'll just show you the difference between the CANA group and the DAPA group. So CANA, greater systolic reduction, greater diastolic reduction. Look at the ApoB. The ApoB was to 10 to 12 points greater, and these were people who were matched for their statin, matched for ezetimibe, matched for their blood pressures. So this drug is changing the LDL. It's changing the size of the LDL. So you have the same LDL for a lower ApoB. It's making them less atherogenic, and this is probably a class effect, as Dr. Ganguly has showed you in the slides. He showed you a slide on which was a Lancet paper of 39 RCTs that showed the statin reductions. You know from that same study, if the ApoB came down by 10 points, CAD reduced by 6% and cardiovascular death reduced by 9%. And that's huge, right? For one drug to have a class effect. And I thought I'll show this data, and this is the data we are going to be presenting soon in one of the meetings. We did a propensity score matching of SEMA with SGLT2, basic conventional dose, CANA 300 with a gliptin, and we have, and it's not different companies, these are standard companies, standard gliptins, standard manufacturers of most drugs, right? So there was not even a difference in the drugs used. And like the SUSTAIN 8, we saw the same thing. Greater BMI reduction, greater weight reduction, greater systolic reduction, greater diastolic reduction. When we look back at the data for the SEMA group, the SEMA people could not reach 14 milligrams. The men just can't reach 14 milligrams. So we had a lower dose of SEMA of 7 milligrams, but at the end of the day, it's data that's there. This is the data that shows that's there. A final thing on liver protection, we know CANA, and I'll show you this is MRI data, this is ultrasound data and CT data. And it shows to reduce liver stiffness, it shows to reduce the ballooning, it shows to reduce steatosis. Coming down to what Professor Sethi said about the weight, you know that if there's a 5.5% reduction in weight, the fat comes down. If there's a 7.5% reduction in weight, the inflammation starts reducing, and if there's a 10% and above greater reduction in weight, the fibrosis starts resolving, exemplifying the importance. And what they found in the study was, again, triglycerides and leptin was the single most two markers that influenced the results, not the BMI, not the weight, not the insulin scores, not the inflammatory markers, but it was leptin and triglycerides. Now this is our paper that these are two papers that we have just submitted to the American Diabetes Association. So we went out to look at three things. We went to look out for characteristics that might influence the liver elastogram. We compared it to the FIB scores, we compared it to the liver enzymes, we looked at the BNPs, we looked at the HSCRPs, we looked at the EGFRs calculated both by cystatin C and the creatinine. We optimized their risks over 1 year. When we did the scans, we tried to see if we could identify something. So what we found was, so I know it's a little fuzzy, but I'll tell you. I want you to focus on the BNP and the triglycerides because this is where I want you to change the outcome. So if you look at the right side, of the slide, we reduced significantly the liver enzymes, we reduced the diastolic blood pressures, we reduced the A1Cs, the weight, the BMI, the triglycerides, and the total cholesterols with the HSCRP. So you'd say we probably did a good job with these people on follow-up. What we went to see is what marker influenced the outcomes for people between F2 and F4. So we categorized them into F0, F1, and by the Metavir scales, and F2 to F4, suggesting that these are higher risks. And from Professor Sethi's talk, these are the people that even need cardiorenal assessments, right? So what we found was in the Indians, a value of 128 had a sensitivity of 53% and a specificity of 73%. So it became a very valuable screening tool, a simple triglyceride fasting. And when the triglycerides went to 191, the sensitivity reduced by 4%, but the specificity increased by about 35%. And that's again large. So our statistician told us from all the data, the 128 was a little more significant than the 191. Now, when we look to compare it with the liver enzymes and the FIB scores, we found that the liver enzymes, if they are elevated, it correlates to the severity of the F2 to F4 category, but there was no relationship seen with the liver enzymes for any category. And I'll tell you what we saw. So what we saw was 41.6% in the elevated score had normal liver enzymes. And in the people who had F0 to F1, 65% had liver enzymes that were elevated, telling you that this is something that you just can't guide, which means rule out viral disease, rule out autoimmune hepatitis, rule out, do a hemochromatosis screen, rule out other things, rule out other things that might be influencing the liver markers in a diabetic. We went and looked at the FIB scores, and the FIB scores told us exactly the same thing. There was no correlation of the FIB scores seen with any of the stages of the liver elastogram. And if you look at the data, a low risk of F13 in the category that showed fibrosis, as many as 50% suggested low risk, and only 7.7% via the FIB score suggested high risk, telling you that the Indians need to be looked at very, very differently. So we looked at the NT-proBNPs in the same study, and the focus was the BNP. And what we found was the F4 had a statistically significant raised BNP, telling you, now for the first time we're bringing out the evidence of the relationship of F4 with heart failure or diastolic heart failure. All these people were asymptomatic. Now echoes showing different things. We didn't look at the specifications of the echo, but if you look at the characteristics of the people in the F4, they were leaking their kidneys very mildly. This was because all of them were on kidney protectors and heart protectors, and we were optimizing the risk factors. But if you look at the eGFR by cystatin C, there was a trend towards a lower number. And that would make sense with the BNP. Obviously, higher numbers required for it to translate into some sort of evidence. So what do we propose? You look at the abdominal circumference, and all these people were above 90 for men and above 80 for women, which is the entire diabetic population really. Sedentariness of 1 hour per day for 1 year increases the liver fat by 1.1%. That's huge, right? Get them to move their backsides. And what we found was the duration of diabetes with the duration, so it's not just the triglycerides, but they need to be elevated beyond that value. And who would ever think a 180, 128 would be significant, but does that not make sense that we're getting these numbers wrong? And so what we propose and what we have started doing is we basically see the duration of diabetes. We see the duration the triglycerides have been 128 above. We do that fasting triglycerides. We subject them straight to the elastogram from the data that we've had, and that's how we've changed our practice since we've got this data. The drugs that we use are canagliflozin, oral semaglutide, saraglitazar, and icosap and ethyl would be the best combination for such a patient, because all these drugs reduce the epicardial fat, which is greater risk reduction for heart disease. And you know the epicardial fat is responsible to a very large extent for HFpEF, that is the preserved ejection fraction, because it works like a mechanical stimulus, right? Now coming down to my last question, and I'm done. So once again, who would use DAPA? I have nobody in the group that used DAPA, right? Who would use scanner? Right, okay. And I believed in this drug before the company believed in this drug, and I still remember Vaishali and me were bludgeoned with 5,000 emails when the DKA story came out, and I had to tell everyone that my father uses it. So you know what? Do what you want to do, but I stand by this drug, right? And I've given you a list of questions, but I think I rest my case. So Thank you for listening to me.
Thank you, Vishal. There are a few questions that have come online. I will ask you to address them. Do you see canagliflozin 300 as the replacement for GLP-1 RA or complementary?
No Nordisk is in this room. Therefore, my next year's funding will go away. So, no. That was not what I'm going to convey, because when I when my next talk is about semaglutide, you all will forget about Cana 300. So, no, they are titans. They both are titans, and it's not either or, it's either and. I wish semaglutide was at 50 rupees a tablet, and I wish Cana 300 was at 25 rupees a tablet. And I think each one in this room would use this unequivocally. I think it's only the cost that's limiting the science behind it. So I'm trying to be diplomatic, evade the question. I think it'll be answered in my next talk. But I think there are two titans right now. One a titan that the company doesn't know how to market, and the other titan the company knows how to market really well. And I think the drug is selling itself. I don't think it needs doctors to write the drug anymore. I have got patients who are giving their drug to their relatives. I have 8 relatives. 3 of them have come to me because the drug stopped working, because they don't know how to take the drug. So no 120 ml water, and this drug is selling itself. I don't think the company needs anyone in this room to write for them, because it's writing itself.
Well, the second question is, do you see SGLT2 inhibitors being a first-line therapy in type 2 diabetes?
So from the evidence, obviously epicardial fat, triglyceride reduction, visceral fat, subcutaneous fat, white fat, besides the overwhelming benefits, our practice, we start off with SGLT2, because if I again go by the risk factors, more than 7 years of duration and more than 50, remember, are 2 risk factors. I'm not even talking about anything else. There are 2 risk factors. And that's the entire population that comes and sees us.
Okay, the third question is, how do we measure SGLT1 inhibition by canagliflozin, and does this have any significance? I think you've answered that in your talk, so I don't think it makes any sense. But the good question that I would like to ask you is, do you see any of these SGLT2 inhibitors being used in the non-diabetic?
So there is a lot of data, and I think I'd pass that off to Professor Sethi, because he'd be the best position to answer that question.
You want to answer it, Bipin?
Anecdote, one patient with hypothyroidism and reduced ejection fraction came to our clinic, and because the patient didn't want to see a cardiologist, I wrote dapagliflozin. His son wrote from United States that you don't know how to practice medicine. You have given an anti-diabetic drug to my father, who has only got heart failure. Similar story happened to a patient with proteinuric kidney disease. So as is told by you, it is a drug which was usually given for people with diabetes, but now non-diabetic kidney disease, non-diabetic heart failure are also indications if they have got proteinuria for the kidney disease. This is the only drug in the arena of heart failure which is shown to prevent prevention of conversion of pre-diabetes to diabetes. So there is enough indication for this molecule, and in fact we are surprised many a time that we have patients with heart failure in thyrotoxicosis, many other things. Cardiologists don't write it, we write it, and sometimes the cardiologists keep changing the molecules not knowing that the patient is already on one. So he says, do not use this molecule, use this one, and patient ends up getting 2 molecules of the same name, with different names, the same molecules. There is indication for non-diabetic people, provided there is proteinuria, and you can use up to GFR of 20 if you are using empagliflozin. The studies with all SGLT inhibitors have been done in the background of ACE inhibitors and ARBs. The only exemption is empagliflozin, which had a small number of people who did not have ARB in the background, could not tolerate it. So you can use EMPA up to GFR of 20, and also in people who may not be able to tolerate ARB in the background.
You need to say that there is so much difference between the class of SGLT2 inhibitors. Would you say that?
All subtle differences. There are differences. And the canagliflozin is supposed to also inhibit the SGLT1. Therefore, the first rise of glucose after breakfast, that is when it is given, is blunted with this particular molecule. But you are right, if cost, as he considered, is the factor, give some. Don't say that because the patient cannot afford the most effective molecule for triglyceride, I will not use any. So his suggestion was that if you are using one, you might as well give 300 milligrams. But that does not mean that if you cannot use this, don't use 10 milligrams. The idea is give SGLT inhibitor to old people. And my professor used to say, show me a patient who doesn't require statins. And he gave an answer, a patient who is on hemodialysis and who has never been on treatment, do not give that treatment. Show me a patient who does not require SGLT inhibitor, the one who gets recurrent vaginitis, as his patient has. For men at least, we can remove that part of skin. And our student has written an article, protect organs, not tissues. Because many people are sensitive about removing that particular skin. So he said, go ahead, have a circumcision done and use the medicine which is going to protect your heart and kidney. What is that skin doing for you? So, I mean, this is very provocative, but what I'm saying is some people cannot tolerate it. Those people you do not give, otherwise you must. A little bit, the genitourinary mycosis is reduced.
Thank you, Vipin. We'll move on to the next talk. Dr. Thakkar here. Dear Thakkar. Vipin. Okay. Are you going to do this tailoring diabetes therapy? All right, come. Okay, so I'm going to ask you to push your talk into as soon as you can, as little time as you can. We're running very short of time. Okay. Thank you, please. There are our attachments and our current positions and publications and special awards, and we are waiting to listen to you on your talk, Priya.
Well, good morning, everybody. As been advised, I'm going to keep it short, sweet, quick, maybe a little practical as well. We're going to talk about today tailoring diabetes therapy, role of degludec and its co-formulation. Well, like most of us know, when we start off a patient on insulin, this is going to be an association for life. With that patient, through thick and thin, better than a husband or wife, well, this is going to be continuing with you all throughout. So what we're looking for is a perfect match. Call it a match made in heaven, well-suited, well-tailored, absolutely customized. So for that, let's talk about first our patient over here, Ajit. He's a 50-year-old engineer, a very pleasant man who's had diabetes for the last 11 years. He comes to you with this high A1C of 8.8, a fasting and PP of 188 and 218. He's obese, of course. His BMI is at 27. His sugars have been constantly high, blood pressure reasonably controlled on his current BP medications, LDL cholesterol, etc., high, like you can see, a GFR putting him in a stage 3 kidney failure, CKD stage 3, and of course, he's got microalbuminuria as well. So drinking is social, exercise, as usual, like most of our patients, is irregular. So for this patient, if we were to consider what his medications are, besides the usual antihypertensive, the statins, etc., his current diabetes medications are excellent, I would say. He's on a metformin, 2 grams daily. Could be split, but sure. Empagliflozin, so he's on an SGLT2 inhibitor, and he's on a GLP-1 RA liraglutide at a 1.8 milligrams daily. So everybody, I think, would agree that he's on a fairly good regimen as far as his medications go, yeah? Everybody okay with that? Yeah. So now, however, his A1C is still high. What are our current challenges? His sugars are super high. Of course, as usual, like every single patient who comes to our OPDs, insulin is a big no-no. He says, my life is hectic, my sugars will fall, how do I adjust it into my daily routine? I travel so much, how do I take it at a fixed time? So everybody has this list of issues that they come with when you want to talk about that insulin word. So what next in this patient? What would we be doing in our practices? So this patient, metformin, SGLT2, on a liraglutide, all at max doses. Just asking everybody here, what would you be doing in your regular practice? very, very practically speaking. I know what I would be doing again, but tell me what would you all be doing in practice? Anybody wants to volunteer? Sulfonylurea, sure. Anybody else? What would you be doing in your practices? Well, like everybody is saying over here, of course, people do not want insulin. Tablets, of course, fast, easy, convenient, both for the doctor and the patient. So in terms of using multiple OADs, well, it's driven by convenience, acceptance, limited consultation time. But what we are aware of is that OADs, when added in succession, do not give the same benefit at every single point of time. So for example, if I have a patient who's on one OAD, add on a second, well, you're going to get a 1% fall in A1C. You add on a third OAD over here, that fall in A1C is going to be halved. You add on a fourth OAD, and that is going to be half of the previous again. So at every point of time, the advantage you're getting by OAD upon OAD is going to be successively reducing. The only medication that can really change this whole profile is insulin, and we all know that. Well, in terms of insulin, we know that this is one of the most celebrated, powerful molecules that we have available with us in our pharmacopoeia. Saved millions and millions of lives. So I always say that if this is a tool that if we know how to use wisely and well, it is a great weapon that can work to adjust sugars in any given patient. So what insulin? So that becomes the next question. What insulin would we prefer for this kind of patient? So let's say over here, his A1C was 8.8, fasting over here was 188, a PP sugar of 218. So again, does anybody have any opinions about which insulin they want to consider for Ajit over here, who travels a lot, hectic, scared, the usual story? Anybody any suggestions of what insulin y'all would like to consider in this kind of patient? Basal. Well, everybody knows who's sponsoring this lecture, all right. However, I think it is a great choice, there's no doubt. As per the ADA 24 guidelines also as well, reiterate behavioral modification. Every time, all the time, spend those few minutes talking to the patient about his diet, about his exercise. You never know when it hits home. The patient will make change, and at the end of the day, when the insulin word comes home, well, they're all rushing to stop all those chickies and mithais and etc. Well, however, if this is the time that insulin is required, if it is time for injectable therapy, well, even as by the ADA, the GLP-1 RAs or the GIP-GLP-1, the dual agonists also would be next in line. However, if this patient number one, the patient is already on liraglutide, no doubt. And so if the patient is already on liraglutide, on a GLP-1 RA or a dual, and if this is not appropriate, insulin is preferred, all of these things are expensive, no doubt. Well, in that kind of scenario, the first insulin of choice, the simplest insulin of choice, the most convenient insulin of choice is starting out with the basal insulin. Well, I always feel basal insulin is convenient also. Why? The patients are very, very scared of that prick. They don't know what that entails, that pen. All of these patients have this impression that having to carry around this, maybe those old-fashioned ideas about the bottle and the syringe and the needle. Many people don't even know about the availability of this most convenient tool right now. And at the end of the day, they're very scared of that prick. But once they are introduced to a once daily insulin, taken into, after meals, into the night, end of the day, don't need to carry it around. So easy, change your needle, change your site, the prick is not painful, then basal insulin turns out to be the best introduction insulin, which in fact improves compliance as time goes on. In this patient, however, let's look at why basal insulin would be the right choice again, besides all of these others. So this was a suggestion given by Dr. Kalra, who basically said that if the postprandial glucose excursion is more than 74, so let's say the patient slept at a sugar of 200, he woke up at a sugar of 126, a 74 difference. Well, if it is more than that, then what this patient needs is a bolus insulin primarily in order to control his PP sugars. In this kind of situation, well, you might consider a rapid-acting insulin to take care of those PP spikes. The other choice is a premix 50-50 because you have a greater amount of bolus insulin. If the patient has, however, this difference at less than 40, well, patient sleeping at 200, waking up at a 160, let's say, well, then a basal insulin will do the trick. The next choice is, again, a 30/70 premixed insulin. So this would be maybe just a guidance in order to understand which insulin might be a fair insulin to start out for. Now, which generation insulin? First generation, second generation, what is going to be the insulin of choice in this kind of scenario? So no doubt, when in the past we had the intermediate acting NPH insulin, when we got glargine U100, that changed the management of diabetes completely. Here we finally had a basal insulin given once daily, so easy, lesser hypoglycemia. It just eased out diabetes management, and no wonder it became what was known as the gold standard in terms of basal insulins. But as time goes on, well, when we have good, we want better. When we have better, we want best. So as a result of which, with the first generations, as better things got available, we realized that the first generation analogs, where all could it be made better? Well, this was not truly once daily. Everybody is aware, detamine, 22 hours, glargine, maybe 24 hours. So there's often a failure of control of the fasting well enough. A higher variability, a fixed time dosing, because it has that 24 time period, you can't afford to play around too very much. I will at the most tell my patients that if you're taking it, let's say between 9 and 10 p.m. on a daily basis, try to stick to that time, otherwise you're going to lose control. This is not truly peakless as compared to the second generation, and when there is a peak, well, a peak of that insulin action is always going to be associated very often with a hypoglycemia. So this was not truly peakless, which resulted in a higher rate of nocturnal hypos. Then comes the question of how to initiate insulin degludec. So let's really, really simplify this. Well, this number one, in patients who are insulin naive, a very simple way of thinking about it is, number one, you can give it alone, or you can give it in combination with other orals, with GLP-1 RAs, or with bolus insulin as well, no problem. A simple starting dose, 10 units. Now, of course, this is a general guideline. We might be changing that around. Let's say I have a patient who has, we're a little more fragile, older, we're a little more afraid of hypos ourselves for that matter. You could go a little lower, or a very obese patient, you could start higher who has very high fastings. Well, but a simple way of looking at it for a new patient, for doctors who are not so familiar maybe, is a once daily starting dose of 10 units. And ultimately, subsequent individual dosage adjustments. Insulin is incomplete if you've initiated it, it's half the battle won, but if you've not titrated it to its requirement, well, you don't want the patient coming back and saying, doc, my orals were working, you took me off this, you started a basal, my sugars are no good. Well, insulin is not going to work if you don't adjust it. I tell my patients, you know what? I eat 2 rotis, you eat 3 rotis, everyone's requirement is different. So till you get the insulin to the right dose, you cannot say that it has not worked. Another important factor is if you're switching from, let's say, an older basal to a new basal like degludec, if it's an OD or a BID basal insulin dose, or the basal component of a basal bolus regimen or a premixed regimen, it's a unit-to-unit switch. Remember that if you're using glargine versus a degludec, a 20% dose reduction is to be considered when switching from a BID insulin or a glargine U300. Let's look at the evidence then very briefly of degludec versus glargine U300. Both of them are the second generation basal analogs that we have. Well, at the end of the day, what are we looking for with the basal insulin? We're looking for better, very simply put, better control. We want a tighter A1C, but we want lesser hypos. And that's the beauty of these insulins. Control is tighter, sugars are coming down, but I don't have hypos. And insulin degludec, well, showed that it had a significantly lower risk of hypoglycemia. This was lower, 30% lower of hypos with degludec versus glargine U300. And the proportion of patients also experiencing more than one episode of hypos significantly lower with degludec as compared to U300. Let's look at some of the profiles of these insulins. Well, degludec, onset of action 0.5 to 1 hour versus a glargine U300 is 2 to 6 hours. The duration, again, so over here, what was important over here, I used to always wonder, especially when it first came in, for my hospitalized patients, do I want to start out with an insulin like degludec if I'm looking for basal control, a fasting control for my patients who are in hospital? Does this long-acting insulin work fast enough? Does it start working immediately? So like seeing over here, 0.5 to 1.5 hours. So the start of action is fast, and the duration of action 42 hours as compared to glargine U300, onset being 2 to 6, duration being 30 to 36 hours. Where does this duration really kind of manifest? Is, well, from the flexibility point of view. So for patients on degludec, I have a fantastic window of 8 to 40 hours. So today, let's say my patient comes home at night, forgets about taking his degludec. No problem, can take it the next morning and then again take his degludec back on this usual routine. As compared to that with the glargine U300, it gives me a window of flexibility of plus or minus 3 hours, and that is where the beauty of degludec really shows up. In terms of variability, this has become a very important parameter today, where we know that glucose variability is behind the scenes contributing to those complications of diabetes. So with regards to degludec compared to a U300, like you're seeing over here, well, it's maintained in a very stable level as compared to U300, which shows this U-shaped dip over here. At the end of the day, therefore, variability decreases with the use of degludec as compared to U300. That was within day variability. If you look again at day-to-day variability also as well, degludec maintaining a very stable profile as compared to glargine, which the levels go up and then come down, and this again can show up from a clinical standpoint as well. Potency-wise, this is another important factor. Well, glargine U300 has a 30% lower potency versus degludec, so these are some of the big advantages that this stands. In conclusion, well, degludec might be the perfect partner. Why? It's flat, it's peakless. When it's peakless, it minimizes hypos. The longer duration of action, going into 42 hours, gives our patients so much more room to not get stuck with that insulin. If today I forget my pen, all of these things happen. People forget it, people might be out, might go for a day out and not remember. All of that put together, the longer duration of action allows for our patients to have such incredible flexibility and the minimal variability as well, which is the one that's contributing to the complications. Let's look at Amit. Well, he's the brother of Ajit, the little older brother, 53 years old and a businessman. He's had diabetes now for 7 years, and his A1C is worse than his brother's. 9.2 with a fasting and PP of 206 to 88. He's also obese at a BMI of 25 like his brother, and his main issues is the hypoglycemia. His blood pressure fair, cholesterol again high, and in terms of his management, other than the usual antihypertensives and statins, this patient is on metformin again. He is on a sulfonylurea at 2 milligrams once a day, must be a glimepiride, of course, and a dapagliflozin of 10 milligrams once a day. Now, again, for him, his issue is what? He has highs and he has lows. So he is incredibly afraid to start out with insulin again over here, because he feels that, his eating pattern is erratic. He travels a lot like his brother, so it becomes very hard to fit this into his daily regime. So what next in this patient? Again, this is a little repetition over here. Well, over here, basically, we have an excursion which is somewhere between 40 to 74. And at the end of the day, the important thing over here is understanding that the fasting and PP are equally important when it comes to maintaining good glycemic control. A lot of our patients, when they come into our clinics, what do? I tell them, have you been checking your sugars? Yes, doc. What are you checking? And they'll show me a daily fasting sugar that has been checked. Rest of the day, absolutely nothing. A1Cs sitting at 8.59%. Where is the sugar going high? Patient saying, doc, where am I going wrong? My fastings are fantastic. Why are you increasing my doses? Well, your PPs are high. So important to understand that you have to explain to your patients that the fasting and PPs both are very important, and you're never going to get complete control till you start monitoring that and addressing that as well. So over here, let's look at the use of premix over here. We have a variety of insulins, again, the old human regular insulins, as well as the analog premixes. Let's look at where this stands, what stands better. What is the real difference? Well, with the analogs, well, absorption far faster. Number two, it reaches its peak concentration, therefore is higher. At the end of the day, the glucose control, the glucose lowering effect is more rapid, more pronounced. Duration of action remains similar. And very, very importantly, one big difference that matters to you as the physician and to the patient as well is that hypoglycemia rates are lower. So this is the value truly of insulin analogs in type 2 diabetes management: better glucose control, lower hypoglycemia. So over here, for this kind of patient who's got highs and lows, you can address both things simultaneously. Let's look at IDEG ASP versus IGLAR. So we're talking about a basal insulin alongside with a basal bolus IDEG ASP. What does the evidence say? So 4 aspects as usual that we need to consider. Efficacy, 1, safety, 2, the quality of life, very important for our patients, and flexibility. Of course, we want to make life easy for our patients so that they stick to their insulins. In terms of glycemic parameters, well, if you look at IDEG ASP versus insulin glargine U100 and U300, well, the fasting plasma glucoses, since your basal is addressing fasting, so you're going to see it's virtually similar. IGLAR U100, 32 versus IDEG ASP, 34, so not a big difference over there. The PP sugar is obviously going to make a big change because in the IDEG ASP, you have the aspart, you have a bolus insulin that's added in. And as a result of which, the PP sugars showing a big improvement with the IDEG ASP of a 28 as compared to the PP control with the basal insulin alone. And this translates therefore into an A1C improvement 15% as compared to the A1C obtained with IGLAR 100 or U300. This is again, that was about the glycemic efficacy. If we look at the hypoglycemia risk, which again holds great importance, the risk of overall confirmed hypoglycemia, there was no risk, no excess risk, because again, the word always is the moment you add a bolus insulin, your risk of hypos is going to go up. But in this particular meta-analysis, like we're seeing, there's no significant difference in the overall confirmed hypoglycemia with once daily IDEG ASP versus a once daily basal. Nocturnal confirmed hypoglycemia, again, this is something that our patients are always worried about, significantly lower in the once daily IDEG ASP compared to a once daily basal. Very important is the diabetes therapy related quality of life. So this was a study that was done when patients were switched over from glargine U100 or 300 to an IDEG ASP. Patients actually had a better quality of life, and that was reflected in their scores. In terms of the numbers, patients with diabetes, 78.8% said that they were willing to continue treatment with IDEG ASP. 74% said that they preferred IDEG ASP over previous therapy with the glargine. Again, in terms of the flexibility, with IGLAR U100, 10 units once a day, any time of the day. You can use it any time because it does have a 24-hour profile, but stick to the same time. With IGLAR U300, well, initiate with 0.2 units per kg. Your time interval of flexibility is plus or minus 3 hours over here. With IDEG ASP, well, you start again with 10 units, again, keeping it simple, 10 units once a day with any major meal of the day, because it'll give you those 2 advantages. It'll take care of the post-meal glucose excursion, while at the same time take care of the fasting and the basal needs as well. So 10 units once daily. This is IDEG ASP again. Basically talk to the patient about which is his most carb-heavy meal in the day. And if I had to give it twice daily, I will choose the 2 most carb-heavy meals in the day. It doesn't matter whether you're using this before breakfast and lunch or before lunch and dinner. It doesn't matter about the proximity between those 2. You use it between the 2. And again, the 2 doses don't have to be identical. You can use different doses depending on the requirement. So this is what we talk about the main meal concept. You basically, if you're using it once a day, you find the most carb-rich meal. So over here, for example, this is dinner containing 100 grams. So this is where you can target your once a day IDEG ASP taken prior to this meal. However, if I need 2 meals covered, I can basically take it with my lunch and with my dinner, 2 separate doses, because this has a lesser amount of carb. I can use a lesser amount here, a greater amount here as well, and that's how I can continue using it, the same insulin used for intensification. Now, when and how do I intensify OD to BD? Well, if I have these PP rises after 2 meals. So if my 1 meal is addressed and I find I've given it before dinner, my post-meal dinner sugar is great. But my post-lunches are still sitting super high. What do I do in that kind of scenario? Well, you can use it prior to the lunchtime as well. So if the patient kind of adjusts his diet taken care of, sugars, PP still high after lunch, do that. Or if the once a day dose is sitting at a high amount, 30 to 40 units a day, you can split this up into 2. And again, the daily dose can be split over 2 meals with the greatest carb content. Remember that since the IDEC ASP has a 70% of a basal, degludec in itself, you have to make sure that the fastings don't go too low either when adding on to it twice a day. The good part about IDEC ASP is its safety in special situations like the elderly, patients with renal or hepatic impairment, and during religious fasts itself. It's approved for patients with type 1 diabetes also. And in summary, therefore, IDEC ASP a great choice for insulin initiation, again, backed by evidence, time-tested, evidence-based, the key attributes of this being efficacy, safety, quality of life, and flexibility. Thank you very much. I'm happy to take questions.
Thank you, Pia, for that excellent presentation. We are running a little short of time. Are there one quick question if anyone wants to ask? Right, no one? Good.
So yes, everybody looking forward.
Professor Sethi is part of the trial. He will actually give us
That sounds great.
So Professor Sethi is part of the IDEC trial.
Excellent.
For both type 2 and type 1, I think he'd be the best to answer this question.
See, we had it done in type 1s, and in type 1s it was more of a negative study. It is not going to be used in type 1. My other colleagues in Apollo Hospital use in type 2. That's good, once a week injection. But what about that patient who misses that once a week injection? So compliance is an issue. And when you start, as Madam said, 10 units, patients say, 10 units? My neighbor is taking 4, and here you tell them you start with 70 units. And then he says, 70? So this is a problem, but it is a very good thing to have. And I think sooner or later we will have this, though the company's focus now is going into GLPs and all that. ICODEC is something. For type 2, it is definitely a good thing. Type 1, issues remain.
Vipin, you are the next speaker on PCOS, so please proceed with your presentation. Thank you.
Is the issue of PCOD, which is about 6 to 10% of populations that we see in across the country. Yes. So there have been something new happening in this area. So we thought that we should look at the Endocrine Society guidelines for this. We'll again start with 3 cases. This is a 16-year-old girl who is coming because she is having irregular periods and facial hirsutism. She attained menarche at 12 years and has not had a single regular menstrual cycle. Initially, they felt it is a usual perimenarcheal problem, and later on also it persisted. Does this confirm the diagnosis of PCOD? Irregular periods and facial hair. How many people say yes? Yes. But for the others, do you want to do any other tests? Because there are only two hands, and I had to raise mine. And of course, Vishal. Yes, USG abdomen. Somebody wants to do serum insulin? Yes. Please don't. Ultrasound abdomen not needed if you have got 2 criteria fulfilled. If this patient did not have regular menses, what would you do? She has only facial hirsutism, or she has only irregular menses, no facial hirsutism. What will you do? No. We'll see what we can label her. You don't have to do any more tests, but we'll still label her. Okay. Now this is the patient who is married 4 years, detected to have PCOS. We will not go into how she was detected, because when people come to you, they say that, what is your problem? PCOD. And then they stare at you as though you are an idiot. She has been advised letrozole, and she went through the net, and this drug is used for breast cancer. So she said the doctor was very busy. When Dr. Vishal saw me, he was at the fag end of the clinic. He saw me at 12 midnight. So maybe he was sleeping. So do you think that I should choose a drug that is used for breast cancer? Anyway, she doesn't want to use this drug. Is there anything else that we can give her? Or shall we send her to our infertility colleagues for IVF? This is question number 2. So you have any suggestions? Metformin, yes. Alone, maybe. What else? What about good old clomiphene citrate? It is good, old, doesn't matter. It is good, with or without that is good. We don't have to send it directly, though letrozole is the treatment of choice now. This person has again hirsutism, menstrual irregularity, diagnosed PCOS, has impaired glucose tolerance and dyslipidemia. But her concern is not GTT, not dyslipidemia. She is worried about hirsutism. So what is a better option, metformin or OC pills for hirsutism? For the dyslipidemia, we have drugs which we have discussed. For GTT, we will be anyway giving her metformin. Well, will metformin alone help her reduce the hirsutism? Or will you give her OCPs? So I think both. So we will see that this audience is answered questions well. In Vishal, it's good that people came in. Otherwise, you have to raise hand or Dr. Gangopatya, and we just discuss among ourselves. So this is last year's recommendation for PCOD, and we'll quickly go through this. What is new? Old criteria. If you have 2 of the following, clinical or biochemical hyperandrogenism, menstrual irregularities, or PCOS morphology and ultrasound, but or AMH levels. Now this AMH is in the story is becoming curiosier and curiosier. They are saying you can use it, but we can't tell you which level is recommended for cutoff. It's like saying that elevated glucose is diagnosis of diabetes, but I can't tell you the cutoff. But it is now there as a new addition. So in special scenarios like this girl that we had, if she did not have one of the abnormalities, you say increased risk or at risk for PCOD. Because you cannot and you should not do ultrasound in these people. And reassessment is advised about 8 years post-menarche. And that girl, it will be at age of 20 years. That doesn't mean that in a 21-year-old girl you cannot do ultrasound if she had a menarche at 11, but do not do it till there has been at least 8 years after the. This is something which is very, very new, and I think we should do it, because what happens is, though people don't listen to us, they already come to us with an LH, insulin, ultrasound report, and finally you ask them, what did you get it done for? They don't even know why it was done. It was just a part of the PCOD workup. In menopause, can you have this diagnosis? It is, if the patient, sometimes what happens is, they have some facial hair which they say that my aunt had, my mother had, everybody had it, so we didn't bother about it. Menstrual irregularities beyond the reproductive period, they don't bother whether they menstruate or they don't. In fact, many people feel very unhappy when we start them on treatment at 35 for premature and feel that I want to get rid of these periods and you are again starting them. So this is what the problem is. But in case you have some clinical or biochemical features, they can persist beyond reproductive age, and it should be considered if there is a past diagnosis or history of amenorrhea, oligomenorrhea with hyperandrogenism or PCOS during reproductive years. It can be there even in menopause, and many people for the first time start getting little concerned about the hair, and of course you shouldn't jump and think of only ovarian cancers, which can be there, or ovarian hypertrichosis. It could be that she had PCOD which she did not look at. So hyperandrogenism is hirsutism, acne, female pattern hair loss, and you have various scoring systems. We will not go into that. Mostly the Federman-Galloway score with more than 4 to 6, but it depends on a person. If the woman is worried about 2 strands of hair on her chin and on her upper lip, it is important. It may not be really coming as a clinically significant Ferriman-Garrow score. Hyperandrogenism, biochemically, you can use free testosterone or total testosterone. If both are normal, then only you do androstenedione or DHEAS. And if somebody is on oral pills, many people say, you diagnosed me PCOD, everything has disappeared in ultrasound. That is because everything has been set by the OC pills. You should reevaluate only after stopping a minimum period of 3 months, because most of these women will say, I stopped the pills, I had 1 cycle, and then second cycle came out 45 days, then I'm amenorrhea again. Now this is the definition of the oligomenorrhea. That is, if you are post-menarche, this should be less than 21 days or more than 45 days. More than 3 years menarche, almost same, but it comes to as 35 days or less than 8 cycles per year. 1 year post-menarche is 1 cycle in 30 days. This is something which we need to know, that is age-related. Mostly it is menarche-related. And if you have ovulation with serum progesterone level, it probably means that there is ovulatory PCOD. Ultrasound parameters, of course, are there, but the problem is now with more and more sensitive ultrasounds, you have to go by the follicular number per ovary or follicular number per section and ovarian volume. This is a problem for people who have not, some people who are unmarried. The transvaginal ultrasound is not really easy to perform, and it should not be done. Otherwise, it's a very, very sensitive method. And if you have got the follicular number per ovary more than 20, or transabdominal ultrasound can be done. And if there is follicular number per section more than 10 in one ovary or ovarian volume more than 10, then you can say that there is PCOD. But invariably what happens when you see a report, PCOS morphology seen. So you do not know what is it. But this is how it should be defined. And they say that it should not be used till somebody has had 8 years post-menarche. It may be that if you have got age-specific PCOM criteria later, it could be different. AMH level, they say, could be used. Either or is not required in women with ovulatory dysfunction or hyperandrogenism. Just like your ultrasound, you don't have to ultrasound if you already have a history person with oligomenorrhea and you have ruled out hypothyroidism, Cushing's, congenital hyperplasia, and hyperandrogenism. All those criteria are still valid. Then again, they say that you should look at the person's age. In people with higher BMI, unfortunately, the levels are lower, which might actually put kind of a doubt in your mind as to whether the patient really is PCOD or not PCOD. And if the person has had OC pills or has had ovarian surgery, that might interfere with this. But these cutoffs are work in progress. But it is important that across the world, it's easier to get a blood sample than a trained sonologist for diagnosis. So what is the algorithm? You have irregular cycles plus hyperandrogenism, exclude other causes that we have said earlier, and you diagnose. No need to do anything else. If you have got no clinical hyperandrogenism, you look for blood tests and then confirm whether there is hyperandrogenism. And if it's only irregular cycles or hyperandrogenism, then you should go for ultrasound. Otherwise, it is not indicated A, if you have diagnosed by clinical criteria, or if you have got a person who is 8 years under the menarche. Management, what is different now? Previously, it was only about symptomatic management. This is about holistic management. And it is not just about the fertility issues, it is non-fertility issues, cardiometabolic malignancy risk, psychosocial health, and lifestyle measures. Lifestyle measures, basically they say do not stigmatize these girls because the incidence of psychological disturbances and even suicides is more. So they say you take permission of the patient whether we can measure the weight and then talk to them using words that you are having some weight issue. So it is it is quite different from the talk that I gave for the metabolic dysfunction associated liver disease, wherein you are supposed to say weight, weight, and weight. Here, because people are younger and more vulnerable, you should not use the words of weight. And you should have dietary intervention, exercise intervention. And again, this is the kind of activities that we do, which is standard for anybody who wants to lose weight. And this is ask permission, tell people that you have a higher weight, and you should have a weighing machine which can also look at people who are heavier. You shouldn't have that small machine on which this obese woman cannot even stand. So sometimes you have to have a bigger machine and offer treatment which are weight inclusive, and of course tell people in the family also not to comment badly, because many times the mother comes and she keeps on commenting saying that this girl doesn't do anything. I keep telling her, it doesn't move, and of course most of the girls don't move these days because mother is cooking, getting the food. It's enough if they get some good marks or get some good salary. Then this is another thing. This is a quality of life issue. Look at depression and anxiety. Be very, very calm, quiet, and do not be judgmental in assessing them, because as most obese people are, they keep trying and they have failed. They have come for some kind of an advice from you, not some kind of a judgment or stigmatization. Then cardiometabolic risk. This is important, that at least get lipid profile, at least get, instead of getting insulin or LH-FSH, get fasting plasma glucose or HbA1c owned and lipid profile. Look for obstetric sleep apnea and then try to also give them reasons why they require regular shedding of endometrium to prevent hyperplasia or cancer. CVD risk, of course, this is important, and they said that you should consider inclusion of this, and I think the American Heart Association already says PCOS is a risk enhancer for atherosclerotic cardiovascular disease. If somebody has got PCOS, rheumatoid arthritis, psoriasis, the person automatically goes into high-intensity statin therapy. So I think that already is there, but still it's important to consider. Impaired glucose tolerance, I think I don't have to tell this audience what they need to do. It should be done. And reassessment is important even if the person has got a normal glucose tolerance by whichever measure that you have seen. Obstetric sleep apnea, this is something, another elephant in the room, which we have not been assessing, and we need to assess for this. And of course, talk to people that it is not about messiness, it is about endometrial health when we are giving you therapies for regularizing your menstruation. Because women are very happy if they don't have periods. But we have to be told that it is a disease and we need to treat this. Non-fertility issues, again, start with cycle regularization, weight management, and hyperandrogenism. But you cannot manage hyperandrogenism in a woman who is planning for pregnancy, because therapies that you give for that either are oral contraceptives or anti-androgens, both of which, at least the first one will ensure there is no pregnancy, the second one can interfere with the masculinization of the fetus. Combined oral pills, as most of you said, are the recommendations for the reproductive age group, and also they can be given even to people who are at risk and who do not have a clear diagnosis of PCOS. Given the safety of this, be careful with standard precautions. Look at dyslipidemia, look for migraine and past history of deep vein thrombosis or cerebral venous thrombosis. There is nothing about any specific progestin, estrogens. You can use anything, and also there is no point in giving more than 30 milligrams of ethinyl estradiol. Metformin alone, as somebody said, can be considered for overweight people. It could be considered at risk or with clear diagnosis for regularization of period, but this is not so good for regularization of periods as it is for the dysmetabolism. It may be considered in underweight PCOS also. Again, the evidence is very limited. Start with a small dose, and there is no parameter to look at. You can go by the numbers that we give for diabetic patients. if you give this together, then obviously it is useful for people who are overweight, who are having diabetes mellitus, who have got pre-diabetes, but it is of little benefit in patients who have got BMI less than 30. Anti-androgen therapy could be considered in combination, not as first-line treatment. If somebody has got no response for it, these girls want a response in 5 days, 6 days. I have a wedding to attend. You don't realize my problems. But we tell them that the hair growth has a cycle of growth, static period, and shedding off. The anagen, telogen phase. And for a therapy to show effect is minimum 3 to 6 months. So if they have some urgent needs, they can go for local treatment. But otherwise, you combine with OCPs. And if OCPs are contraindicated for whatever reasons that I mentioned, some people really don't want, they have a stigma. The mother says that you want to give this girl contraception, you are encouraging her. So these are questions which have been asked by our patients. So you can give this, but tell these people that if you are in the reproductive age group, you must stop this treatment when you are planning pregnancy. Spironolactone can be given, sapropterin acetate, there is no point in giving dose more than 10 milligrams. Finasteride can be used, but it has a liver toxicity, and these flutamide and other things are not even to be used. Mechanical therapies, once the person is on stable dose and says that there is no further hair growth, the hair growth has become lighter, the rate of growth is less, there is no new hair on any other parts of the body, but she is worried about whatever hair is remaining, they can go for a treatment at this point of time. And if the person is having this therapy, you should give this therapy before giving laser, because it looks nice. No person with hirsutism should be offered this as a first line of treatment unless she is getting married tomorrow. Anyway, the laser also won't cure her in 1 day. Right? Then we have this. This is the minoxidil thing. I think under pressure from industry, they said that it could be considered based on individual preferences. You let me know what is the science in this. Could be considered on individual preferences, no criteria. Limited harm, they didn't say that very good. Potential for improvement metabolic measures, limited clinical benefit for ovulation, which means that the minoxidil people have given enough money to the writers of this particular guideline, not to exclude it. Just mention, you know that story, no? About a person who used to drink wine, he was a womanizer who had done frauds, and his brothers went to the priest saying that in the sermon tomorrow, please say that he was a good person. So you know what he did? He said he was a womanizer. He used to drink. He had committed frauds, but compared to his brothers, he was a good man. So this is the minoxidil story. Anti-obesity measures, as has been said, you could consider, now in this, they have not yet looked for evidences with what I call them as second generation or third generation incretins, tirzepatide or retatrutide. But they say that you could be considered, metabolic surgery could also be considered. Infertility is important. For the first time, they have started with letrozole. If it does not, they say that you could consider clomiphene citrate alone, clomiphene or metformin, or gonadotropins. And if ovulation is detected, fine. Otherwise, go for gonadotropins and then go for IVF. Do not miss this step of letrozole. Very cheap treatment, very easy. Second day to fifth day, you give it and you forget it before sending these people to this. Of course, weight management, pre-diabetes, everything is. There is no point letting these people conceive when they're actually having diabetes. Metformin in pregnancy, not shown to improve gestational diabetes, late miscarriage, hypertension, preeclampsia, macrosomia. There is no role of this. Could be considered in some circumstances, but even the ADA now says if it has been used, you should stop it by 3 months. I don't know why. I feel it can be stopped even before that because there is increased incidence of obesity among children born to women with this. Side effects of metformin are mild, and they should be counseled that it might have long-term offspring effect in terms of obesity, though the causality is not certain. So why, see, in the first trimester, if you want to give him iron, the gynecologist say no. And they want to give metformin. Safely crossing the placenta, going to the baby, effects not known. Now this girl, all of you said, no 4 tests are required for her, but if she has only one of these, you call her increased risk for PCOD or at risk for PCOD. Second patient, you could give CC, clomiphene citrate with or without metformin. And third patient, metformin for metabolic effect, but OCPL should not be denied. So in short, why we chose this topic? We know least about common disorders. And PCOD is a common disorder. Its incidence in certain population is equal to that of type 2 diabetes. We need to know about this. The criteria keep changing. And now we have at least one more parameter which we might use at least in people who are lean. For now, you may consider AMH for diagnosis. Adolescents should not have an ultrasound done till 8 years of menarche. Hirsutism and menstrual dysfunction should be managed with OCPs. Ovulation induction, letrozole, first choice. Later on, more than clomiphene citrate and gonadotropins. Metformin only for metabolic disorders. Rolomyostol is upgraded, not yet anointed. Monitor for CV risk and avoid stigmatization. Thank you very much.
Thank you, Bipin, for that excellent presentation. Are there any questions?
Sir, PCOS confirmed presence can be screened for hypothyroidism?
Yes, by definition, you should rule out all the secondary causes like hyperprolactinemia, CAH, Cushing's, and even people with acromegaly can have this problem. So I know that if somebody's TSH is 5.7, that is not the cause of her PCOD, and if somebody's TSH is 100, you will be able to diagnose clinically. But as per rule, you should have a TSH prolactin done in this people.
Sir,
Yes,
sir, what is the incidence of NASH in these people?
I don't think it's systematically looked at, but the incidence is quite high.
And then will your treatment change?
No, I don't think the treatment will change because A, lifestyle modifications are common in both these disorders. Weight management can be done by therapies which reduce weight in both these conditions. Only thing is you might not use certain drugs for management of the diabetes in these people, and that we have already discussed.
So the metformin used in pregnancy and the outcome, can you just elaborate on that?
I think there was one study which showed that there is a decreased risk of abortions. And that study has been repeatedly quoted, but there is no such proof. And therefore, all the guidelines say that if for any reason it was chosen, you should stop it after 3 months. In our clinic, we stop it right from the diagnosis of pregnancy, or we tell people not to conceive while on metformin.
Thank you, Vipin. Thank you for the excellent presentation. The next speaker is Dr. Srirang Godbole. He's online, all right. So Dr. Godbole is going to talk to us on why do all weight-losing therapies perform suboptimally. The diabetic will be interested to listen. He's from Pune and he's online. Can we start him now?
And all across the country, thank you for giving this opportunity to take part in this hybrid meeting. There are 2 questions I sort of plan to answer. Why do all weight-losing therapies perform suboptimally in patients with diabetes? And the second question is, what evidence we have for weight loss in people with diabetes with weight loss therapies? So we can move forward with the slides. Now there are a number of mechanisms which try to explain why people with diabetes do not respond so well to non-diabetic peers. And there are several reasons, and I will just name a few of them. One is, of course, the role of energy conservation. That when anti-obesity medications are given and when they reduce the glucose levels, naturally glucosuria is going to reduce, glucose is going to be retained in the body, and therefore there is no sort of energy loss, or rather there is energy conservation. So you are bound to hit a sort of a plateau when you start treating an uncontrolled patient with type 2 diabetes with weight loss medication. The second thing is the role of hyperinsulinemia, and it has been thought that all organs do not exhibit insulin resistance uniformly in the natural course of the disease. So, for example, in early onset diabetes, there could be insulin resistance at the level of the muscle or the skeletal
Interesting topic. The impact of oral semaglutide on cardiovascular risk factors.
I couldn't hear the question. If the question was asked, I couldn't hear it.
Sorry, we're not taking any questions. Thank you so much, Dr. Kothuri, for being with us.
Okay. Oh, come back. Okay, so I'm back for. Let me work this out. Okay, so now the difficult part of this talk was that there is really no data on oral semaglutide except the 6, the Pioneer 6 and the Sustain 6 that people keep talking about, right? So I'm going to project some of my own data, and I'm going to see how we can translate that into what I think should be right. So before I start, I want to expose you all to 2 concepts. I think it's a continuum from the last talk that I gave you on the epicardial fat. And I want to talk to you about the coronary plaque and the atherosclerotic plaque as seen post-mortem. Because once we get an understanding of that plaque and its relationship to atherosclerotic coronary artery disease and its relation to the epicardial fat, then we will see the evidence behind this drug oral semaglutide on weight. We will see I'll try to bring forth 3 aspects on every aspect of the heart to see how it helps the markers of atherosclerosis and inflammation, to see what it does to markers of fibrosis and myocardial function per se, and the fear of these GLP analogs causing arrhythmias and maybe tachycardic syndromes, and to see whether it's good or bad and whether there is a benefit of this class of drugs. So because there's no real data, I was asked to talk on risk factor reduction. I'll try to incorporate that as we go and extrapolate data as we go, okay? So, I want to, so first thing, what do we know about these plaques from post-mortem samples in diabetics? We know that the commonest 3 parts of how these plaques, they rupture. So we know that plaque rupture is the most common. We know that that's seen in 65% people, and that's most common in men. We know that there are erosions, plaque erosions. That's the second most pathologically common pathology seen, which is seen in women. And the third is the calcified eruptive lesions seen as many as 5%. Now, I told you about the men, right? They experience more plaque ruptures, women experience more erosions. We know that the HbA1c is an independent factor for coronary disease, contributing to nearly 11 to 16% for every increase in the A1C. We know that the necrotic core is greater, the matrix is greater, the lipid content of the core is greater. We know that there is more thrombosis. And something that I want you to concentrate on the last bit is for the people who get sudden death. What they found was the number of healed lesions in these people are greater than 3 lesions throughout the coronary artery tree, telling you that sudden death is more a coronary artery disease phenomena than an arrhythmogenic phenomena. Now, coming back to the epicardial fact, we got exposed to the fact that this is a visceral fat. We know it has endocrine and vasocrine functions. We know that it's in direct contact with the myocardium and the coronary arteries. You know that way back in 2001, right? One of the driving mechanisms of the coronaries, if you remember, was the vasa vasorum and the adventitia, and the upregulation of the RAS system, where the angiotensin II receptor upgrade and the downgrade of the MAS receptors was greatly incriminated. We know that because of the direct contact of We know that because of the direct contact to the coronary arteries, there's increased coronary vascular death. We know there's increased atrial fibrillation. We know because of the direct contact with the myocardium, it acts as a mechanical and a pro-inflammatory pathology towards the right ventricle more than the left, and contributes to heart failure, preserved ejection fraction. We know that there's an altered secretion of the adipokines, greater inflammatory response. It's directly related to coronary artery disease progression. It's directly related to the coronary artery disease plaque instability, and as I told you, HFpEF. I'll try to take it really simply. So I'll just talk to you about one of these cytokines or adipokines. As we know, so we know adiponectin and we know leptin, right? So one of the very simplest theories is that in health, this epicardial fat, when there's no obesity, no blood pressure, no diabetes, this is basically a type of brown fat. So you know browning, increased mitochondria, very, very active, correct? Lots of uncoupled proteins. We know uncoupled proteins are 1, 2, and 3. We know PGC1 alpha is the predominant driver to this mitochondrial function. We know that this particularly browning is responsible for increased fatty acid oxidation. It prevents the accumulation of fat in the cardiomyocyte, and we know that there is a constant entry and an exit in terms of metabolism of the fat. Now, in diabetes, what happens is that this entire process gets skewed. It's a very complicated process, but I'm trying to make it as simple as I can. This eventually leads to reduced fatty acid oxidation and therefore accumulation of the fat in that region, which accounts for the greater percentage of fat that we saw in diabetics and increasing obesity. Now, as this increases, it interferes with the AMP kinase and the PI3 secondary insulin secreting messengers, and therefore there's no GLUT4, and if there's no GLUT4, there is no utilization of glucose. So then the entire heart becomes very fatty acid dependent. And what that does is, for that to happen, there are going to be increased fatty acid binding proteins, and because there's going to be increased proteins, it goes through toll-like receptors to upregulate the entire inflammatory process. So coming down to, so I've tried to set up this base and try to divide this outline into, do we have real world evidence for weight loss with this drug? So we just presented this paper at Glasgow at the British Endocrine Society around the 14th of November. And what was this paper? We had about 69 patients, very well controlled and optimized for their thyroid. We had a little protocol. So we have a protocol that we follow. We have so patients coming to us with a TSH above 4.2 more than 2 weeks apart, irrespective of their antibody status, we start them on T3 replacement therapy. We add T4 to optimize the TSH to the lower limit of normal. And the purpose of using oral semaglutide in these people were cardiovascular risk factor optimization. And I'll show you what risk factors we use. So these people were on the heavier side, and they had far greater inflammatory markers of the CRP and the highly sensitive C-reactive protein. So what was the eventual result from this paper? We got about 5 kilograms of weight loss reduction. We got about a 10% weight loss, 10% reduction in the total cholesterol and the LDL cholesterol. We got a similar amount in the triglycerides. We got a reduction in the HSCRP and the BMI. And what you'd agree with me is that what we are doing is we are controlling risk factors, right? The weight, the BMI, the blood pressures, the inflammatory markers. This is the total cholesterols and the LDL cholesterol, and we heard how important the LDL cholesterol is. So this was a single-arm study. Now this is the paper we are just submitting to the Thyroid Journal. So this is a propensity score matched 52 to 52. Again, the purpose of using oral semaglutide was cardiovascular risk factor reduction. We used the same protocol. So we looked to see different things. We looked to see if the TSH baseline and at the end of 6 months contribute to the weight loss. We looked to see if the TSH was related, if the LDL and the total cholesterols relate to the TSH criteria. We divided the TSH into 0 to 0.3 to 0.9 and quartiles of 1 point to divide them into 4 categories to see relationships. This was the protocol as I discussed to you, and I want you to pay attention to the left corner. So these were relatively young people, right? So these were in their mid-50s, very well matched both groups. We had predominantly females, as you would expect, because this was a thyroid paper. The weights were very, very well matched, and I want you to pay attention to the HSCRP. So in the semaglutide, you look at the HSCRP nearly 2 to 3 times, if not 4 times, the values seen in the control group. And this was the group that had optimized. So on T3, T4, these two had T3, T4, same doses both sides, and we used semaglutide. Now the semaglutide protocol, we asked them to self-titrate their drugs based on, we didn't follow the company's guidelines of 1 month, 1 month, and 1 month. We told them to self-titrate. As you know, the women tolerate this drug far better than the men, and they're able to upgrade them very fast. So in our practice, 3 and 7 milligrams is usually very easily done on their own. They move to 14 milligrams. We educate them. Every time they transfer their doses, we tell them to take an antiemetic for 3 days and a prokinetic for about 3 to 5 days. And that helps them tide over. We give them written instructions that if they have a problem, we teach them how to downgrade the drugs, and then after 5 days to upgrade them back again based on their symptoms. So what we found over 60% of these people achieved more than 5% weight loss. We found more than 20 or as much as 20% achieved more than 10% weight loss. We had about 8% that achieved between 15 and 22% weight loss. And look at the risk factors. We found reduction in weight by as much as 5 kilos, the total cholesterol and the LDL cholesterol. So you'd agree that these people are these people are controlling their risk factors. What we also found that in the people who dropped more than 10%, there was a positive correlation with there was a negative correlation with the TSH. So if the TSH was below 1, these people dropped more weight in the 10% plus category. Now what I want you to do is, I wanted to see if this translated again into, so these were again another small group of people on on semaglutide in type 2 diabetes. Not oral semaglutide, but semaglutide. They used injectable semaglutide. And similar results were seen. So about a 6 kilogram weight loss, a 2 BMI weight loss, a systolic and a diastolic reduction between 3 and 4 millimeters, a reduction in the total cholesterol and the LDL cholesterol. So we got risk factor reduction. And what they went out to do is they went out to see if there was any relationship to the type of food. So savory foods, salty foods, fatty foods, carbohydrate foods. And what is marked in what is the predominant fraction showing is that the fatty foods is something that they had an aversion to. And this is what we counsel all our patients, right? So taking 2 steps forwards, there was this, I think the Korean groups, there was a Korean group that added fat in the breakfast, and what they found was by adding fat at the breakfast, the effect of Rybelsus or effect of oral semaglutide increased by 39%. So obviously fat leaves the stomach the least. This is something that slows the stomach down. Anything that's really fatty, you find that they don't tolerate it. They don't tolerate the burgers well, the medu vadas well, and the bhajiyas definitely well. And the men, I think, because they indulge in all these foods 3 to 5 times more than the ladies, we have these issues more with the men. So again, coming down to risk factor reduction, right? Weight and BMI, we've shown very constructively that it does it. I told you about the waist circumference differences in the last talk, about 5 centimeters in women for the same BMI and 1.1 centimeter for the men. So I'm interested in knowing whether this drug actually brings down visceral fat, right? Because it's a great, over 30 years we've had much more fat and much lesser mass. So what do we learn from the SUSTAIN 6? That the average fat reduction was 14%, the visceral fat was 12%. There was a reduction in lean mass by about 3 to 4 kilograms, but relative to the fat, it did not make that much difference because the fat reduced far more than the muscle mass. So we know that there is reduction in both the subcutaneous fat and the visceral fat, and I told you through the last paper that it was the most outstanding in the reduction of the epicardial fat by as much as 25%. That was dose dependent and duration dependent. We know that there's reduction of the total cholesterol LDL, we know that there's a reduction in blood pressures, and we know that there's a reduction in the inflammatory markers, and we know that again from the STEP trials that there was a 43% reduction in the C-reactive protein. So effects on the oral semaglutide. Over and above, this was a study that looked at the epicardial fat when compared to dulaglutide, and what they found was that, again, the same things. They found that along with dulaglutide, and you know dulaglutide is not that much of a weight loser, right? With the 1.5 milligrams, the data is about 1.5 to 1.9 kilograms in a meta-analysis. So these were effects of the drug outside weight loss, which helped the visceral fat. And you know that this class of drugs does things at an anti-inflammatory level, for which I will show you a slide. So coming back to the previous slide, again, this drug, semaglutide, dose dependent, about 25% reduction in epicardial fat, and its effect keeps augmenting as the duration keeps prolonging. So it's not a one-time thing that stops after 3 months. So what were the effects on markers of atherosclerosis? I found this lovely paper on inflammatory response in patients who were subjected to angioplasty and pericardiotomy, and they took samples to see what the tissues, what type of inflammatory cells they were dealing with. So this was a paper that looked at the BNP, looked at the, this was a group that had 38% had coronary artery disease, about 30% had an EF between 40 and 50%. You know, there's a mid-range category in that 50 that stays undefined. So very, very diverse group of risk factors. 91% of these people had baseline SGLT2 inhibitors, and about 91% had baseline statins. So they were quite well controlled. And what they found was, again, I told you about the total fat, the visceral fat reduction. So what they found was, the BNP reduced by about 25%. And this is a message to carry, right? You know the story about the BNP. So in somebody whose BMI is above 27, you know that the scavengers in the subcutaneous tissue of the fat, they increase by 50% to 100%. So they scavenge the BNP. So which means that if you have a BNP of, let's say, 100, in somebody who's got a BMI above 27, you can safely say that the BNP is 50 to 100% more than what you see. So what this paper showed, that they dropped 14% of total fat mass, and with that the BNP reduced by 25%, which, so you lost fat, the BNP should have gone up, and it came down by 25%, telling you that there's something that this is doing with the pathophysiology of the whole process. The inflammatory markers came down, the monocytes dropped by about 50%. There was a reduction of the fatty acid binding protein 4 by about 21%. And there was an increase in the CD88, and you know the CD88 is done nothing but the complementary 5A receptor. So if you're going to increase the receptors, you're going to stabilize these inflammatory cells and not allow them to do what they're doing. I found this paper, another paper on subclinical atherosclerosis. So this was not a big group, a small group that they looked at. They looked at the carotid intima media thickness, and they looked at the risk factors. So again, very similar results to what we saw. So they got a reduction in BMI, in total cholesterol, in the LDL cholesterol, in the triglycerides, and they found a 10% reduction in the carotid intima media thickness over a period as short as 6 months, 4 months, sorry. We went to look at the STEP heart failure. We went to look at the STEP heart failure preserved trial, and I've already showed you that the NT-proBNP improved by about 25%, along with weight reduction, which obviously would translate to a higher value. What they found was that the 6-minute walk test improved from a 2.1 meters to about 21.5 meters over and above biochemical markers that improved. So there was a serious improvement in the quality of life, and the C-reactive protein reduced by about 43.5%. The last thing I thought we'll talk about sudden death and arrhythmia. We know in diabetics the sudden death is atherosclerotic coronary disease. But I thought we'll talk about arrhythmias. So this was a big meta-analysis that looked at all the papers. And what they found was that oral semaglutide in particular had a 57% reduction in arrhythmias, tachyarrhythmias, and they found a hazard that tended to the negative for dulaglutide. Not albiglutide, sorry. I thought I'll bring up the effects of semaglutide on NASH because in our paper, as I showed you, we presented that stage 4 fibrosis is associated with an elevated BNP. And you know that this drug reduces ballooning, reduces fibrosis, reduces ballooning, reduces steatosis, improves the liver enzymes. I think the jury is out for about fibrosis. But I think if you can achieve more than 10% of weight loss with this class of drugs, you're going to get the weight loss benefit on fibrosis. So if I was to conclude, there is real world evidence of great weight loss with the oral drug. There is evidence of reduction in visceral fat. There's evidence of reduction in body weight, BMI, epicardial fat. Is particularly non-arrhythmogenic. I wouldn't go out and say protective. Right now I'd say it's non-arrhythmogenic. It reduces the inflammatory response. It modulates the entire tissue towards health. And I truly call this class of drugs the Brahmastras of today's therapies. I'm a complete fan of this class of drugs. I don't use them alone. I always combine them with an SGLT2 inhibitor to get the responses that I need to. Thank you.
Thank you, Vishal, for that excellent presentation. There are a few questions online for you. The first one is, how is oral semaglutide effective in heart failure patients?
So again, to answer, so oral semaglutide, I don't think there is any data that is there on oral semaglutide and heart failure. The only data we have is on liraglutide, both in low ejection fraction, where they showed improvement in BNP, if I remember right, by about 30 to 40 points, but that did not translate into an improvement of any parameters. There is no data right now on the echocardiographic features, but I think that, am I right, the descent or the ascent study is on way that is showing echocardiographic. I think there is a study that they are conducting on the echo and the heart. I think that will come into play in 2027. I'm not sure, but maybe the company will tell us.
The second question is, where do you place semaglutide in the management of the CV continuum? I think that question is more or less answered by you in your talk. You know, the way, I don't know whether you want to answer that because the basis of your talk was how it helps the heart itself in several ways, which you have shown very effectively. So, I don't know, I think that's answered if you listen to the talk. Whoever asked the question. That's a brief question. Now let someone else have a chance because we're running short of time. Anyone else? If there's no one else, Date gets a chance. Okay, Date, you're lucky, your chance, you're on.
Sir, one question and one comment. The question is, parental semaglutides prevent heart attacks and strokes much better.
Sorry, what did you say?
Parental semaglutide prevents heart attacks and strokes much better.
Yes, so...
but not the oral one.
So you know what? There's no head-to-head comparison, right?
No,
we need a good planned study to do it. So we don't extrapolate data from Sustain 6 and the Pioneer 6 to make comments like this, because they were never designed for stroke and for heart disease, and they were never designed for a primary endpoint. They are doing their work. So what I showed you was a reduction in the carotid intima media thickness. Would you agree that a reduction of 10% would translate into stroke reduction?
No, as compared to parent.
I'm asking you.
No,
you have asked for, when a person gets to prevent stroke, what do you do in your clinical practice? You ask for a carotid intermedia thickness, right? So if you're going to improve markers of atherosclerosis and endothelial function, by theory, it would benefit. We need an outcome trial, and we don't have an outcome trial. I'm sure they will provide one for us.
So do you actually support the funding of drug trials and maybe conferences by non-pharma companies under corporate social responsibility rather than
You
pharma.
find me 10 people, I'll next meeting.
Non-medical question. Not of any importance here, please. Thank you, Dr.
find me 10
Date.
people, we'll
Yes,
do the
come on,
next
gentlemen, you have to
conference.
what?
In case of hypothyroidism, you thyroxine, and if you want to start oral sema to reduce the weight and to reduce cardiac risk factor,
You have
how
to
give this both medicines together?
So I'll tell you, it's not an easy question to answer. Okay, you know that two things you have to be careful about is oral anticoagulation therapies, and you have to be careful about thyroid, because the exposure of these drugs are increased by about 33%. So you're going to get increased exposure of the drug, but we often see both. We see that there is inadequate absorption and there is increased absorption, and we find so what we do is when we start a dose, we've optimized the TSH to low limit of normal. We see the TSH, we see their response, we titrate that to their daytime energy, to their nighttime lack of sleep, and we dose adjust them and we tell them what to do as the weight starts coming down. So we start down titrating it with the weight loss. So if they get lost to follow up, a lot of people are doing well, they feel great, they don't want to come back.
Not to monitor on TSH?
Sorry?
Not to monitor on TSH?
Of course, but that follow-up will happen. They're not going to come to you after 2 weeks, right? So we use our clinical skills and we see their starting point, and then we decide that if this is what they're going to lose weight, we don't do it, or then we plan accordingly.
Thank you, Vishal. Now, to continue with the story of semaglutide is Dr. Ganguly once again, and he's going to address the weight of diabetes with oral semaglutide, killing two birds with one stone.
Thank you, Chairperson, sir. So my heartfelt thanks to the Chairperson, sir. You gave me 5 minutes extra for my previous one, so I'm going to compensate for that to try and be quicker in this. This is not as difficult as the last one, but I still have the hangover from the lipid one, you see. So as I said, VLDL has got 70% triglyceride, rest are cholesterol, and my talk is 70% company slide, 30% is mine. So here I will tell you which are my slides. So any problem there, it's my fault. So I'll give you some additional data, some questions when people lose weight. Some people say I feel fine, and some people say I feel a bit weak. Muscles are becoming weaker. So what is that? So I'll tell you. So this is the financial disclosure. So burden of weight, this I'll be going quickly because you have seen it a number of times, and I don't need to enlighten this August gathering. So 88% of patients who have diabetes are overweight, and our diabetes control is poor in India. So type 2 diabetes itself can cause a lot of pathologies here. Obesity itself can produce a lot of inflammation, systemic inflammation. Both of them together leads to cardiovascular disease and death. So you've got the unholy trinity of these three drugs, three moieties together. So 88% of patients with diabetes have got overweight or obesity, and more than 80% of people with coronary artery disease are living with overweight and obesity. So this summarizes the that bit. So more the weight, you have got more increase in diabetes-related health costs. Now, weight loss, I think, so if you lose weight, and as our previous speakers have said, that you set into process a lot of things which disrupts the unhealthy metabolism, improves the glycemic control, and therefore you get reduction in micro and macrovascular complications. So weight reduction, I think, as was said here, I'm sorry it's not very clear. So moment you begin to have more than 5% weight loss, you get reduction in HbA1c, reduction in sugar, in greater weight loss, greater reduction. So in look ahead trial, If you have more than 10% weight loss, you have a 21% lower risk of composite outcome of 3-point MACE or admission to hospital for angina. So weight loss helps, we all know that. And in the look ahead, now this is the important bit, that because I tell my patients, even if you lose 1 gram of weight, that will help. Lose something. So 5% of weight loss, you can see the systolic blood pressure. This is not well appreciated by many patients, that you do drop your blood pressure as well. Many patients come to the clinic, I said, I walked to your clinic, and that's why my blood pressure is up. Okay, wait for a bit, 10 minutes, till it is up. So walking, regular exercise does drop your blood pressure as well, proven. So blood pressure drop, as your weight goes down, your blood pressure also goes down. Somebody asked me while I was having tea and coffee, what impact does exercise have on the lipids profile? So triglyceride, clear benefit of weight loss. HDL, there is a benefit, but LDL, that seems to be quite stagnant. So don't get that much benefit that what you would want to with just weight loss. In exercise, HDL will go up, but LDL, diet, triglyceride will come down, but LDL doesn't have that much of an impact. So more than 5% of your body weight, if you lose, you get a 48% reduction of your CV risk factors. So 5 to 10%, and that is enough to prevent diabetes, have an impact, as Dr. Sethi has highlighted nicely, impact on the NFLD, dyslipidemia, everything else. The higher you lose weight, you get more benefit. But something is better than nothing. Now, we know of this, and I'm sure you have all attended semaglutide conferences. So we know that the snack, which is the first time that an oral peptide helps in absorption of oral peptide. So it prevents the breakdown by the gastric enzymes and allows absorption of the semaglutide. Now, the other bit is a little bit about the clinical trials. So you've got Pioneer program, huge, a number of, and comparing with lots of other agents. What I found lacking was there's no pioglitazone comparison or addition of pioglitazone compared to others, or addition of SGLT2 and GLP-1 comparing with others. You've got a head-to-head of oral semaglutide versus empagliflozin. Why not have oral semaglutide versus canagliflozin? I don't know. Is there any data of semaglutide versus canagliflozin? Yes, there is, but that is with subcut. The subcut semaglutide versus Cana 300, I think the sema weight loss wise, it wins. But is there any data with oral sema and Cana 300? No. The only one you will get is the Pioneer 2, where it compares with empagliflozin. There is a clear added benefit of HbA1c reduction, although I must say I'm a little bit surprised the weight loss wasn't as much as I would expect when you compare oral sema with empagliflozin. I expected more with oral semaglutide. So the superior HbA1c reduction, as you can see here, just a point, it's about 0.5% better with as compared to empagliflozin. And overall, with placebo, and that's the drug. So a drug compared with placebo tells us the actual benefit effect, the HbA1c lowering ability. So placebo, you get about 1.5% reduction. No one drug will cause this much reduction in HbA1c. The best you'll get is 1%, apart from insulin, of course. So 1.5% as compared to placebo. And that's the important bit, because you are killing many birds with just one stone, 1.5. That is equivalent to 2 anti-diabetic drugs. And as far as weight loss is concerned, the maximum is, I think, in the trials, the mean is 5 kilograms. There are always outliers. Many people lose 15, 20 kilograms. Some don't lose. So what proportion? Roughly around 80 to 85% will lose some amount of weight, and 10 to 15%, there will always be outliers who don't lose any weight. And now I'm coming to the important bit, which I feel is very important. So fat mass over lean body mass. So you can see here, the fat mass is reduced, but the lean mass isn't reduced. Now the thing is, you see, I'm sure you have got patients on metformin, especially the ones who are not that overweight or in the normal BMI. They come back and say, my wife is grumbling, my relatives are saying, you have lost weight, you look a bit haggard. My next question is, are you weak in muscles? No, muscles are okay, I'm okay, but I'm losing weight. So lean body mass, you see, you have to be careful. So this slide will say, okay, the fat mass is reduced, lean body. What is lean body mass? Lean body mass is your total body weight minus your fat mass. But that includes your bones, your skin, your tendons. Somebody with thick skin, pun not intended, say, or some people might say, my bones are a bit heavy, that's why I'm overweight. You don't take that into account when you say lean body mass. So better term would be skeletal mass index. So suppose there's an Ethiopian marathon runner, very skinny fellow, 40 kilograms of weight. If you compare my right thigh will be more than his entire body muscle mass. Does that mean he's sarcopenic? No, of course not. We have to look at indices. So skeletal muscle index, what does it do? Skeletal muscle divided by height square. That gives you a better idea of the skeletal muscle mass. So the question is, I always will ask, don't tell me lean body mass. Tell me the skeletal mass index or skeletal mass percentage. That is skeletal mass divided by body weight percentage. That is important to me. Otherwise, lean body mass, it might mean a lot of other things. So now these slides are mine. So this is an important and interesting area which is gaining importance. There is something called intermuscular adipose tissue in between the muscles. Okay? So suppose somebody is appearing to be muscular, but actually there's a lot of fat inside the muscles. So is this important? I'll tell you. So this is from a young person, BMI normal. So this is a muscle. So here you can see, if in between the muscles, the intermuscular adipose tissue is not that high. But look at the older person with obesity. Here, lot of intermuscular body fat is there in between the muscles. Is this important? Is this relevant? Okay. Now see why the problem occurs. So the fat in between the muscles is just as bad as the visceral muscles, visceral fat. The fat in between the muscles, they have the same inflammation, they liberate same cytokines, inflammatory things, bad things. What does it do? It locally damages the muscle and you get muscle loss. But because it is local, that effect, the cytokines, the inflammatory material doesn't spill over into the blood. So you cannot measure it in the blood. The blood is fine, muscles are getting sarcopenic. Why? So that one of the reasons for sarcopenic obesity, obesity with less muscle, is this. And we fail to notice this, and that's an important area. So I tried to find out, is there any data at all that we are reducing this? But again, the total content actually of the intermuscular fat and the visceral adipose tissue, we always talk about visceral adipose tissue bad, it is bad. But actually, the total content is same. But we ignore that completely. We just concentrate on the visceral adipose tissue. And the lipolytic rate is similar to the visceral adipose tissue. And this is 3 times more than the subcutaneous adipose tissue. And it changes the local muscle micro environment by increasing the interstitial fatty mass concentration. And as I said before, that without altering systemic fatty acid concentration, you will not be able to detect it in the periphery because it is doing the damage and then it's disappearing. We are not able to find out. So this is a busy slide, but you see I'll just go there and show it. So if you see, these are in pigs, but there are in humans as well. So this is subcutaneous adipose tissue, visceral adipose tissue, and intermuscular. Now look at this column. If you see inflammatory cytokines, chemokines, significantly higher secretion than both subcutaneous and visceral adipose tissue, significantly higher than both. So intermuscular fat, I feel, is quite important and often ignored. Now if you see, the skeletal muscle death. I'm building up this story. I'll tell you why I've done it. And I think Novo, if there is anybody from the medical team, should get more data for us to educate us. So skeletal muscle death, sarcopenic obesity. Why is there skeletal muscle death? So the other fats, they liberate a lot of bad things that impacts on the muscle, that is there. But the lipid deposition around the muscles and inside the muscles, that reduces GLUT4 translocation. So the glucose uptake suffers. Now, the GLP-1 receptor agonists actually can improve this, reduce GLUT4. I tried to dig out, is there any data of SGLT2? I could not get any data from SGLT2. It says that SGLT2 also reduces GLUT4 in the adipocytes. Muscles, I don't know. I could not get any data. But GLP-1, it does reduce. Remember, GLP-1 is an anti-inflammatory agent. It reduces the inflammation. So intramuscular fat, inflammation, that the GLP-1 will work. SGLT2 will not work in the as an anti-inflammatory agent there. The other thing is amino acids and insulin. That is required for muscle growth. So therefore, patients on insulin, whatever data I could dig out, it seems that the insulin does improve the muscle mass. Because in conjunction with the amino acids, it will increase the muscle mass. So consequently, reduction of insulin will reduce your muscle mass. Okay? So therefore, again, I think the SGLT2 story comes here, that it reduces insulin. So theoretically, at least, that should have a detrimental impact on the muscle mass. Now, when we say he is sarcopenic, this lean chap, one of my friends, Dr. Animan Mujumdar, very skinny fellow. And we were climbing a very uphill task. After about 3 minutes, I said, wait. And he was climbing a skinny fellow. Is he sarcopenic? No. How do you define sarcopenia? So you have to look at a few things. Muscle mass, where you can measure by DEXA, and you know those meters that we get. Muscle strength and muscle function. Sarcopenia doesn't mean muscle mass. It should be at least 2 of these 3. So how do you measure muscle strength? You measure upper limb by hand grip. You have a dynamometer, the hand grip strength. And you have got another device where you can measure the muscle mass of your lower limbs. And muscle function is gait speed. So sitting up, standing up and walking a particular distance, what speed? Time up and go test. How many times we can stand up in 5 seconds? All these things are there. So I feel that if you really want to say a person is sarcopenic, he should have at least 2 of these 3, not just muscle mass. Muscle strength has to be there in the. So I think, I'm sure you have encountered patients on SGLT2, certainly I have, that some of them, they say that, yes, I have lost weight, but I'm feeling a bit weak. So probably this is working there. And I make it a point, or increasingly so, that ask them to do some resistance exercise. If I have time, I will show you in 1 minute how you can do resistance exercise, upper limb, abdomen and lower limb. Simple test, simple things. Now, so I tried to dig up data of GLP-1 on this intramuscular fat, data of GLP-1 on the muscle strength and function. So this is there are a few papers which suggests that you get reduction of your muscle wasting, basically anti-inflammatory, again targeting those intramuscular adipose tissue. This is normal mice. This is high-fat diet mice. And this is high-fat diet plus semaglutide. So look at the size of the high-fat plus semaglutide. It is less than the high-fat diet. But I want to know what's happening with the intermuscular fat. You'll get a lot of data with visceral fat. Yeah? So here, so the normal one, very little fat in between the muscles. High-fat group, more fat in the muscles. But when you give semaglutide, that seems to improve. This I find at least quite interesting. And therefore, again, think, and I'm thinking as well, that patients I've given the GLP-1 receptor agonists, nobody has complained of weakness, GI symptoms they complain. Weakness, muscle weakness, I don't think I get any. And you know, the elderly frail, those who have got less muscle mass and the SGLT2 might worsen. But don't think that I'm against SGLT2. The benefit of patients who are more than 65 years of age with SGLT2 is as good as, if not better, than the rest of the population. They do very well with the SGLT2 inhibitors, with their cardiac-wise, heart failure-wise, renal-wise. But a subgroup of patients do lose the muscles. And therefore, I tell them to do some resistance exercises routinely. And I'll tell you if I have time. So this is what I could dig out. This was a pilot study done in Japan, effectiveness of semaglutide on body composition in elderly obese. So again, I'm not interested in just lean mass. As I said, muscle mass divided by height or divided by body weight. So here was a pilot study where they gave in elderly patients, mind you. Now you see here, oops. So fat mass is reduced, skeletal mass statistically reduced, but skeletal mass percentage, that is skeletal mass divided by weight. That gives you a better indication of your skeletal mass percentage. That is actually more. Then if you look at the individual lower limb muscles, all of them, they are almost the same, before and after semaglutide. Now, the other one which I could get, there aren't many actually studies if you look at, and these are all recent, within the last 6 months. So this is a Chinese study where data was analyzed for about 53 patients, if I'm not mistaken, obese patients after 6 months of semaglutide. Now, if you see here, skeletal mass is reduced. Again, body skeletal muscle rate percentage, that is not reduced. Hand grip strength, arterial muscle power, that is not statistically significant. So you're losing weight, power is not reducing. So this, I find, is very important. Now, reducing body weight through appetite suppression. So energy intake during, so semaglutide, if you take whatever is given in front of you, so Vishal has arranged lunch for us, eat whatever you want. But if you're on semaglutide, you will be taking this much as compared to placebo. Because my patients, when I'm asked, so what exactly has happened? You see, with metformin, many patients become vegetarian. I don't like fish, I don't like chicken, egg, I just don't like it. And with semaglutide, they said, you don't eat non-veg? No, I eat. Previously, I used to have 4 or 6 pieces of mutton, but after 2 pieces, I'm fine. I'm not unhappy that I couldn't eat the rest, but I feel I'm fine. 2 pieces is fine. That is what the response comes from the patients. So I think the abdominal circumference, which is an indirect measure of the visceral fat, I think if compared with empagliflozin, there was statistically significant difference. With sitagliptin and with placebo, definitely there was difference. So you get about 3.5 centimeter drop. So you have got the Pioneer 6 trial, which I'm not going to go into detail. I think one of the largest trials is the SOUL trial, which should be out in the next 1 year or so with oral semaglutide and CV outcomes. Pioneer Real India, where real world evidence oral semaglutide, I don't think we have the results yet. So these are the group of patients where they have been tried. We'll have to wait for the results. The practical, and this will be the last slide, I think. So there is appetite suppression. So yes, 15 to 20% of patients will have nausea as well. But the rest who lose weight, they said that I don't feel like eating the whole plate given in front of me. The problem is, as I think Dr. Vishal Gupta was saying, and that it wasn't working when they gave it to the relatives, is the way that you're taking it. because one patient taught me this. So I gave 3 milligrams. Normally, the official dictum is you give 3 milligrams for 1 month, then 7 milligrams for 1 month, then 14 milligrams for 1 month. I asked, why will I do that? Will I be causing any harm if I do not give for 1 month? The answer is no. They come in strips of 10. So I go for 10 days. It is only for the GI effects. So I think 10 days is enough. So I give 10 days 3, 10 days 7, and then 14. Now, one patient, I gave 14. There is nothing is happening. Sugar is going up actually, weight loss. You gave such an expensive drug, nothing is happening. Every day in the morning, I wake up and put the tablet and I said, what? You said in the morning with 120 ml of water you take? I said, lesson for me. So now I say, take the tablet, whole, don't chew, water, drink. And then several of my colleagues said exactly like that. A few patients have said. I said, I've learned from this now. Whole tablet, 120 ml of water. How to measure? Just take half glass. No food or drinks for 30 minutes. If you follow that, that should be fine. So I think with this, what I would suggest is that there is a growing body of evidence on the intramuscular adipose tissue with the SGLT2 inhibitors, inflammation, and the fact that it makes you lose weight without really impacting on your muscle power. So far, the evidence points towards that, and that's why it is an exciting area. So thank you very much.
Thank you, Dr. Ganguly, for a brilliant presentation. There are a few questions online. I think the first question is how important it is to control weight in type 2 diabetes. I don't think that really requires an answer. It's important. We all know that. I mean, there's no point asking you to answer that. But the second one is, how is oral semaglutide effective versus the injectable variety?
Okay. So I think Vishal had probably answered that to some extent. I don't think there is any head-to-head trial with oral versus subcut semaglutide. Theoretically, the oral semaglutide absorption is only 1%. So if you don't follow the proper guideline while taking it, then the absorption might go up and down. That problem is not there with the injectable. So you inject, that will go up level-wise. Is there any comparison of the blood levels achieved? So I think it was presented somewhere in ESD that they indirectly compared oral semaglutide and subcut semaglutide and saw the level of the semaglutide in the blood. Actually, it is the same for 1.5 and 14 milligram. The level in the blood is the same, but it is not a direct head-to-head, separate, but the levels are the same. So if you take it properly, it should achieve the similar levels.
The third question is, can oral semaglutide be used in childhood obesity?
Not licensed yet, I'm afraid, so can't.
Anyone from the audience here? One question? Come.
Yeah, hi, doctor. So, do you recommend measuring IMAT, intramuscular adipose tissue, in clinical practice, and especially for individuals who may be at risk because of familial factors and genetic factors and hereditary? Is there any role in measuring this and going forward after 6 months, 12 months, or it is only theoretical?
This entity is very new now. See, we are just knowing about it. So I don't think it will become too expensive to measure the intramuscular fat. So we don't even measure the whole body fat, so let alone the intramuscular fat. But this is a new area, so I see in the future there is scope for this to happen. At this point of time, no, I don't.
Okay, thank you.
Okay, so that's automatic. So many patients come and say, give me some vitamin, give me some, my muscle weakness, they think that with diabetes you have to give a vitamin and you have to give a proton pump inhibitor. That's how come you have not given this? So when I looked at the data of muscle strength and this oral supplementation, so it seems with the oral supplementation, muscle mass increases, muscle strength doesn't. That's funny bit. Muscle strength doesn't. So there is no intervention which will increase your muscle strength except resistance exercise. Nothing else will increase your muscle strength.
I think we're interested in looking at what? Yeah, please show us the exercise. Exactly what I was asking.
So the best man is sitting in front of you here. So see, I don't go to the gym as as frequently as Vishal does. So I'll just tell you simple things because so three things: upper muscle, middle, lower muscle. Very, very, very important balance. I have a patient who I walk for 30 minutes every day, and in the lift, when I was standing, the lift suddenly gave a jerk, and I fell down. What's the use? Very important. So upper limb. So I've got a trainer who comes once a week. So 4 kilograms. So you don't need to have dumbbells. You take anything. 4 kilograms. Upper limb. Okay, 15 times. Up to here. Don't go beyond this. That injures the muscle. Injures the ligaments. This. So biceps, deltoid, okay, and the shoulder muscles up. So these are 3 for the upper limbs. For the middle bit, now you can do bending down, but I've got a bit of divarication of recti, and many people have this problem. So if you put pressure, that bulges out. So I do Kapalabhati, very simple. With every breath, like this, for about 30 seconds. Very good exercise. For lower limbs, you are sitting in the chair. Imagine when you're trying to get up, what do we do? At least I do that. Put my hand on the chair and then stand up. No. Whenever you're sitting up, you sit up and down at least 30 times every day. Make it a habit. When you're standing up from sitting, I'm trying to make this a habit for myself. When I'm standing up, I do like this. Okay? So if you do that at least 30 times, lower limb done, upper part of lower limb done, lower bit, heel, up and down. Simple. 3. Isometric exercise, muscle power. Very important, balance. What to do that? With that? Because the balance muscles might be different from your other muscles. From walking muscles are different, balance muscles are different. So what I tell is that simple thing, stand on one leg. So somebody asks, should I put the feet here? Just lift your other feet up. Stand like this. You will find after 15 seconds you will be wavering. Yeah, do it today. You will find after 15 you will be doing like this. So what I do is in the lift, because the lift at the start, at the end, it becomes a bit unstable. So there I put this. Going up, going down, other feet. So if you do this, and there is another thing that we do, tiptoe walking for checking cerebral symptoms. Okay? Walking backwards, very good balance. So these 3 things we can do. For elderly people, I say that don't start with lifting your leg without holding on to something. Hold on to something lightly. Once you get your strength, then you leave that. Then you do this. Simple things that will stop. So I've tried it on several of my elderly relatives. All have thanked me for this. They said, balance is much better.
Thank you. This is very enlightening. And we need now to...
So it has been trialed, but it is not licensed yet. No, I stand corrected. The subcut semaglutide is licensed in India, but is not available. Yeah, for non-diabetic, still not licensed. So not yet. But yes, the trials are there. It is a craze in USA.
Dr. Date, before we become hypoglycemic, you have to keep your thing short, all right? Because we have one more talk before this.
Huh? Well, in use, I don't know. I don't know. Yes? Semaglutide, yes. What is the result? I think the empagliflozin arm, there was 0.8% drop in HbA1c. With the oral sema, it was 1.3. Body weight, at 52 weeks, it was statistically significant. Not as much as I expected, with oral semaglutide being more, but not as much as I expected.
Okay.
Outcome trials with what? Huh? All the CVOT are 3-point MACE, which includes mortality also. That was not a trial to look at mortality versus empagliflozin. So you have to look at SOUL trial, which will have 3-point MACE, and 27% of the patients on SOUL trial is with SGLT2 as well. So you'll have a good idea there.
Thank you so much. It was very kind of you to address us. We have to do this last talk before lunch.
Good afternoon, everyone. I'm Vaishali. I'm Vaishali, working with Vishal for last 10 years. I'm going to present a case discussion wherein Bipin sir will moderate the case. We have a patient, Mr. K, a 33-year-old young man, smoking 4 to 5 cigarettes a day, last 5 to 10 years. Lot of work pressure, which all the youngsters coming to the clinic, they have this answer. बहुत pressure है sir, बहुत pressure है ma'am. With a family history of underactive thyroid and diabetes in mother. He presents with a very poor quality of life, 3 of 10, 10 being the best, since the lockdown. He's constantly fatigued, bloated, especially after meal. He's unable to sleep, taking long hours to sleep, and often gets up in the middle of the night with palpitation and choked up feelings. He's been on anti-anxiety medicine post-lockdown, sertraline 10 milligrams per day over last 2 years. His current medication includes a lot of supplements with the fear of death, since we're seeing many people dying in the mid-40s. He's on longevity enhancers and also on thyroid replacement of 50 micrograms per day. We asked for his thyroid test. His TSH 2020 was 1.1. 2021 was 1.9, a TSH of 5.1 in 2022, and on 50 micrograms of thyroid replacement, his TSH is 2.1. And a dose reduction or stoppage was considered by a treating physician on obviously request of the patient, citing that Dr. Saab, my TSH has always been in the reference range. On presentation, little parameters of the patient's weight was 107 kilo. He's given up on losing weight since he tried liraglutide 3 milligrams per day for 3 months, and he lost only 3 kilos, which he all gained back on a 10-day holiday. He gained over 10 kilos. Pulse rate was 92 in the clinic with a systolic pressure of 146 by 96. He was extremely anxious after all the counseling we tried doing him. His lipid profile, total cholesterol of 240 with a LDL of 100, triglycerides of 250, HSCRP of 6.8 with a TSH of 2.9 after the dose reduction, if reminder. TPO antibody negative, TG negative. His liver enzymes were not optimal. His A1C was 5.9 with an impaired fasting glucose. What is his working diagnosis? Optimally treated hypothyroidism with sleep apnea syndrome. Optimally treated hypothyroidism with a generalized anxiety disorder. Diagnosis of hypothyroidism is wrong, and we need to be under he needs to be under a psychiatrist and a sleep specialist disorder. Adrenal disorder and thyroid medication would be worsening the hypocortisolism. We need more information to the case. I would request Bipin sir to help me.
Yeah, I think this one works. I'm usually loud enough. So, as far as the hypothyroidism is concerned, can we go to the first slide? I'll remember this. The diagnosis of hypothyroidism was based on his TSH of 5.1. Now we assume that this was subclinical hypothyroidism, and since he was complaining of many other symptoms, for symptomatic improvement, with or without anti-TPO antibodies, he has been placed on treatment, and that diagnosis is there. It's not that he does not have subclinical hypothyroidism, whether he needs treatment or whether he doesn't need treatment, whatever he has received has normalized his TSH. So that part I think is correct. Now whether he has any anxiety disorders, I think that all that description that you are giving are of a person who has some anxiety disorders. So I don't think, now we can go to the last slide, which you have shown us. So now whether he has generalized anxiety disorder or he has got worsening of hypocortisone. Theoretically, yes, but unlikely that he has with 50 micrograms worsening of adrenal disorder. See what happens in some people who have got, let's say somebody's got Addison's disease and somebody's got hypothyroidism. You are supposed to start steroid first and thyroxine afterwards. Do you know how much time it takes for thyroxine to start acting? By 1 week it will start acting. There are patients who come and tell us that if I don't take the tablet for 1 day, I feel miserable. I said that's good for compliance point of view, but pharmacokinetics don't suggest that your levels have fallen. Or I took the first tablet of thyroxine that you gave me and I felt miserable. That has not even reached the tissues. So I think this possibility is little bit less likely. Now, I'm sure you will have much more information. So, but only thing is at this moment we can clearly say that he has hypothyroidism. All obese people with this kind of weight will certainly have some degree of obstructive sleep apnea. You have not documented it, but anxiety disorder is very much there. So I don't think that he has got one disorder. His main problem is anxiety, and that has created issues. And the second thing that you raised very importantly is many of our patients, they discuss their disease with somebody else. My auntie is taking 25 micrograms. You put me on 120. Don't you think this dose is too heavy? So I tell them that, aren't you heavy? If somebody, see, it is a per kg body weight requirement. So if you have got a lean and puny girl like this, she will require not more than 75 micrograms. Now I am a little stout, I will require at least 100 or 112. Somebody else may require 150. So you cannot say that this. So we tell them the good way of looking at is not comparing with your neighbor or somebody else, but with the TSH. If your TSH is normal, many of the physicians have saying that, "Arey, Dr. Bipin ne tumko to 100 milligram ka dose pe dal diya. You should take smaller dose." Then what happens? That smaller dose is 12.5 and he comes away with a TSH of 75. So we tell them that if your TSH is normal, first, don't let anybody change your treatment without doing a biochemical analysis. In my view, this dose is too much. So you do the TSH while the person is on drug. TSH is high, dose is inadequate. If the person has missed it, different. If the TSH is normal, continue. TSH is low, only then, and then you should decrease, provided you have ruled out things like biotin. There are many people like even I would like to grow more hair. Na? So the first thing that the dermatologist gives is biotin in grams doses, and that interferes with the TSH assay. You can have a clinical picture of thyrotoxicosis, but the patient is okay. And some of them do even produce increased FT4, decreased TSH, and also interference with the TSH receptor antibody. We think is Graves' disease. So I think that's important. But this patient, doctors or he asking for change in treatment, could be that he was subclinical hypothyroid, never had any symptoms. So he is obviously wondering whether he should take it or not. So hypothyroidism is clear. He will probably be having sleep apnea. He has anxiety disorder. At the dose that he is taking, unlikely that he has got adrenal insufficiency.
I'll go on to the next slide, sir. In the meantime, he went back to his trusted doctor, who reduced his dose to 25 micrograms. He did his TSH after 2 weeks. After he felt extremely uncomfortable, the TSH had gone up to 3.9. He saw the same treating physician in his clinic, and his blood pressure went up to 156 by 100, and pulse rate was 76. He felt more anxious, more bloated, and weight gain was there. Also, the weighing scale didn't show it. What is the working diagnosis? No evidence of thyroid disease and sleep apnea syndrome. No evidence of thyroid disease with generalized anxiety disorder. He needs a psychiatrist and a sleep order specialist. Pituitary disease with bioinactive TSH. Overactive adrenal disease. We need more information.
Now, if you just go back to the slide that you said, now this patient's physician has decreased his dose. And to be fair to the physician and to this patient, only after 2 weeks, this is 2 weeks again, ideally you should do it after 6 to 8 weeks, his TSH has started going up. So we can't say that he did not have, there is some change that has happened, and his blood pressure has increased, which could be circumstantial. But we are clear that within 2 weeks, his TSH has started going up, and you give it another 4 or 6 weeks time, TSH going, you can just go to the slide that you showed. So I don't know whether we can say that he doesn't have any thyroid disease. If we really wanted, there are many people who ask us, shall I get the test done while taking the tablet or after stopping the tablet? So I asked them a question, why is it you're getting the test done? If you're wanting to know the efficacy of the drug, please take it after your routine thing. If you want to know whether the drug is necessary or not, then you stop it. There are people who are taking 12.5 micrograms and their weight is 100 kilos. TSH is normal. So we tell them that, okay, you can even stop it. So after stopping, the TSH remains normal. That is one tablet less for them. But the lady says that I stopped it one day, I felt miserable, I gained 5 kgs weight. So I tell them, you didn't go to Dr. Vishal's party. You can't get 5 kg weight gain by missing just one tablet. So this patient has some subclinical hypothyroidism. I never used to believe that people gain 10 kgs weight in 10 days. But in one day I have gained 1 kg weight with Vishal's food. So you can gain weight. The second one is anxiety disorder, he definitely has. He is telling the doctor that I have gained weight, the weighing machine is not showing it. So how can that be? So that is one thing. And bioinactive TSH, there has been a fluctuation in the TSH level on treatment. So we can't say it's bioinactive, though that's one possibility. Theoretically, his adrenal is overactive because he's producing a lot of catecholamines. But I don't think that we can say that he doesn't have thyroid disorder, he doesn't have anxiety disorder. So I think he has those. He may be having something else, and he has some requirement for thyroxine because the TSH level is beginning to increase even after 2 weeks of omission of treatment.
We did further investigation. Thyroid sonography showed a goiter. Repeated thyroid antibodies showed they were still negative, and a TSH done after 2 weeks gone up to 4.3. A full thyroid panel, a TSH of 4.3, FT3 mid centile, and FT 4.95, low normal range, sir.
So your TSH normal range is what in your lab?
0.4 to 4.
Up to 4. So he has subclinical hypothyroidism. That's okay because you haven't given the range of TSH.
Yes, 0.4 to 4.2, sir. What is the line of management for this patient? We restart the levothyroxine at a 50 microgram dose along with the gluten-free, dairy-free diet. Up-titrate the dose to 1 microgram per kilogram body weight according to the ATA guidelines. Initiate a T3-T4 combination such that the ratio stays 1:5. Titrate TSH to low limit of normal and start CPAP therapy. Initiate optimal dose of T3, 25 to 50 microgram per day, and supplement T4, titrated to the TSH of low limit to normal. Initiate blood pressure management with calcium channel blockers. Rule out adrenal overactivity. Start CPAP, but wait to start thyroid replacement therapy. Evaluate the patient for pituitary disease, both anterior and posterior function tests.
I think these are all very relevant questions. Now, this patient has subclinical hypothyroidism, is symptomatic. His symptoms can be anything. This patient, his main symptom is weight, and he is unable to lose weight. Now the problem is that he has subclinical hypothyroidism, he is antibody negative. He is symptomatic and his symptoms have worsened after stopping treatment or attempting to withdraw treatment. So he does require to restart the thyroid hormone replacement. Now this thyroid hormone replacement has gone a full circle. When initially the only treatment for thyroid replacement was thyroid hormone extract from the porcine gland, and that used to supply both T3 and T4. The problem was we didn't know whether what was the iodine content of this, and it could not be standardized. So when we went to T4, we said, okay, fine, wow, we found it, because we are able to now give an exact measurement, 12.5, 25, 50, 37, 62.5, 75, 88, whatever it is, you can titrate the dose. And then years thereafter, we found that TSH is a good marker of adequacy of treatment, at least in primary hypothyroidism. So we thought that the story was over. My professor was supposed to give a talk on recent advances in treatment of hypothyroidism in 1990. He said, what is recent in it? Are you administering the tablet from any route other than the mouth? That may be recent advance. So the issue was that we thought we have settled everything. And therefore, most guidelines say if you have subclinical hypothyroidism, you look for indications. Somebody is pregnant, somebody is planning pregnancy, somebody is planning fertility cycle, treat them. Antibodies, if-ish, because the Indian Thyroid Association, which has come out with guidelines, say antibodies are positive, you could still observe these patients, but most people will be inclined to treat these people. And if the patient is symptomatic, treat them. Then see what happens to them. If symptoms improve, continue. Symptoms don't improve, the treatment for which it was started was symptoms, to stop it. So we would like to restart this patient on this regimen and then see how he goes. You can start with 1 microgram because these people are basically requiring much lower dose, and his highest TSH was 5.1. After stopping treatment is 4.3. So I would be quite comfortable treating him with this and see how he does. The way he's been responding, it's unlikely that he is going to respond to anything that we give, because this is something like this. You have fever and you take treatment, you are okay. You have got toothache, you take treatment, you are mostly okay. Hypertension, coronary artery heart disease, obesity and diabetes. Many times have you not seen the patient saying that, sir, HbA1c सब ठीक है, sugar भी ठीक है, lipids भी ठीक है, no, ठीक नहीं लग रहा. The quality of life, and the patient comes to VJ and says, my quality of life is good because he meets good people. The quality of life issues are still there for all chronic disorders. So if a patient of hypothyroidism is unhappy, we don't know what to quantify. At least TSH we are able to quantify, but how do you, you just give him a score of how happy you feel, and he just marks that, how do you quantify that? That is the problem. So we would conventionally like to start him on levothyroxine, and you have shown such very beautiful data on T3, but still all guidelines say start these people on treatment with levothyroxine.
A sleep study confirmed severe OSA. Weight loss was agreed upon both the parties. Optimized thyroid to achieve weight loss was agreed upon, as Sir said. He was initiated on T4 replacement and TSH was titrated between 0.3 and 1. The doctor covered him with a very low dose of beta blocker for 5 days only to settle him with the thyroid replacement, and he was put on a gluten-free, dairy-free diet, and he was asked to follow up after 4 weeks. This was the treatment started. Now, in the meantime, he visits a cardiologist for an annual review just before his thyroid review. The doctor found missed beats. Pulse rate was 82 beats per minute. His ECG confirmed the ectopics in lead 2. Patient was though asymptomatic. His TSH was 0.4 after all his trusted doctor did. Patient was told ectopics were because of thyroid hormone replacement. The cardiologist asked the patient to reduce the thyroid dose to 37.5 micrograms. He postponed the thyroid doctor's review and went to see the cardiologist after 4 weeks. With the focus now has shifted from weight to the heartbeats. Now the repeated TSH was 9.1. His blood pressure was 160 by 100. And his weighing scale showed 3 more kgs higher. Coming back to the case, what do you think is happening to him? Hypothyroidism with pheochromocytoma, hypothyroidism with Cushing's disease, subclinical hypothyroidism with celiac, with sleep apnea and urgent need of weight loss, generalized anxiety disorder with sleep apnea, no thyroid disease, and I'm unable to.
Right. All these options are not correct. Not that I'm not able to comment. The thing is that you have shown that he has hypothyroidism. That there is no doubt about. This patient, after giving treatment for obstructive sleep apnea, also has not lost weight. He has gained 3 kg weight. I don't think that his weight gain is solely on account of the thyroid hormone reduction by the cardiologist. So when we often tell this is in a lighter vein, that when you start some treatment, the patient says, my doctor told me to stop this. So I tell them that is he an endocrinologist, because endocrinologists also differ. If I have a bone fracture, I don't take the opinion of an endocrinologist whether I should get a nail fixation, total hip replacement, partial replacement, or McMurray's orthoplasty. We go to the doctor who is treating this and is familiar with this disorder, then only his comments are valid. If I comment on, you have undergone bypass, you should have undergone stenting, on a drug-eluting stent. So this trusted doctor should be one who has similar qualifications. There could be difference of opinion, but you can't ask a homeopathy doctor whether thyroxine is required or not. I'm just exaggerating it. So similarly, you can't ask a cardiologist to review, because we have these two statements in our medical school that strange are the ways of God, gynecologist and cardiologist. If the baby is delivered nicely, it is because madam has done it. If something went wrong, because the TSH, it increased from 2.5 to 2.55, that mucked the whole thing up. So the same problem has happened to this man. I think he has hypothyroidism. He has anxiety disorder. I don't think we have to look at only celiac disease. He is absorbing it well. His absorption is good. TSH is coming down. So I think I'm able to comment, but I don't think any of these is the right answer.
Thank you very much, sir.
Then what is the next thing that happened?
He was not our patient, sir.
Okay. So that is the hypertension was being treated with
calcium channel blockers. Yes.
It was, yes sir, yes sir. Topics. Day. By Gemini or so what she was trying to say no, these beats are too small and they are not likely to be due to their dose. If somebody is thyrotoxic, TSH is suppressed, we can say it is because of thyroxine replacement. So your question is right, sir, that this requires additional investigation, but not finding a blame on thyroxine replacement and stopping or decreasing the dose.
Exactly. Your point is well taken. Let us just break for lunch. We need to keep some timing here, or we'll be here all evening.
Thank you.
Thank you so much. Thank you very much.
Protection beyond RAS blockade and SGLT2 therapy. Rushi.
Sure. Hi, good afternoon, everyone, and thanks, Vishal. It's always nice to be a part of this meeting, which has now become our annual event for a long time. So, am I clearly audible at the back? Yeah, wonderful. Thanks. Okay, so we are talking about renal protection beyond RAS blockade and SGLT2 therapy in diabetics. So, this is a young guy, like any of us here, 10 years of diabetes vintage, hemoglobin A1C of 7.4, blood pressure of 138/84. Now, on a routine visit, you look at his eGFR, it's coming to 60. All of you are familiar with this table, right? Which looks at the GFR, the estimated GFR, and the albuminuria, semi-quantitative, and tells you where do you fall on the chart and what is your risk, progressive risk. So, we know that the green is good, yellow is okay, orange is little problematic, red is very problematic. So, Raj is looking green with the eGFR of 60, but his albuminuria ACR is 352, which puts him at G2A3, which is not as good as it looked when we did not know about his UACR. So, the take home point is, it's not just the eGFR that you will look at when you see your patients with diabetes, but it is imperative that you also monitor the urinary microalbumin or the albumin semi-quantitative method at least, to understand where they stand in terms of proteinuria. Why is albuminuria so important? Because we know that it is an independent predictor of cardiovascular composite endpoints as well as renal endpoints. So, whether we are looking at doubling of creatinine, end-stage renal failure or mortality, at all parameters we know that albuminuria is predictive, and not just that, worsening of albuminuria is directly proportional to the increase in the events, whether it is renal or cardiovascular. So, it is not that you need to have a proteinuria above a gram or 3 grams to have a bad outcome. Any proteinuria, albuminuria beyond 30 milligrams per gram, there is a linear increase proportional to the amount of albuminuria you see in both cardiovascular as well as renal endpoints. So, what we are trying to say is that albuminuria is an independent risk factor which you are all aware of, and now we know that reducing albuminuria is very important, not just for slowing down the progression of CKD, but also in reducing the cardiovascular endpoints that we just discussed. So, the ADA 2023 says that in patients with chronic kidney disease who have albuminuria of more than 300 milligrams, a reduction of 30% of greater in the urinary albumin excretion is recommended to slow down the progression of the chronic kidney disease. So, this is important. Why is it that in a diabetic who say Vishal has controlled excellently, HbA1c is now less than 7, between around 6.5, why is it that the renal illness still progresses? Because the driver is not just metabolic, it is not just glycemic control. There are two equally important factors. One which we understand very well as clinicians, which is the hemodynamic factor. Now, this Brenner's hypothesis, many decades back now, clearly showed us that intraglomerular hypertension is the driver that leads to further worsening of proteinuria and renal dysfunction in diabetics particularly. For that matter, he also showed that in non-diabetics with a 5/6 nephrectomized rat, they could show the same process, that intraglomerular hypertension is a single factor. So, if at all I had to choose one to treat, I would have chosen the hemodynamic factor. That is how important it is. The last is inflammation and fibrosis. Now, that even today to me, I mean, I understand it is important, but whether I can really change it with the armamentarium that I have at my disposal today is a question that I ask myself. If we look at the renal part, the cardiovascular part I am sure will be discussed by my colleagues in the audience who will be speaking after me, but the renal part, if I was to do a kidney biopsy on any of these patients, what am I likely to see? if I have a concern, I'm not sure about my diagnosis of diabetic nephropathy, I would do that. Otherwise, if I just biopsy a diabetic nephropathy, what do I see? I see the KW kidney you are not going to see usually, because that's usually an advanced lesion. You will see more like mesangial expansions, early glomerular sclerosis, tubulointerstitial damage, some hypertrophy at the level of the glomerulus, and all of these are factors which will tell you that this CKD is likely to progress. So, what are the different approaches that in today's 2024 as we stand, what are the different approaches that we can take to slow down the worsening progression of this CKD? We know now the pathological mechanisms that are at play, the pathophysiology. So, the most important remains the RAS blockade. Why? Because like I told you, hemodynamic is very important. Reducing intraglomerular hypertension should take precedence over everything when it comes to slowing down the albuminuria and progressive kidney disease. So, RAS blockers work, that has been shown for almost 30 years now, and use it to the maximum tolerated dose, and it will just continue with it. So, it is like the stock market, like I was sharing with somebody, you have to start early and you have to stay invested. I suppose that is the only way to make any money, right? So, that is how it works here. The other drug which is very good and is very easily available to all of us today is the SGLT2, which I am sure all of you are already using in practice, and that is a wonder molecule. And in patients who don't have urinary tract infections, we see wonderful results just maintaining it, both in terms of edema, the natriuresis, as well as by reducing the tubuloglomerular feedback, it leads to decrease in the intraglomerular hypertension and slows down the proteinuria. The GLP-1 receptor agonist for metabolic control, that is something that I am sure Vishal will cover at a later point. The last thing is the MRA, and of which finerenone stands out today as the only non-steroidal MRA, and that one of the purported mechanisms is reducing the light green shade which I mentioned, the factors which we don't understand so well today, fibrosis, inflammation, endothelial dysfunction, and as to how it would do it, we'll see. So, by reducing the overactivation of the mineralocorticoid receptor, it slows down the progression of heart and kidney disease in patients with type 2 diabetes. So, it does work by the mechanisms we understand well, the hemodynamic mechanisms, and also by decreasing the inflammation and fibrosis. So, why choose a new mineralocorticoid receptor antagonist? You already had two, right? All of us use spironolactone in practice, and eplerenone, I mean predominantly cardiologists, but we have all used it in practice also. Are there any advantages? So, one is definitely the non-steroidal nature, and the other important one is that it has, so two things I will tell you in my clinical thing that helps me choose between the different MRAs. One is the gynecomastia. So, that is much lesser with finerenone as compared to aldosterone through the spironolactone. And the second is hyperkalemia. Now, there I will tell you, if they are on a good dose of finerenone, I am not seeing very low incidence of hyperkalemia, but it is shown in data that it has lesser incidence of hyperkalemia as compared to spironolactone. So, particularly where I use it today is it in males where I want to use an MRA. That is the starting point. Females, shifting them from aldactone to finerenone, not unless there is a real reason to. So, all of you are familiar with the 4 pillars of managing heart failure, right? So, similar to that, this would be the 3 pillars for managing chronic kidney disease in diabetes. Optimize the RAS blockade, keep them on SGLT2 inhibitors, and add a non-steroidal MRA to the prescription. So, these 3 pillars are important in practice to ensure that we are doing the maximum possible to slow down the progression of chronic kidney disease. Evidence is definitely in favor of this molecule finerenone. Both the Figaro and the Fidelio trials and the combined analysis, what they call as Fidelity, is one of the largest studies. You can just compare with the DAPA CKD or the EMPA or even the IDNT the renal is an old study which was the first one that showed losartan in diabetic nephropathy. So they really had a good number of patients here. So they included patients across different spectrum. So Fidelio is the late stage CKD. So more proteinuria patients were taken with lower GFRs. And Figaro was an early stage CKD, so to say, with lesser proteinuria and better GFRs. Both of them together is the Fidelity, which has patients from CKD stage 1 to 4 with different levels of albuminuria. So if you look at the pre-specified pooled analysis of the data, the patients who were taken were diabetic, CKDs of different stages, already on good dose of RAS inhibition, and who did not have hyperkalemia. And they studied both the cardiovascular and the renal endpoints which we discussed. And this is important slide for all of us, because it's what they have done is 100% of their patients were on RAS blockade. So it's only after RAS blockade. The problem here is the bottom, the last line. Only 6.7% of the patients were on SGLT2. Now the reason for this is that when the study was conceptualized, SGLT2 was not the standard of care. That became standard of care subsequently. But that remains one of the problems with this data in today's time, because these patients were not on full doses of SGLT2 as they would be if a study was conceptualized today. And also they were fortunate to have a mean potassium of 4.4 in patients already on maximum dose of RAS inhibition. So if you look at the baseline, 40% of patients had albuminuric CKD with preserved kidney function, by which they mean a GFR of more than 60. And the median albumin create ratio was 515, mean GFR of 57.6. So what they found on follow-ups, and that up to 4 years of follow-up was done for these patients, so it reduced the risk of composite endpoint by 23% and of renal failure requiring dialysis by 20%. So in clinical practice, that would mean delaying dialysis for 1 patient out of 5, which is not a bad number. Every 5th patient walking into my clinic, if I can avoid or delay his dialysis by a significant period of time, I'd be willing to do it, right? Not just the kidney, but it also helps the heart and all cardiovascular endpoints, non-fatal MI, non-fatal stroke, hospitalizations for heart failure. The incidence came down by a similar number, around 20% or 1 out of 5. So Finerenone demonstrates significant on-treatment reduction in the incidence of all-cause cardiovascular mortality and risk of sudden cardiac death in the intention to treat population. So what about the proteinuria reduction? By month 4, if you see, the albuminuria reduction is by 32%, which means that it's 1/3 down from the peak that it was at. My own analysis of whatever patients I have seen tells me that if you start early, by early I mean a albuminuria less than 1000 milligrams, you are likely to see this effect. If you start when the albuminuria is above 1000, it will take you much longer to get it down by 1/3. Okay. Now whether it is referring to the pathophysiology of the illness, whether it is different in that population, or are we just starting late, I don't know. But that is what it is in practice. If you are lucky to have a albuminuria less than 1000, you can show great results by adding this molecule. So in the fidelity analysis, it improved the urine albumin creatinine ratio in patients with chronic kidney disease and type 2 diabetes, irrespective of SGLT2 use at baseline. But the caveat is that the percentage of patients on SGLT2 was a very small number, less than 10%. Okay. But it did show that even in absence of, or even in presence of SGLT2, it did show a further decrease in the proteinuria by 1/3 almost. Now this is important. It's an expensive molecule. Are we really giving any benefits? Now this data is compared with a placebo, but what it showed that clinically meaningful hyperkalemia was lower than as compared to the steroidal MRAs. Now this was a little concerning to me, that analysis on the right, if you can see there. Look at this. These are patients on dual RAS inhibition, and here the risk of hyperkalemia is 1.97, intervals of 1.3 to 2.9, and this is your non-steroidal MRA far better than the steroidal MRA when it comes to hyperkalemia, right? 5.4 versus 2, but still worse than dual RAS inhibition. I mean, you and I gave up on dual RAS inhibition because of hyperkalemia. The trial showed us that there is a higher mortality with hyperkalemia. So this drug we need to use judiciously and with monitoring the potassium. Okay. So it is a great drug, it works, reduces the proteinuria, but if the dual RAS blockade is causing similar amounts of hyperkalemia, then we need to be careful while monitoring these patients. Guidelines are definitely in favor of this molecule. Both American Heart Association, ACE guidelines, ADA, KDIGO, which is like the Bible for nephrology, RSSDI, everybody has recommended in 2023 and far more in 23 and now in 24 ADA guidelines. They are all recommending early usage in CKD with this molecule. My own limited experience, not now it's more actually, but when I gave them this data, so this particular patient that we had, he was started on Finrenone, and within 4 months his albuminuria reduced by almost 50%, and continuation wise it came down to almost 44.5%, so it was great. So this was the 20 patients or so that I collected for them when we started using this molecule. And if you see this data, quite similar to I suppose everybody's clinic, 2/3 males, around 12 years of diabetes, mean GFR of around 40, otherwise they would not come to my clinic, right. What was surprising was that the patients that we chose, or I must have chosen at a subconscious level, were the ones with lesser proteinuria to start with, right. And significant number on ARBs and ARNIs together, that's almost 2/3 of the patients were on some form of ARB. As you know that using ARBs when the creatinine worsens, a lot of people tend to take them off instead of continuing or persisting with them, which would be the right thing to do. Smaller number on loop diuretics, still a significant number on metformin, almost half of that. I think Vishal just stepped out, so we'll ask him what he thinks about that. But the USR excretion came down by around 40% in the follow-up. And in the second follow-up, it was showing a further decrease up to 50%. Okay. So like I showed, if the stage 3, which means the patients who had more proteinuria, the reduction is lesser as compared to if you start it early. Even in this small cohort of 20 patients, you can see this effect. So this is a very visible effect if you're looking for it in practice. If the albuminuria is less than a gram, the effect is better. If the albuminuria is more than a gram, the effect will take longer and won't be seen as easily in say 6 months of follow-up. It may take longer. So different CKD stages, it showed a similar improvement, no question there. In the patients with a history of cardiovascular disease, there was a great improvement in the UACR. Creatinines, I would not say, this is difficult to explain why in this cohort the creatinine drops so much. It doesn't usually drop so much in such a short follow-up. I think it was reducing the diuretics in a similar time, because I thought that when you are using something that is again blocking the sodium uptake and causing natriuresis, we could reduce the diuretics in this group of patients, and that's why we must have seen an early improvement in the GFR by some pre-renal changes. In the 20 patients that I followed at this period, potassium wasn't a significant issue in most of them. So nobody was discontinued because of hyperkalemia. So this was a carefully chosen population. So in conclusion, around 1/3 of, around 40% reduction in the urinary albumin creat ratio with a stable eGFR through the period of time, and no significant hyperkalemia in the 20 odd patients that we studied in our clinic. So at the end of the presentation, the key things I would like you to take home. So MRA is one of the pillars when it comes to managing diabetic kidney disease with albuminuria. Start early. Which MRA to choose? The evidence is heavily in favor of Indea or Finrenone. That being said, the similar action can be obtained by both aldosterone and eplerenone. The advantages in clinical practice are minimal or no gynecomastia. So particularly male patients, you would want to preferentially put them on non-steroidal MRA as compared to a steroidal MRA because of this potentially troublesome side effect. Hyperkalemia is there in these patients, so please watch for it. like, with Vimada, how we had these experiences when we started, same here. When you start this, you are going to see more hyperkalemias. If the potassium is above 5.5, you should hold the drug temporarily, wait for it to correct, and then reintroduce the drug at a lower dose. You can start the drug till as long as the eGFR is above 25, and if you are already on it, you don't need to take it off just because the eGFR has dropped below 15. The benefits seen both in terms of renal endpoints and heart failure is almost 1 in 5 patients is saved from dialysis, and 1 in 5 patients from a hard endpoint, the cardiac endpoints, by using this drug consistently. Thank you so much for your attention.
Thank you, Rushi, for an excellent presentation. I think there will be some questions for you. My question is first, I know the target dose is 20 milligrams. How effective is it at the 10 milligram dosage?
So, it's effective when you look at the MRA effect in terms of natriuresis and some diuretic effect, definitely. But like for ARB, sir, for lowering blood pressure, we require a lesser dose. For antiproteinuric effect, as you keep on increasing the dose, you see more and more antiproteinuric effect. The same thing holds true for Candia as well. You keep on increasing the dose, you see more antiproteinuric effect.
Any questions?
We are not the efficacy wise, we are not challenging that which drug is better. Both are better. It's the side effect profile that is helping you choose between them. But right now I don't have, see the third circle, if you remember the 3 circles in the pathophysiology that I showed you, hemodynamic, metabolic, and the molecular mechanism, the fibrosis. Now unless we are able to show you some hard data with this drug that is showing you, say, for an example, say IL-17 or WNT1 expressions, which are markers of fibrosis in the kidney. If this drug is showing a reduction in those markers for a starting point, then I will be telling you, no, use this instead of spironolactone. For today, I don't have any reason to use one against the other. If it's a male patient and gynecomastia is a troublesome side effect, definitely choose this drug over spironolactone. Similar extent, there will be reduced reduction in the pro-BNP. If you are not having any trouble with your patient on eplerenone, I am not going to ask you to switch to.
Okay, no further questions. Thank you, Dr. Rushi, for your very good presentation. May I request Dr. Suresh Vijan to come forward to make his presentation on evaluation and treatment of type 2 diabetes with subclinical diastolic heart failure. Dr. Vijan is a well-known cardiologist in the city. He has been trained at the prestigious Texas Heart Institute, Houston, and has several papers to his credit.
Good afternoon, people. First of all, I must thank Vishal for asking me to come and talk to you about heart failure. Pointer. Okay. And my favorite topic for the day always is heart failure. And last weekend I've been busy since Friday on various meetings in cardiology, heart failure, and atherosclerosis. So my wife's threatening now that if I didn't behave myself, she's going to go to her lawyers. So I want to behave myself on this issue. So I'm going to talk to you about management of patients with heart failure inside the hospital. And I'll just give you a little bit of glimpse of why it is important that we get very aggressive at managing these patients inside the hospital. Tendency for anybody with treating heart failure, oh, he's breathless, he's looking. Let's be very gentle, give some diuretics, let him decongest, and then we'll see about other drugs later. Later means never. Patients improve, they become less breathless, they come to your clinic, you say, oh, he's looking fine, carry on with everything. So the drugs that modify the disease. What the diuretics does is release congestion and nothing else. drugs that will actually modify the underlying disease do not get started and then never get started. So the benefit in terms of reducing the heart failure mortality, which is incredible, it's worse than breast cancer at 1 year. 50% of patients with heart failure will be dead in 1 year if they're not treated appropriately. So that mortality, we don't seem to kind of have an appreciation of that. We're very appreciative of breast cancer mortality, but for heart failure, somehow we don't seem to have that kind of fear that this patient could die within 1 year. So the point that we're going to make today is aggressive therapy started very early during the onset, and that's where I think it's going to be an eye-opener for a lot of people. This is what we want to do. If you look at a heart failure patient who's admitted here, what's he going to do? This is acute onset heart failure. He's come to you feeling very breathless, naturally. He's bubbling, his lungs are full, he's got edema of feet, ascites, and quite rightly you're going to start intravenous diuretics, which is fine. But within 24 to 4, it's not working. This one? No, I think the battery is gone. What really you want to look at is early phase, decongest, rapidly decongest, no problem at all. Large doses of diuretics will work very well. But the transition from the early phase, oops, what's happening? Okay. The transition from the early phase to the mid phase is what I call, or somebody uses the word late acute phase. I mean, to me, it's like bad English rather than anything else. So here is where we need to work on between the early phase and the time that you are thinking of transitioning home. A period which is very variable, can be a few days, can be a week, 10 days. So you have time on your hands to do it. But I think we need to concentrate here. I don't see this, okay. In how to transit from intravenous diuretics, which all of us are giving, to oral diuretics, then to oral other medications. And that's the more important part. And then, of course, we'll go on to optimization phase. So by the time the patient is ready for discharge, he's on a fair amount of drugs. So what should you want to do? Here is a 60-year-old patient, okay, admitted with cough, expectoration, as you explained, edema, feet, generalized weakness. You examined him, chest is full of water. You started him on diuretics. Blood pressure is 160/90, saturation 76%. ECG, as quite rightly shows tachycardia, maybe left ventricular, maybe ST segment changes. A 2D echo done shows grade 2 systolic dysfunction with an EF of 28%. And this is what your patient is. He's there lying in front of you in the ICU with heart failure. What do you want to do and how do you want to do? First of all, let's assess what is the severity of all these problems. What is his mortality? About 5% of patients will die in the first acute admission. A figure that we don't seem to register a lot because anything can happen there. But 5% will die in the acute admission while you're getting his heart failure and the control may not be. Another 20% will be readmitted within 1 month of discharge. Now these are the two figures that I want you to keep in mind because this is what determines all the long term. Either hai, lekin ye dikhta nahi hai. I can't see that, okay? And this is the kind of U shape where the first part with the patient in hospital is a vulnerable phase. You want to actually treat that, and he's going to transit from that phase to a chronic heart failure, which is about 6 months, 1 year down the line. So it's in this limb of the U that we need to get aggressive so that they very safely transit to the chronic heart failure side with the least amount of symptoms and remain most ambulant as far as the symptoms are. And more importantly, do not get readmitted. I think that's important. We don't want a readmission for heart failure, which means basically he's gone home with suboptimal treatment. What we talked about, vulnerable phase, immediately at the time you're ready for discharge or just discharge is where patients are vulnerable for readmission. So we need to minimize that as much as possible and try and take care of things in terms of what happens to them. Okay, so this is just one question for you. In patients with heart failure who are what proportion do you think get readmitted within 1 year of his diagnosis? They gone home and come back. Any idea? More than 10, 1 out of 3, 1 out of 3, 5 out of 10? Generally a third of the patients, the rule of thumb is third. A third of the patients will be admitted again within 1 year of the initial diagnosis with worsening heart failure. Okay, so the heart failure will have got worse, and that's what we need to do. And about 25% of patients will be admitted more than once in the first year from heart failure. So the risk is 3 times for all these patients, and this is what we need to worry about, because every time they are readmitted, the mortality keeps on increasing. So a third of the patient die within the first year, 9.7% in-hospital mortality for the second admission, which is double to what it was in the first admission, a 30% increase in all-cause, 38% during 1 year, so mortality of 30% with the current medical treatment, if at all anything is being taken, and the worst mortality of all in terms of what will happen to these patients. So we really need to have some strategy in place when we are treating them in the hospital to prevent these reasons, because whatever we do now is what affects the reason for them to admit it. So we need to get aggressive as far as that. So when they are admitted, diuretics, that symptoms improve rapidly. Symptoms of breathlessness, edema, so the patient feels wonderful. He says, oh, I'm good, I'm fine. But that's part of the story. It's not even 20% of the story. The story now begins. What do you do to make sure this guy does not come back with an admission, doesn't die suddenly at home, and continues to improve? And that is where the new drugs come in. So the guidelines which are coming through for this is what should we do for them so that you prevent them from worsening, prevent them from coming back into hospital. And that is to add drugs here between the ward and early post-discharge. So he's in ICU, you're giving him his diuretics, he'll feel better. The moment you want to shift him to the ward, start newer drugs, which are RAS inhibitors, beta blockers. Now you're going to come and say, Dr. Sab, this guy's in heart failure, you want us to give a beta blocker? Yes, you want to give him beta blocker, because that works for them. It slows the heart down, allows better filling. They do it. Start with low dose. I'm not saying you want to start beta blocker 25 twice a day, day 1. No. Start with Ramiptal, sorry, not Ramiptal, you're talking of beta-lock. Beta-lock, 3.25 milligrams, 6.25 milligrams, once, twice a day. Start the dose. It's going to take days and weeks to build the dose up. They're going to crash if you go up. The same thing applies to other newer drugs, RAS inhibitors. First it was Ramiptal, ARBs, now of course it's ARNI which has come in. Ramiptal to be is like, something that I've always felt it kind of missed the boat. I remember doing the study on Ramiptal. In 92, we published a study which we sent patients with Ramiptal 5 milligrams twice a day, top dose Ramiptal, within 5 days of admission. That fast for the dose titration. It was not months, which is for chronic heart failure. Within 5 days, they were home on 5 milligrams of Ramiptal, but some of that got missed out. That peri-discharge phase never got the importance that it should have, and that never got used. But the question is, the data was there. If you go back, it's there. So early initiation, low dose if you want to, but a rapid titration for these patients will get you to doses within a few weeks. And that's what you want to do for all the drugs. So you have ambulatory care, which is there, hospitalization, emergency department come in, start moving them around, and then start looking at things. So what are you wanting to do? First of all, you want to use the 4 pillars of heart failure which are there, which are beta blockers, ACE, ARNI, MRAs, and SGLT2 inhibitors. They're all there. It's all coming in. Start up-titrating the dose to begin with as soon as possible. The patient is in front of you. You're monitoring him. You're looking at his blood pressure. You're looking at his creatinine. You're looking at his potassium. So you're monitoring. So you're going to titrate based on the results of it. Introduce new therapies. ARNI and all that comes in now, SGLT2 inhibitor. And of course, more important, the evidence-based approach to other comorbidities, diabetes, hypertension, etc. Now, this is the reason why we need to do it. Once you start these doses, then at the next follow-up visit, which in my case, I believe they should be back to you within 1 week of discharge, not 15 days, not 20 days. Because for heart failure, you need to get See them regularly because hemodynamics is important, blood pressure is important, creatinine is important. And then based on those reports, you can titrate the dose upward. Otherwise, what happens? Oh, come see me after 1 month, boat's lost. All the problems that are going to occur in the first 1 month will occur irrespective of what you have. So you really need to get that doses in early and rapidly titrate. And what can we achieve? That's important. A 59% reduction in 1 year mortality and heart failure hospital. That's what you can do. You can more than halve this issue. And I think being in the hospital is a very good opportunity for us to initiate the therapy. None of your patients are going to go on top doses within 5 days of admitting in the hospital, no. But within the next 10, 15 days, you will get them onto the top doses, provided you follow a method which allows you to do that. Now, why do patients get readmitted? I think the commonest reason is suboptimal treatment. There may be some disease progression, but predominantly what happens is diuretics remain the mainstay in over 95% of it. And that's it. If you look at beta blockers, look at ACE, look at ARB, optimal therapy is there in less than 20% of patients at the time of discharge. So we are not doing a good job of managing patients. So we need to buckle up and start saying, let's do something which we can. And why is it important? Because if you look at this graph, mortality is directly related to whether you've got all the drugs that you want in the doses that you require as soon rather than suboptimal. It reflects directly on mortality. Other way to look at this is that you can influence mortality by appropriately dosing these patients and treating them. So risk of hospitalization I've already mentioned. And the recommendations from all the societies, whether ACC, ESC, AHAs, start early, titrate early, if you want to start reducing mortality. And you might need the help of a lot more people than just yourself. Nurse practitioner, physiotherapist, dietitian, etc. So, looking at this question, another question. What all do you think you would recommend for a patient who comes in with heart failure and be ready for discharge during hospitalization? ACE, ARB, ARNI, MRA, beta blockers, SGLT2 inhibitors. I would want all 4. I mean, you could choose between ACE, ARB and ARNI and we'll talk about what. But I think MRA should be on board, beta blocker on board, SGLT2. SGLT2 because the dose is so simple. It's 10 milligrams. No titration required, no major hemodynamic issues. So day 1, patients admit, he's breathless. I just put a SGLT2 on board. It also works like a diuretic, please remember. Gets rid of water along with glucose. So, and you don't have to monitor any dosage. You do not have to look for anything, no hemodynamic compromise. So in that kind of milieu where you're giving intravenous diuretics, you're worried about beta blockers, pressure will fall this way. SGLT2 start, don't wait, don't think about it. MRA, ARNI or ARB, yes, you will want to monitor and see what's happening. Today, with the data that's available to us, ARNI has replaced ACE inhibitors and ARBs. I mean, valsartan is an ARB, so you're giving an ARB along with something else. But it has replaced ACE inhibitors as first line for patients with heart failure, chronic or acute. And these are the guidelines. First line, now let's do, ARNI is more expensive than an ACE or ARB. But if you look at the cost economics of what is happening, particularly in the Western societies, because that data is coming from there, it is far more effective in terms of cost effectiveness to start patients on ARNI as compared to an ACE or ARB. Today, of course, ARNI has gone off patent, so costs will come down. So the effects will actually get better, provided the drug works. Okay. So broad recommendation for most societies is start ARNI as early as possible, which may be day 2 of the patient's admission to heart failure. And this is just a graph showing you what you actually want to do. ACE, ARNI, beta blockers, MRA, SGLT2, and up titrated dose till. So you move from IV diuretics to oral diuretics, then start, now this is controversial, reducing diuretics and adding in ARNI, beta blockers, MRA. So long as you're going to give very high doses of diuretics, furosemide 80 milligrams twice a day or something, you're going to have a tough time titrating doses because the patient will go hyper. So you need to, once the patient decongests, start titrating your diuretics down and up titrating these drugs which actually modify the disease process. And it's a regular thing. For me, To up-titrate to the dose that I want, it takes at least 2 weeks for me to get some semblance of dose that I'm comfortable with before I send the patients home. So this is something that takes time, it takes effort. If your patient is going home, he needs to keep on coming back to you. It's not something that patients like, but I think we need to do that so that you can enforce upon them the importance of getting the doses right. And when you see them afterwards, you realize that what a wonderful thing that's happened to you. So what's the impact now? Let's look at NT-proBNP, a marker of congestion. This is patients who have not had any ACE-ARB. The black thing is enalapril, the yellow one is ARNI, and you can see that there is a sustained early rapid recursion in NT-proBNP. Started early, and within 1 week you actually start seeing a fall, which continues. Now in people who've already been on ACE-ARB, and you initiated this drug in addition to stopping that, the fall still remains fairly significant. So you have a 28-30% fall in NT-proBNP rapidly. The other thing that you notice is those patients in this trial who were on enalapril, when they were discontinued and started on ARNI, there was a further sustained reduction in NT-proBNP. So there was a much better hemodynamic response to ARNI as compared to enalapril in this particular study, suggesting that you're decongesting the patients faster, and they are responding by decreasing the NT-proBNP. What was NIH status? Most patients admitted to hospital will be 3 or 4. But by the time they are ready for discharge, they move up the scale pretty rapidly. I mean, it may be the fact that decongestions happen, but generally you find a lot of patients will get to class 2 very quickly. So you see a symptomatic response to what you're trying to do. What about edema and dyspnea? Sustained reduction in both with ARNI as compared to anything else. What about further risk of CV death or after discharge? 42% reduction. And please look here, down here. The benefit starts at 14 days. It doesn't take long. 14 days after initial treatment, you will actually start seeing the benefit, and the curves then continue to just diverge all the time. So by the time you are 56 days of admission, there is a 42% reduction in mortality in patients on ARNI as compared to an ACE inhibitor. So clearly, that's the drug you want to give in the doses that you want to give. Rehospitalization, same story, consistent reduction in rehospitalization. What about CV death? Again, 46% reduction in CV death on ARNI as compared to enalapril in this particular case. What about composite endpoints which include everything, hypotension, hypo everything? 48%. Again, a sustained reduction. So you're basically effectively halving the risk for the patient by being aggressive early. That's important. And irrespective of what was given to the patient, whether they received an ACE inhibitor earlier, they received a standalone ARB earlier, and then got shifted to ARNI, the benefit across the board remains consistently in favor of ARNI. So that's the reason why ARNI has actually become the drug of choice in terms of management of heart failure. So I'll just close my talk with this one particular slide. It's way out of bounds of what I'm supposed to speak, but this is data from Paradise trial, which looked at the impact of starting ARNI in patients with heart failure and had repeated echoes done over a period of 6 months and 1 year. What you see, which was a surprise to most of us really, we never thought, there is a sustained improvement in left ventricular ejection fraction in 30 to 40% of cases by 6 months. And by 1 year, 60 to 65% of patients improve their ejection fractions on sustained, consistent doses of ARNI as compared to any other drug, suggesting that you've actually moved their risk. A lot of these patients are at some stage candidates for implantable defibrillator. Today we are seeing with the ejection fraction improving, they cross 30-35%, they're not candidate for ICD. So there is a positive improvement on the patient's underlying status by starting treatment early. The benefit is seen early, of course, in a hospital and immediately post-operative, but this carries on sustained treatment for over a year. Thank you very much for your attention.
Thank you, Dr. Vijan, for an excellent presentation. I'm sure there'll be a lot of questions. Let me ask my question first, and that is, when you're using this combination of ARNI, the valsartan part is a very small dose of valsartan.
Yes.
So in those patients of hypertension, do you add on more valsartan, to this, Arnie?
No, I wouldn't add valsartan to this. If there is hypertension that you need to treat, I would use something else. But I would certainly push Arnie to 200 milligrams twice a day before I think of adding something else. I mean, I am a fan of high dose Arnie to begin with, and I try and push all my patients who can tolerate to 200
You begin
milligrams.
with the 100 milligram dose
I
twice
begin
a
with
day?
50 twice a day, but within a week, if they tolerate it, creatinine is okay, potassium, they'll go to 100 twice a day. In another 10 days, they'll go to 200 twice a day. So it has to be rapid. Some of them will not tolerate, I accept that, and they will remain on the dose that they can tolerate, which would be 100 milligrams twice a day. But we have data now to say that even 50 milligrams twice a day works for the patient. So it's not that by coming down to 50, I'm doing some disservice to the patient. It works. But at 200, the benefit is enormous.
Thank you. Are there any more questions? Good question.
There are 2 or 3 of them. Metoprolol is there, carvedilol is there, and the other one, Concor, is what's the trade name? Bisoprolol. All of them are great. Carvedilol and bisoprolol are number 1 on this for us to use. Metoprolol has now taken a back seat, but these 2. Advantage is small dose, less titration. With bisoprolol, it's 5 milligrams, and that's it. You're done with it. So. No, for us, from the cardiac point of view, whether it's CANA or it's DAPA or it's EMPA, the dose is fixed and it's got to be given. You have to give an SGLT2 inhibitor. You decide in the patient care what you want to give. I would put patient either DAPA or EMPA because a fixed dose for me, 10 milligrams started and that's it. I'm not titrating the dose any further. Yep, yes, it is.
Last question. Yeah, 1 minute. You got Dr. Negluria is going to answer your question.
Thank you for the opportunity. When talking about heart failure, there is data on empagliflozin and dapagliflozin. Canagliflozin, there is no data because if you look at the outcome trials, the cardiovascular benefit was maximally seen in empagliflozin, followed by dapagliflozin. Similar data is not there with canagliflozin.
Please do.
No. Yes, don't change. Correct.
Quality of life improvement, mathematical improvement, everything in heart failure situation. Again, a lot of patients there, they also in active heart failure.
Actually, there's one paper of 230 people, CANA, EMPA, and DAPA, head-to-head. People who had heart failure, sent on either of the 3, randomized, looked at 6 weeks and 3 months. In acute heart failure, they did not find any difference in the outcomes at 30 days, 45 days. So to choose one from the other in somebody who's got acute heart failure, when you choose an SGLT2, and I'm talking about the 100 CANA, the 10 DAPA, and the 25 EMPA. We are talking about the equivalent doses. So there was not one was not, yeah, yes. Correct.
Today now that DAPA is off patent, of course.
Correct.
But EMPA versus DAPA, equal outcome data available, and CANA, no outcome trials are available. So this from primarily of patients is actually a stand level and we talked about. No, these are again there is 10 milligrams dose of 25 milligrams for further sugar reduction.
Yes. You don't need to do that. Correct.
Thank you. Thank you, Vishal, for this kind invitation, and I love to be here for India audience. Unfortunately, this time I'm in a post-lunch session, a very vulnerable period. And I'm going to be talking about post-hospitalization. Thanks to Dr. Suresh Vijayan, you understand what is acute heart failure management in hospital. So I'm talking about post-hospitalization. My patient is just in NYHA class 2. That's what they're telling me to talk on. And post-hospitalization. And there is, what do you think is the, what are you doing, man? Where are you going? Just be on the, no, before this. Yeah. Okay, that's the first slide. No, 1 second. Just, where's the slideshow? This is a slideshow. Okay, I can talk here. The arrow doesn't see the, the mouse doesn't show the, how do I, the pointer is this, so this is what, this I don't need, I can change with this and I can point here, I can only see the pointer, nobody else in the audience can see it, forget it. Chalo. Yeah, so let's get going. So, misperception of the risk. Most of us would think that this patient of mine who is post-hospitalization was in class 3, class 4 symptomatology, got shots of diuretics and got relieved. So, and he is today in NYHA class 2 and being seen at the first follow-up. What is this? This is not my presentation, man. This is not the presentation. I just loaded another presentation, get that back. I want my first slide with the presentation. Sorry, 1 second. Just go to this thing. Where is that man gone? Eric, this is my presentation. That's why I was telling you go to the previous slide. Here it is. So the first question to you was, this patient, what do you think was his risk? Anyway, I already told you that most of us, even cardiologists, go wrong in trying to tell what the risk of this patient who was recently hospitalized and now come for a first follow-up to a cardiologist because he got referred from a peripheral clinic, and what is his risk. Most of us will not perceive the risk well enough. We think that this patient who has been diagnosed to have heart failure some 2 years ago, so who's been diagnosed to have heart failure 2 years ago and was in NYHA class 2, out of the blue got hospitalized 3 weeks ago, and he got hospitalized elsewhere, and then he is currently, as seen at the first follow-up, which is 3 weeks later, he is on ARB for his hypertension presumably, because ARB is not a first choice at what Dr. Suresh Vijayan mentioned. He's on a beta blocker, a diuretic and an MRA. And for his diabetes, he's on metformin, gliptin, sulfonylurea, and for non-obstructive CAD, he was in heart failure 2 years ago and did not have significant obstructive coronary artery disease, implying thereby that an underappreciated part of diabetic disease affecting the heart can be a cardiomyopathy process without really giving significant blockages for our bypass surgeons or for us angioplasters to do anything with it. So this man was 2 years ago diagnosed as non-obstructive CAD, but very well, he's on a statin and an aspirin. So this patient now, his presenting symptoms are what? I'm able to do my duty, daily routine activities. That was one of admission that happened, got relieved with diuretics. Do get breathless sometimes, but I am okay. So this business about I am okay, what about his vitals? Vitals wise, his heart rate is well controlled, like Dr. Vijayan was telling you, on a beta blocker, 1 dose is 74 per minute. We want them to be less than 70 on the heart rate. Blood pressure is good in the context of recent heart failure, 120 by 80. He is good on the creatinine and potassium. So HbA1c 6.8. So diabetes is also well controlled there, meaning, and his ejection fraction, however, is 35%. His NT-proBNP today, 3 weeks later, is still 1125, and his body weight, BMI, is 27.5. We do not have an idea about his body weight during admission, which is very important, in fact. So he is in this kind of a status. What do you now consider his risk status? Do you want to change his therapy? So what I'm going to try to tell you, he's got only mild symptoms, NYHA class 1, 2 are called mild, and is so-called clinically stable. But this NYHA classification, 1921 when it was introduced, is today a benchmark for all trials. You saw Dr. Suresh Vijan showing before, after ARNI, NYHA class changing, etc. But it is very subjective. No two doctors will agree on that class of NYHA. So also it is not reproducible, right? As also, when it comes to these mild symptomatology patients, you cannot really, it is not good to, it is ambiguous in terms of trying to tell what his prognosis is. And this term about stable heart failure, there is nothing like stable heart failure. It is a wrong way, it's a misnomer when you say stable heart failure. Heart failure is never stable. Unlike coronary artery disease, where we can use these terms unstable angina, or we can say chronic stable coronary artery disease, no, you don't, we abandon the term, this misnomer. You can, it's a contradiction of sorts, right? It's an oxymoron, right? In the sense that it should not be used as a reason to do nothing or change nothing. That's why do not call it stable. Why? Because this same paradigm HF trial with ARNI, among which there were patients with predominantly 70% of the patients so-called mild symptoms, NYHA class 1 or 2, 70% of the patients. And in that particular study, you see a significant 31% had deteriorated in symptoms at 8 months. And 11% patients in the control group exhibited an adverse event. And by and large, that adverse event in 33% of these patients was a first manifestation of death. That's why I'm telling you, to call that NYHA class 2 patient a stable patient is misperception of the risk. Same trial, one of the largest trials till date. You can analyze, sub-analyze it, 8,000 plus patients. That's what we mean by outcome trials, not a few hundreds here and there. And what do you see that the risk of cardiovascular death or hospitalization for heart failure was 46% higher in patients who were recently hospitalized. In the sense that, like our patient, within the first 3 months or up to 6 months, compared to the patients in this heart failure, because it was an ambulatory heart failure patient trial, who had never experienced a hospitalization for heart failure, compared to them, the risk is 46% higher. So to put that into perspective, small wonder then that this post-hospitalization phase, up to first 3 months, is a vulnerable phase, where you expect highest mortality, highest re-hospitalizations, like for instance 25% re-hospitalization within the first 30 days. So our patient is a candidate to get re-hospitalized if it's not euvolemic. Then also his mortality could go up to 10%, as was pointed out by the previous speaker. And this vulnerable phase, just like hospitalization itself was an opportunity to get him onto right treatment, this vulnerable phase where he's come for a first follow-up is also an opportunity to change, to identify his risk, as also to change therapies. So what treatment he was on is not good enough. Mind you, in spite of good treatment also, heart failure, in so-called perceived good treatment, heart failure is a progressive disease with increased risk of both hospitalization and mortality. The red graph in the middle is what heart failure, natural cause of a heart failure patient is, punctuated by these downs that you see. Those are worsening heart failure events, not necessarily always hospitalized, but each hospitalization, after each hospitalization, you look at the trough. And then when he goes back to the peak again, he's never back to the pre-hospitalization status in terms of his symptomatology or in terms of his risk. And that is going to be a downhill course. That's why we can predict the cumulative mortality for this patient. Worse prognosis than cancer. And we don't pay much attention unless we treat this. And when we treat this with modern treatment today, and better treatment modalities available, that's where the future is going to be. Very little punctuations happening and a better course for the patient. That's what we are talking about. Indian data, he's already alluded to the Trivandrum Heart Failure Registry, one of the largest database of in-hospital heart failure patients. 1 out of every 3 patients gets readmitted at least once over the next 1 year. That's what they found. Not only that, a cumulative mortality, the same patient data group, when they see in-hospital mortality in Indian scenario going up to 10% and 3-year cumulative mortality going to almost 50%, 46%. So what happens with this repeated hospitalization? You don't want to, these elderly people don't necessarily want to live long. They want quality of life. You need to add life to their years rather than years to life. And what happens here, that the quality of life also in this Alberta study from USA, okay, Alberta heart failure study, they measure quality of life on the basis of what their activities of 10 different activities of daily living, which the patient scores. And mind you, he may be on a placebo or the drug proper. And even a 5-point increase on treatment is said to be very good. But what do you see? Repeated hospitalization, the quality of life as assessed by the Kansas City Cardiomyopathy Questionnaire, in 32% of the patient it goes down by more than or equal to 5 points. And what is the cause for these readmissions? By and large, the pathophysiology is what? For this early readmission. It is a patient who continues to exhibit. So it was my duty to see to that this patient, when he came for his first follow-up, even 3 weeks later, he is euvolemic. He's not still congested. I'm okay, but I still do get breathless. So that is what will determine how much diuresis you need to give this guy or otherwise. And that is one of the commonest reasons for decompensation. Other reasons for decompensation is incomplete recovery and acute illness like a COVID, for instance, precipitated. He's still got respiratory infection going on. And that's why he's come for readmission. Or he's so deconditioned due to the long admission, 15 days in hospital, that is the other reason. Poor social support, that's extremely important. These people require tender loving care along with the family there to look after him, to monitor him closely. His body weight, every day morning his body weight ought to be taken, plus they do their own blood pressure and heart rate measurements. That's important. And of course, repeated renal function and natriuretic peptide plasma levels. But yet, despite all these guidelines, even in the Trivandrum heart failure registry, in hospital registry, 75% of the patients were not in receipt of good GDMT. And the same we found. I had the fortune of being a chairperson for this collaboration that we did with the American College of Cardiology. And we took about 10 to 15 centers from the country, all cardiology practices, mind you. And we had a database, a huge one marked in red there, 75,000 plus patients as a database. And we were just looking at their outpatient data record. And what did we find? 15,000 patients had an EF less than 40%. So common teaching, guideline teaching tells us what? They have to be on a beta blocker and or AC inhibitor at least. So we just look at receipt of beta blocker or an AC inhibitor in this patient, and we didn't know why they didn't receive. But about 2/3 of them did not receive a beta blocker or an AC inhibitor with an LVEF less than. They are not necessarily all in stage C heart failure. They are the ones who are stage A or B, whatever it be, and yet stage B more likely, right? And they are not in receipt of beta blocker. Only about 30% to 35%, either one beta blocker or an AC inhibitor or a combination of two. So that is a thing that is happening. So guidelines are there, but guidelines need to be implemented. And as far as my patient is concerned, very recent, from 2023, Heart Failure Association of European Society of Cardiology is giving us recommendations about what to do. 3 key recommendations for any patient who's come with a follow-up following an hospitalization, whether there is relief of congestion or otherwise relieve his congestion, optimize his GDMT, and a regular follow-up. By regular follow-up, we mean the first follow-up. First follow-up in the guidelines, here highlighted in the European guidelines, has to be 1 to 2 weeks. So as a default, every heart failure patient who's gotten admitted for care should be for a follow-up within a week to 2 weeks. Week to 10 days is a good thing, and he should have had your appointment done, for the consultant's appointment, to see what is his level of congestion, whether he is tolerating the drugs or there is a need to up-titrate evidence-based therapy. Or otherwise, during the admission, as Dr. Vijan was telling us, blood pressure on the borderline, GDMT, all of these good medications are going to drop your pressure, and you have omitted it. And he's gone home only on so-called diuretics, or usual suspect. This guy man had some coronary artery disease sometime, so he will get some nicorandil, he'll get some calcium antagonist being continued because he had coronary artery disease. All these are non-disease modifying drugs, and these need to be got out in order to make room for drugs like ARNI. So our patient, who is still only on a ARB, he was on a telmisartan 40 milligram dose. And what do we mean by GDMT? These are all medicines which are life-saving, survival-enhancing medicines. These 4 pillars, remember these 4 pillars. And SGLT, again, evidence-based ones. As far as beta blocker is concerned, 3 beta blockers which have outcome trials with it, which Dr. Vijan told you about. SGLT2 inhibitors, we discussed about it. And the new kids on the block, ARNI and SGLT2 inhibitor, he is on neither of these. So he obviously needs to be started on these. And it does not matter in what sequence you do it. By and large, most of us will begin with ARNI, given that the comparator arm in the ARNI trial was, so long as you get 4 drugs within 4 weeks on board in at least the lowest possible doses, you are fine. And then up-titrate them as and how you can. So why this ARNI first approach? That's important to know. That there is today, no, they started, when they did the trial, because ARNI had failed in an earlier trial, there is no biological plausibility there to start with an ACE-ARB and then switch to ARNI. Or for that matter, going to ARNI, there is enough data today, is well tolerated. You need not even use an ACE or ARB, ACE inhibitor or an ARB. The benefit of ARNI, as Dr. Vijan pointed out, appears very early in trials, and you want to get the early benefit. You want more dividends on what you invest into. And waiting for failure of ACE-ARB and then to start ARNI is exactly what we are trying to prevent. So that's what it is. And this is one trial, though it is done in an acute heart failure setting, but goes into the post-discharge phase. That's what I mean by early rapid up-titration. It's only theoretical, all this while people were talking about it. 1,000 plus patients in this trial, 1,200 odd screened. And what do you see? There was a high intensity arm where they started all 3. Herein, there is no SGLT2 inhibitor there. There was either a RAS blocker or an ARNI or beta blocker or an MRA, started early in drug-naive patients and started at half the optimal dose. Imagine starting for a patient of acute heart failure with an 100 milligram BID of ARNI and not a 50 milligram half BID homeopathic dose. They started with that kind of a dose, and the trial had to be prematurely halted. Why? Because the rapid up-titration arm did way too better. Okay, both the primary endpoints as well as the secondary endpoints also not shown on the slide. It was safe. So hashtag for a Twitterati out here, hashtag GDMT works, rapid GDMT works and is safe. That's what is the message out of strong heart failure trial. And so, but if you see the up-titration here, you see that there are 4 follow-ups within 6 weeks. And they are all been, like at the bottom of the slide, they are all being monitored for everything, vitals as well as this thing. So if you can do that, you can do it. Now, 2 impediments to starting ARNI are what? Hypotension and your change in renal function. So a couple of slides on this.
PEP or it's HFrEF, the prognosis is the same. And the second thing I think you should emphasize, I like that emphasis on forget the blood pressure, keep up the ARNI.
Absolutely.
I think those are the two important points.
In fact, paradoxically, I have seen in my patients that the blood pressure actually on follow-ups improve. And if you have a walk-in patient, they're 80 to 90 also. They're not dizzy, they're fine, they're good on the pulse volume. Rather than the blood pressure, go at the perfusion pressure. They're passing everything good. ARNI needs to be up.
I tell my residents, if the guy is not too giddy, that means his brain is functioning. If he has no angina, his heart is functioning.
Yeah.
If he's peeing properly, his kidneys are functioning. Don't bother about the pressure.
Absolutely.
Yeah.
Sir, we learnt it from you. I was your student.
the doctor is functioning well.
Once upon a time, you took lectures for us.
Aren't you tired of asking questions?
Sir, this is regarding...
He is a date. He is a date. I have to answer date Saab's questions.
So this is regarding upgradation and also the hypotension part of it. Now, if the patient happens to be also a dipper at night, most probably, and if he has an enlarged prostate, he will rush to the toilet, and what he will have is postural hypotension, in which case he has giddiness and he will have fracture of the femur, and all these therapies will be forgotten.
Dipping business, we worry about for hypertensives here.
No.
When you are doing
postural
this
hypotension
man
is a common
90
thing.
through the day, what dip is going to do what for him? We're not worried about that.
Postural hypotension is a problem with any hypertensive drug.
Yeah, because ARNI and postural hypertension, it's an art of how you go about, not only ARNI, all the other drugs. Every drug is going to drop your blood pressure. How you go about it, it's an art.
Thank you, Dr. Kelkar. Brilliant presentation. May I ask Dr. Niglu to make his presentation? And he's going to tell us the choice of best and safest insulin therapies.
Thank you very much for the kind introduction. Thank you, Dr. Gupta, for the invitation. And we've been using insulin for the last 100 years. And it's one molecule which has undergone a lot of change, a lot of metamorphosis. And now we have so many types of insulins available. That's why we need to choose the best and the safest insulin for therapeutic regimen as in 224-24. So we know that there are a lot of parameters of how to gauge the patient's control of diabetes. We all the time used A1C, fasting, and PP sugar. Now there are more metrics to see how the patient is well controlled or not. One of them is time in range, which now most of us use it routinely, and also the glycemic variability. These two parameters do contribute to the outcome of these patients, probably because of the microvascular and even some macrovascular outcome are obvious if you have a drop in time in range by 10%. And what's interesting is that it gives you a very smooth control with glargine 300, especially because it produces dense microprecipitate in the subcutaneous tissue, and therefore it allows quite a bit of flexibility in the adjustment of the dose. You don't have to give exactly at the same time. You have a levy of 3 hours before or later, and of course been shown in many trials that it is not inferior to U100 degludec. So therefore there are a lot of benefits that we have now with the newer insulins that we can use routinely our patient. As I mentioned earlier, the glycemic variability is one of the important parameters we need to study in patient, because in the past it was believed that it's only useful in the ICU setup, but even in the outdoor patient setting also it has an impact to see what are the possible complications, especially on the endothelium, that you get with glycemic variability. And we know that the excessive glycemic variability and the subnormal or suboptimal time in range has definitely impact on the outcome of patients of diabetes. And therefore, most international guidelines now have included that time in range and of course variability should be studied when you look at the patients, especially when the control of diabetes is very important, either in type 1 diabetic patients or those who got comorbid conditions like chronic kidney disease or obesity or ischemic heart disease. This is a very important parameter one has to know. So when you look at this particular parameter or this particular graph that you see on time in range, and most of you are familiar with this, this is what it gives you a lot of metrics like time in the range, below the range, above the range, and of course glycemic variability. And you have a graph which shows on the right hand side, and it shows that what is the central line is the median line, and we have the 50% target that you see above and below that line is called an interquartile line, and the still above that gray shaded area tells you about what is the variability that you get of glucose either in the day or within the day or between 2 days. So inter-day and intra-day variability can be calculated by using these parameters, and therefore we get a lot of wealth of information when you look at these particular graph to see what is happening to the patient's blood glucose. And this is what is recommended by the ATD 2019 guideline, that any patients of type 1 or type 2 diabetes, the time in range should be at least 70% equals to about 16 hours, and 25% should be below, not above the range, and of course the 5% should not be below the range. And if you look at patients who have got comorbid condition, they should be at least 50% in time in range. And in patient in pregnancy, you have to have at least 70% in time in range, but the target value is different here. It is 63 to 140 is the blood sugar range in pregnant population, and especially pregnancy with type 2 diabetes or GDM, you need to have more than 90% time in range, because glycemia is the driver of all the complications of the fetus and of course the congenital anomalies. Therefore, you should be very careful to have this time in range to the tune of 90% in patients of GDM or type 2 diabetes with pregnancy. So as I told you earlier, 10% drop in time in range will get you 60% of the patients having retinopathy, 40% of the patients will get microalbuminuria or nephropathy, 25% will get neuropathies, and 5% have increased cardiovascular morbidity and mortality. So that's how the impact of this time in range, as we say, that there's a height and trough of blood sugar directly hits the endothelium. So it's like a tsunami wave which hits the endothelium and therefore bringing about vascular compromise in patients who have this abnormal time in range and the variability. These are the indications for using time in range in diabetes management, especially in type 1. Of course, we need to use this to assess the requirement of the patient's insulin and also titrate the dose of insulin. Question of type 2 diabetes is also interesting because here a lot of contribution comes in. Patient's diet, the exercise, the gestational diabetes, and of course the post-operative state when you want to have good control of diabetes. This is a very good kind of a parameter which helps the control very immaculately well. In GDM especially, the control should be very accurate, and where this has a very important role. So therefore, time in range is very simple that way, and it's very objective and also has been validated, and therefore the patient is empowered and he knows exactly as to where he lies so far as the control of sugars are concerned. Now let's look at some of these trials which shows the comparison between U100 to U300 in patients of type 1 diabetes. There are 59 patients of type diabetes who have a crossover trial where these patients underwent the hyperglycemic clamp study. And what you see here, the blue line is that of U100 and the green line is that of U300. You obviously see there's a hump when you use U100, and that shows the variability of blood sugar. So therefore, this definitely does peak in so far U100 is concerned, and this peaking is much more common in patients who are lean. The obesity somehow nullifies this effect of peaking of U100. It's very interesting observation, though we don't know the explanation why it happens, but it does happen, and it's very common in Indian patients because most of us have only central obesity. Otherwise, the overall BMI is lower, and you see that the difference is almost 14 milligram in 24 hours. So therefore, you get a smoother control when you use U300 and lower nocturnal hypoglycemia. And all of us know nocturnal hypoglycemia is very dangerous It can cause the prolongation of QT interval. It's the acquired cause of inflammation and can cause sudden death, sudden death in bed, and therefore it can cause abnormalities in the arrhythmias also of the heart. So therefore the nocturnal hypoglycemia is extremely dangerous. Talking about flexibility of the time we need to inject, normally if suppose the patient injects at 9 o'clock, he or she wants to go for a movie, then he can't take it 9 o'clock. There has been some time difference. So 3 hours is now permitted when they use U300. So this is a study which is looking at flexible dosing versus the fixed dosing from the patients of edition 1 and edition 2 trials of type 2 diabetes. And they could get the patient originally at 7.33 was the A1C. And if we looked at the hypoglycemias, either the confirmed hypoglycemia or possibly a possible or a nocturnal hypoglycemia, you see there's no difference whether they use the fixed dosing or whether they use the flexible dosing, suggesting that the flexible dosing does not affect the glycemic control or there is no untoward side effects of hypoglycemia. This is the changeover trial, which is called switching trial, which was switched from U100 to U300. These are 10 patients of diabetes, of 8 were type 1 and 2 were type 2 diabetes, and they only did nocturnal CGM. And what was seen here, you can see obviously, that there is a twofold decrease in the night glycemic variability and also decreased nocturnal glycemic variability. We also talk of variability in the daytime and in nighttime. So as I said earlier, that the nocturnal controlling of sugar is very important because the hypoglycemia occurring at night can be sinistrous. Now let's compare the modern, the basal, analog insulin, who are very well at par to each other, namely U300 and of course degludec 100. So these are the lot of trials. We'll see few of them. And this is one of the first one, which again using a single center randomized trial, which has 45 number of patients. Again, it is a euglycemic clamp study. You can see these two graphs on your slide, and you can see the one that top glass is of the U100 of degludec, and one that lower is the U300. Again, the hump that you see with U100 of degludec suggests that there is a variability of blood sugar. So 20% reduction in the variability is seen when you use the U300 glargine versus U100 degludec. So therefore, this is very important that the variability is much less when you consider this kind of insulin. This is again an independent study, not driven by the pharma industry, and therefore it's very important to realize that there is again hyperglycemic, euglycemic clamp study. And when you see here, the degludec was given at the dose of 0.26 unit per kilogram body weight, and glargine was given as 0.34. We know that glargine requires little higher dose compared to degludec, so it was 0.34 unit per kilogram body weight. And what you see here, there's a 22% increase peak, which can see with degludec, especially occurring at night. So around 2 to 3 p.m., 3 a.m. in the morning, you can see that peak. And you also see that there is lesser variability with glargine 300 in the next graph, showing that 23% reduction in this variability. So this has been convincingly proven that there is a difference in between these two insulin molecules so far as the variability is concerned. Now this is again in time in range, and this we are talking about type 2 diabetic patients. Here there's a small number of patients, 15 in each, 15 in 300 glargine and 15 in the degludec. And what they looked at time in range. And if you look at the graph on to the left, you can see the time in range is almost normal. But what you carefully see here, that anytime hypoglycemia, nocturnal hypoglycemia is very well seen when you use degludec. So therefore it definitely tends to have that hypoglycemic episode, which is significant statistically. So therefore again, it is not all that same effect, though the efficacy is similar, but the safety wise, it is 300, which is better. Now, this is again another study which looked at again similar problems on looking at nocturnal hypoglycemias. This is the FLASH trial where the patient had these flash monitors of Libre, and they used to flash it at least 8 hourly in these patients. And you can see here the frequency of hypoglycemia occurring in these patients at night. Those who take U100 degludec is higher compared to U300 of glargine. Again, suggesting that the nocturnal variability of hypoglycemia is pretty high when you use U100 degludec. Now, this is the type 1 adult diabetic patient, which is called OneCare trial, which is a quite large trial, though it's a real-world evidence trial, which had almost 100 patients in each group of the either degludec or glargine 300. They were switched this molecule from other kind of basal insulins, and were studied for a period of 24 weeks. And what you see here, in the daytime, the control is fairly good. But in night time, if you look at very carefully in night time, between 70 to 140 and 70 to 180 group of control, you can see the time in range is little better when you use U300 compared to U100. So there's a subtle difference which can be seen, which can be appreciated in these patients, though it's a real world trial. Now coming to the trial with basal plus insulin. Here is a very again interesting trial. What they did was they had collected about 20 patients in this group. First they gave these patients the Rhizodec twice a day and could get the control effectively. And they had the fasting sugars somewhere around 100 to 130 and pre-dinner sugar around 100 to 130. And then they switched these patients subsequently on the basal bolus therapy, which 2 insulins of bolus insulin at breakfast and at dinner, and of course the basal insulin of U300. And this was studied, and what they looked at time in range below 70, how much was it, and below time in range and time below range, and also below range 54. And what you can see here, time in range was 84% when you give 300. It was 73 only, again significant statistically. Looking at hypoglycemia, again it's important that the U300 was safer compared to U100 in terms of hypoglycemia. This is the in-range study. Again, this is a type 1 diabetic study patient. This is number 333 patient in this trial. And here the problem was here the patients were also made to do SMBGs, and also they had the CGM study. And what they did was they gave these patients to begin with the basal insulin to start with, and they could get the fasting sugar controlled around 70 to 100. Once the fasting sugars are controlled, then they were given mealtime insulin, that is a bolus insulin, and they controlled the prandial sugars. And the prandial sugars controlled between 130 to 180. And these patients were studied for a period of 12 weeks, and then they used the CGM to see what is the outcome of these patients. And what you see here, that the primary endpoint was that of the time in range, which should be below 70, above 70, which should be in 70%. And here you can see here that in glargine it was 52% the people had time in range, whereas in degludec it was little higher, but not difference so far as the statistical significance is concerned. And secondary endpoint also was similar about variability between glargine 300 and 100. Again, if you look at the outcome of this trial, this is the first head-to-head comparison between the degludec and the U300 in type 1 diabetes. We had the BRIGHT study which looked at type 2 diabetics. This is the study which looked at type 1 diabetic patient. And we see there's a non-inferiority so far the primary endpoint is concerned, that is time in range. There's a non-inferiority for the glycemic variability concern, that is the secondary endpoint. And the hypoglycemia evidence is similar. So again, this study says that glargine 300 and U100 both are similar so far as the safety and hypoglycemia profiles are concerned. There's a question of being asked quite often in most of the meetings whether glargine is safe in pregnancy. So this is the data which comes from the 44 countries. Actually, this is a poster presentation that first presented at the EASD and subsequently is also presented at the ADA meeting as a poster presentation from the 44 countries to 44 exposures here. And what they saw was there was no much problem to the fetus. There was the insulin does not cross the placental barrier, so it does not really cause problems, and therefore 300 during pregnancy was not associated with any specific adverse events. And a large number of more than 1,000 patient prospective data shows that there is no problem during pregnancy. This was raised initially because the mitotic index when you use the glargine was higher. And because the pregnancy is a stage where there is a lot of multiplication of the cells occur, so there was a concern about using this. But this poster presentation, I think, puts to rest of this controversy of not using the glargine 100 or 300 during pregnancy. So to conclude my talk, ladies and gentlemen, for the last 15 minutes what I spoke about is the variability of glycemia and a suboptimal time in range has a significant impact on the lives of the people with diabetes. Glargine 300 allows a dosing flexibility of 3 hours. You can take 3 hours earlier or 3 hours later, not exactly the same point. And the numerous trials and CGM and TIR have demonstrated that Glargine 300 provides effective sustained glycemic control and lowers the incidence of variability and also lowers the nocturnal hypoglycemia, which is a bad sign. And the use of Glargine 300 associated with the lower incidence of overall nocturnal hypoglycemia. With that, I conclude my talk. Thank you very much, Gupta sir, for inviting me for this talk. Thank you very much.
Thank you so much, Dr. Neglu. Any questions? Wow, that is no response from you. Thank you.
You're exhausted of asking questions or you don't want to ask questions?
Actually, I had gone out.
You can ask.
All right.
Let him ask one question.
What are we going to do? Are we waiting for Dr. Pariwala? Here, Dr. Pariwala comes. Right.
Sir, after how much ECFR can you continue Glargine 100?
You can continue any dose. There is no problems of the continuation dose. You have to be careful about hypoglycemia because the insulin is cleared by the kidney and the proximal tubule and the proteins are broken down, they taken to the pool. The only risk of hypoglycemia is there, which is much less when you use Glargine 300 compared to Degludec because Degludec has a binding to the protein. And if the proteins are less in patients of renal failure or nephropathy, then a lot of drug is free. So risk of hypo is a little higher. And this was also proven in BRIGHT study. When a BRIGHT study of the kidney subset the patients were studied, they looked at this aspect very carefully of hypoglycemia occurring with Degludec versus the U300. So this was observed in that BRIGHT study.
Right. So thank you.
Sir,
Anyone else? That is now too late now. Now you ask the next speaker question,
Okay,
right? Thank you, Dr. Neglu. Right. The next speaker is Dr. Patiwala, my old friend and colleague. He is going to talk on optimizing A1C without causing harm. Best insulin therapy guidelines. Dr. Padiwala is currently works at the Wockhardt Hospital. He's been a postgraduate teacher for DNB, principal investigator in many trials, has many papers and publications to his credit, and many medals and gold medals at the resident level. Dr. Padiwala, please.
Yeah. Thank you very much, Altaf. I don't know how many of you know that Dr. Altaf Patel was the assistant honorary when I was a registrar. He was a locum assistant honorary. And our association goes back to 1980s. Thank you. So today I'm going to be talking about optimizing A1C without causing harm. You know, when you optimize A1C, invariably what happens is you'll end up with weight gain and you'll end up with hypoglycemia. How do you avoid all this? Primarily, what you have to understand is the insulin paradox. When we initiate insulin, why do we tend to fail? Why is it that after starting insulin, we never seem to be meeting our A1C targets? And I'll show you statistics to prove that later on. That primarily occurs because of this hypoglycemia risk and the fear of weight gain that most of the physicians have. And the second thing as to why we fail in the insulin paradox is that you do not intensify insulin therapy. If you do not intensify insulin therapy, there is no way that you're going to meet your A1C goals. So why are we initiating insulin to fail? We must understand that. Are you aware of this statistic that 86% of patients who take oral antidiabetics and insulin do not meet their A1C targets? 86%. And 79% of patients who are only on insulin do not meet their A1C targets. That speaks a lot, not for the patient, but for us, that we are not managing the patients properly, or that at least we are not managing the patient's insulin properly. Why is that? Why is it that they are not, why is it that the A1C is not getting into target? Is it because of the progression of type 2 diabetes? Or is it because of an increase in the comorbid conditions that these patients have. That is something that we need to understand. But the bottom line is that despite insulin therapy, you do not have the desired glycemic control, which should be routinely achieved. What is important is that your initiation period is what predicts long-term outcomes in the maintenance period. What I mean is the first 12 weeks is defined as the initiation period of therapy, where 80% of the maximum treatment effect, the maximum treatment effect basically means the A1C reduction. 80% of your A1C reduction occurs in the first 12 weeks following initiation. And after that, it is only maintenance therapy. So early response in that 12-week period predicts what is going to happen in future, whether the patient is going to control or whether he's not going to control. Unfortunately, if you get hypoglycemia during this initiation period, then it doubles the risk of the patient getting hypoglycemia later. And what is a double whammy is that if you get a hypoglycemia during the initiation period, it increases the risk of discontinuation of therapy by almost 50%. And I've seen this personally. Patients get so scared of hypoglycemia because it's something that they cannot do anything about. And when they get hypoglycemia, it's almost invariably that he's either going to stop it or he's not going to increase his insulin dose. Remember, the key to successful management of high glycemic control is adequate titration. And 30 to 50% of type 2 patients remain uncontrolled 6 months after the initiation of therapy, which speaks a lot for us, that we are so diffident in doing adequate titration. That is something which is extremely important. So, you know, the first 12 weeks after basal insulin initiation is the titration period. Internationally recognized that, because that is the titration period which is defined as a time frame of 12 weeks after initiation of treatment, when either you switch on treatment or when you switch from some other treatment. Subsequently, of course, it's maintenance period. And you can understand this by this beautiful slide. If you look at it in detail, you'll really understand. With effective titration, 80% of the maximum treatment effect occurs in terms of A1C reduction, of course, within 12 weeks. And that is why you can see that if you look at the dose increase, it is 150% dose increase occurs during the titration period and only 1.4% during the maintenance period. And you can see that per kilogram increase also only during the maintenance period occurs. So that's extremely important for you to understand. The maximum dose increase is going to occur only during the period of initiation. Therefore, in any uncontrolled diabetic patient, to realize the full potential of insulin therapy, it is early initiation with adequate titration, which leads to optimum control and patient satisfaction. That is something that we must understand. Now, if you look at it, you can see this, again, this is a very beautiful cartoon which shows to you that in 3 months, that is 12 weeks, your A1C coming down from 8.7 to 7.2 and subsequently to about 7. This is within 12 weeks of therapy. And once you achieve this, you can see that for the next 2 years, or more than that, 32 months of therapy during the maintenance period, the A1C remains constant with very little dose adjustment. All the dose adjustment has been done during the initial period. And that is borne out by this slide, isn't it? Which shows you that during the maintenance period, there's very little dose increment that is being utilized. After having understood why we fail initiation of insulin, let's talk a little bit about this bugbear of hypoglycemia and weight gain. How do you prevent it? Primarily, you have to understand that your choice of insulin also matters a little bit. I think Vijay Neglu was speaking ahead of me, and he did mention to you a little bit about time in range, time below range. Time below range obviously means hypoglycemia. More the time below range, more the TBR, the greater the chances of hypoglycemia that the patient has. And if you look at this cartoon over here, you can see glargine 100 vis-a-vis IDEC aspart versus bias 30 and versus a human premix. And you can see that if you look at confirmed hypoglycemia, it is 86% higher with IDEC aspart. If you look at bias 30, you can see that whether you see an A1C below 9 or an A1C above 9, there's a definite reduction in hypoglycemia with glargine 100 vis-a-vis these other molecules. And if you look at human premix, again, there is a lesser risk of overall and nocturnal hypoglycemia. Primarily, that means that your time below range is much less with this molecule as compared to the other insulin. And coincidentally, not coincidentally, ipsi facto, because of this, you also have a lower weight gain because there is less of defensive snacking. That becomes very important. So at 52 weeks, you can see that the weight gain with glargine is much less. Now, if you look at only weight gain, you can see that if you look at bias 30, there's a 35% less weight gain with glargine 100 as compared to bias 30. And if you look at IDEC aspart, it's about 36% less. And this is at 52 weeks of therapy. So that, again, becomes very significant. So your fear of pushing your insulin to achieve your control because you'll get gained weight or you'll get hypoglycemia does not exist when you choose the proper insulin. So once you've understood that, we've understood that there's less of hypoglycemia and there's less of weight gain, how do you intensify insulin therapy? You must understand that at some time or the other, after every basal insulin is initiated, either de novo or on an oral antidiabetic, you still do not achieve A1C levels. Why do you not achieve A1C levels? Primarily because you have some postprandial hypoglycemia peaks, right? This is because there is a decline in the first phase of insulin secretion, and that causes a postprandial hypoglycemia. And this postprandial hypoglycemia makes a significant contribution to overall glycemic exposure, and that is what drives your A1C up. But what is the significance of this postprandial hypoglycemia? Why are we worried? Why are we so worried about this postprandial hypoglycemia? Remember, any attempt to reach an A1C2 target is impossible unless and until you control the postprandial glucose surges. That is extremely important. And remember one thing. Postprandial hypoglycemia is the period when you have the maximum oxidative stress. The body gets the maximum oxidative stress in the period of postprandial hypoglycemia. And not only that, but clinical and epidemiological studies have shown and indicated that postprandial hypoglycemia is a direct risk factor for coronary and cerebrovascular disease. Therefore, when you have postprandial hypoglycemia, you are driving CVD. So which is the physiological way to intensify insulin therapy? You have to have something which closely mimics normal pancreatic insulin secretion. Remember, what do basal insulins do? Basal insulin just give you the basal insulin requirement which is necessary. And that prevents the hepatic glucose output which occurs in between meals and that occurs during your fasting at night. The prandial insulins, on the other hand, control postprandial glycemic surges, and that is what is important. So when you look at the advantage of a basal prandial intensification, what it does basically is it mitigates the postprandial glucose surges, there are fewer hypoglycemic episodes, and obviously because of that, lower weight gain. You can titrate both the prandial and you can titrate the basal insulin. It is relatively very user-friendly once you get used to it, and it can be a stepwise approach to treatment. So, we know that, we have already mentioned that the basal insulin concept is usually started after OAD failure. The starting dose is between 0.2 to 0.3 units per kilogram body weight, can be titrated up. But what is over-basalization? Over-basalization is where your basal insulin requirement goes to more than 0.5 units per kilogram body weight. Beyond that, no matter what you even see, you have over-basalized the patient. Don't go beyond 0.5. And that is where you get a basal plus or a basal bolus insulin concept, which I think Vijay Neglur was alluding to in some of his slides. Here you have two components. You have the basal component plus a bolus, or a basal component plus various boluses. The basal gives you a constant background level, and the bolus covers the meal-inspired spikes of postprandial blood sugar. Now, when you want to optimize after basal insulinization, how do you intensify? Either you add a prandial insulin or you switch to a premixed insulin. And this is so beautiful. If you really look at this and you study it, this slide is really good. Look at this. If you give a prandial insulin at the peak postprandial level, more or less your target is met. One basal insulin and one bolus insulin at the peak postprandial level. And 85% of your patients meet the A1C targets. That is something which is extremely important. So a basal plus insulin is, you have greater flexibility with a basal plus insulin, and you have greater and higher treatment satisfaction. If you use a premixed insulin, that whichever it may be, a 25-75, a 30-70, or a 50-50, they usually give you higher rates of hypoglycemia, and they're less flexible. If a patient has a variable lifestyle, it is this very inflexibility. Target on the right, you have event rates of hypoglycemia. And you can see that the hypoglycemia is more with the premixed insulin than with the basal plus. That's very simple, because it's easier to titrate when you have a basal plus regime rather than a fixed dose regime. Now, what are the bolus insulins which are available? We've talked now that you give a basal insulin and you give a prandial insulin. What are the prandial insulins that we have? You can have a rapid-acting insulin, or you can have a regular human insulin. What is the difference between the two? A rapid-acting insulin is an analog insulin. It is more rapid-acting, and it is short-lasting. So if you give that, you prevent postprandial hypoglycemia, because the action doesn't last for 6 hours. After the start of a meal, an analog insulin. Therefore, it is better than regular human insulin, and it has lesser variability. If you look at human insulin, it's less rapid-acting, lasts for about 6 hours. It causes more postprandial hypoglycemia, obviously leading to an increased susceptibility to hypoglycemia. It requires a waiting time. You have to give it 30 minutes prior to an injection. And in any busy ward, that is something which is very difficult to achieve. As anybody who has worked in the hospital will tell you, 2 nurses going around to give injection to 15 patients is going to be damn difficult. By the time the last patient gets insulin, it is 40 minutes or 50 minutes. There is less consistency with different anatomical sites with regular human insulin. And obviously, there is more variability. So if you look at a rapid-acting insulin, an analog insulin, when you add it to a basal insulin therapy, it gives you perhaps the largest window. If you look at the bottom, you can see the various rapid-acting insulin which are available. Glulisine, aspart, Lispro, and the newer aspart or the Fiasp. And you can see that you can give glulisine 15 minutes before a meal, you can give aspart 5 to 10 minutes, Lispro 15 minutes, and newer aspart you can even give it 2 minutes before the meal, which is fantastic. It obviates the nurse running around. After the start of a meal, only glulisine and the newer aspart you can give after the meal for 20 minutes. But look at the total window period in which you have to give. It's 35 minutes for glulisine and about 22 to 25 minutes with Fiasp or faster aspart. So what are the guidelines or the recommendations which the ADA and the American Association of Clinical Endocrinologists or the American Clinical Endocrinological Society give you? It's very simple. When you start off with the basal insulin, they recommend that when you do not meet your targets, you can give the prandial insulin at the time which is the highest peak. If 1 plus 1 doesn't work, then you can add a basal plus 2 prandial. If that doesn't work, then you go to a full basal bolus regime. And that is how you achieve your A1C. Trials where it has been used de novo. Even at a high A1C of more than 9.5%, glargine 100 is effective and well tolerated, especially in insulin-naive Indian patients with type 2 diabetes, with a low risk of hypoglycemia and weight gain. And it has emerged over the course of time. I mean, I remember having used this insulin for the most 10 to 15 years. An 86% higher rate of overall confirmed hypoglycemia can occur with some of the newer basal insulins as compared to glargine 100. And the titration period during which you adjust the dose of insulin predicts a long-term prognosis in the control of the patient's A1C. And glargine 100 intensification is associated with the lower risk of nocturnal hypoglycemia versus premixed insulin. Thank you very much.
Thank you, Behram, for that very illuminating talk. Are there any questions, Dr. Date?
Yes, of course,
okay.
Yes.
First question to you.
Yes, Dr. Date, I know. Somebody give him a mic, please.
No, it's
you have it, huh? It's kept with you only.
Yeah. Sir, with the advent of the newer insulin pumps,
yeah,
which have a dual injection system,
yes,
wherein you can give insulin when the patient.
Which article are you reading out from?
Sir, I will discuss this with Dr. Venkatesh from KM. You know him, perhaps.
Yeah.
So, this is a newer insulin pump, by which you can inject insulin when the patient is having hyperglycemia, and you can inject glucagon when he is having hypoglycemia. And you can set your thresholds. In fact, this can be used in practically every situation, including brittle diabetes. Because you have set your threshold. If the pumps behave as they are meant to be, and if the government of India reduces the cost price of these pumps, and also the pharma people cooperate, then this would be the ideal solution for hypoglycemias.
I think that's a very good comment that you made. Insulin pumps in any brittle diabetic are the way to go forward. I think even Vishal, you will accept that. And when you have these insulin with a loop system, where they have a built-in sensor which recognizes hypoglycemia and stops injecting, the question of hypoglycemia doesn't arise, because these are intelligent pumps, which so-called augmented intelligence, augmented reality, right? So that if you do not have hypoglycemia, the question of getting glucagon doesn't arise.
No, but glucagon that way is safe, sir.
I accept. In the rare cases where perhaps it would fail and you would get hypoglycemia, glucagon being present would help. I accept that.
That would be the safest.
Yeah.
With that would be the end of these conferences for diabetes, which is better and what is not better. If they had that, then the question does not arise of anything else. No?
I think Altaf, somebody has a question there.
Yeah.
Sorry?
Benefits of the Degludec
IDEC, yeah? So I just showed you some data. We have somebody sitting over here from Novovesi. Oh, he's gone. Oh, he's there. He's there. Narveka is there. Look, it's this way. If you look at Indea, degludec, they found that in the initiation, you have less hypoglycemia with glargine 100, glargine 300. During the long-term period, you have less hypoglycemia with degludec, right? The choice is yours. It's not to say that I do not use. I use degludec also, right? If you use it judiciously, there's absolutely no problem.
Okay, any more comments?
Date, we'll talk. If you want, we'll talk outside. You have to stick to time, beta. There's somebody else following me.
Okay. So now your question outside with Padiwala. All right. I think the next speaker is online, Professor Seshadri, who is going to talk on ultra-fast-acting insulin analogs versus short-acting insulin analogs, and he's going to give us an update from that. I think he's online. Yes? Fine. And he's a senior consultant endocrinologist in diabetes and Apollo Hospital, Greaves Road, Chennai, and senior clinical and research lead Apollo scholar. He has several orations to his credit, recipient of several awards, and he got the Sam G. Moses oration by the Research Society for the Study of Diabetes in India in 2014. He has research interests across a great spectrum of diabetics. Dr. Seshadri, your talk, please.
Thank you. So, are you someone controlling my slides? Because from there, or can I just share mine? Oh. Is somebody going to move the slides?
Yes, sir.
Okay. So please note my conflicts of interest. I have a commercial relationship with the organization that's sponsoring this particular talk. Can we have the next slide, please? Okay, let's talk about the following. One is the importance of postprandial glucose in patients with diabetes. We look at the gaps in the postprandial mealtime flexibility in prandial insulin dosing, time and range monitoring diabetes and how it ties to this, and then we will look at ultra-rapid acting Rispro, its pharmacology, the evidence in 1 and 2 diabetes, and then we will close this and maybe take questions. Next slide. Next slide. So this is something that we all talk about, and we especially remember that in India there is a higher prandial component because of the carbs, because of the way we eat, because of our glycemic load. And interestingly, if you look at Monier's study, it would show that at the highest end, the fasting contributes to the A1C. At the lowest end, the prandial contributes to the A1C. But if you look at the Indian subjects, you will realize that there's an equal, or the Asian subjects, in fact, this is done in East Asia, that there is an equal contribution of prandial to A1C at both ends of the spectrum, right? And therefore, earlier attainment of postprandial targets is essential for the earlier attainment of A1C. And therefore, when treating patients in India, and especially if the spread between the prandial and the fasting glucose is more than 60 to 80, then even starting off with a prandial insulin seems to be a very, very useful strategy in diabetes. Postprandial glucose is a strong association with micro as well as macrovascular complications. So let's take this forward. Next slide. Right. So the postprandial state is something that we really want to get a recap of. Remember that the glucose levels rise about 10 minutes after the start of a meal. Remember that insulin starts rising as you start thinking about a meal, right? Then the peak is around 1 hour. So not the 2 hours that we talk about. The peak of glucose is about 1 hour. They return to a prandial state by about 3 hours. The carbohydrate absorption persists for 5 to 6 hours, but slows down over a period of time. And essentially, by controlling the glycemic state through the prandials is very, very essential. Insulins that have been available so far have a later peak. The prandial insulins peak around 1.5 to 2 hours. So insulins with earlier peak that come in, do their work and leave, while there is a basal insulin that keeps throughout. is something that people have been talking out for years, meaning can we have insulin that matches the physiologic secretion that occurs in the pancreas? Next slide. Right. So, what is the ideal prandial insulin? One, it should mimic the endogenous insulin secretion. It should match the insulin absorption and action to food as related to the glucose. And it should match the carbohydrate intake. And especially when we, in our this thing, when the glycemic load is high, it should have a fast absorption, it should have a rapid onset, and it should leave as fast as it comes, because the longer it lingers, the longer is the risk of hyperglycemia, right? So what are the rapid-acting insulins? They are developed to increase the insulin absorption and have a later onset of actions versus the regular human insulin. Remember, regular human insulins have actions up to 6 hours, and their peak doesn't even start less than 2 hours. They provide optimal postprandial control versus regular human insulin. Where do they fall short? The onset of action does not match the carbohydrate absorption, resulting in limited postprandial control. The PKPD does not mimic the physiologic post-meal insulin secretion patterns of healthy subjects. So you really want it to be earlier onset, rapid deterioration, and exit. Next slide. So, the expert recommendations for insulins regarding postprandial insulin, one is that rapid-acting insulins are preferred over regular human insulin due to lesser risk of hypoglycemia and greater mealtime flexibility. For example, you really don't have to, with the rapid-acting insulin, to dose, then wait for some time, and then eat. You can take it wherever you go. Eat and dose is something that is very, very useful with rapid-acting insulins. Now we have ultra-fast acting insulins. They more closely mimic physiological mealtime insulins than even the available rapid-acting insulin. And of course, an expert consensus is that ultra-fasting acting insulins are better suited for Indian patients with high postprandial excursions. Remember, a grade A is backed by high level of evidence. Next slide. So what are the so why is mealtime flexibility in prandial insulin dosing required? So let's look at this carefully. Next slide. Right. So in the real world, there is a big difference between the injection meal intervals and the real world setting. Remember, pre-meal insulins negatively affect lifestyle to a great extent. I told you you have to dose, then you have to wait, and then take insulin. Right? What it does is it restricts people. Many of them don't eat out, or when they do, they skip the insulin, right? And they're worried about postprandial levels after a meal to a large extent. Again, pre-meal dosing is a big issue. So you can't dose and eat. You have to eat. You can't eat and dose. You have to dose and eat. On the other hand, if you're able to eat a dose just before you eat, or maybe even after you eat, that becomes very easy. It gives you flexibility. It can be done right in the dinner table or the lunch table. It can be done in a bathroom if you're going outside. You don't have to wait, order your take the insulin, order your food, and wonder if it'll come before you have a hyperglycemic attack. Next slide. So this is again looking at the timing of meal insulin in younger people with type 1 diabetes, right? It's a type 1 registry. And if you look at this, many of them take 21% take it just before the meal. Some, about 10% take it during the meal, about 44% immediately before meals, and about 24% after the meals. Next slide. So what do we learn? One. So importantly, optimal meal intervals for prandial insulin dosing can minimize postprandial hyperglycemia and also avoid the risk of postprandial hypoglycemia, right? Rapidly acting insulins as well as regular human insulin are affected by this, and therefore either they are too slow or they are too inconvenient. Rapid-acting insulin should ideally be given 15 to 20 minutes before a meal for optimal postprandial control. In the real-world setting, this is often not possible and is a mismatch between the insulin taken and the meal, and therefore a mismatch in the glucose control. Next slide. So let's look at time in range, because that's something that has become very, very important. Next slide. We know that time in range is I would not say it's a more accurate information than HbA1c. It gives more meaning to the HbA1c. And it tells, for example, someone with very high and very low glucoses can have a beautiful A1c. The time in range allows you to quantitate that, right? You really want, but if your A1c, your time in range is around 70% of the time normal, then you know that your A1c is approximately 7%. You really want to be increasing during the time in range, reducing the time above and below the range. Next slide. So what should new prandial insulin do? It should reduce postprandial reduction to the entire postprandial period, as close to a meal ingestion, and its action should last fast and get out. Provide close to the physiological glucose control, ease the patient burden by allowing eating and dosing, and importantly, increase the patient's time and range. Next slide. Next slide, yes. Next slide. So let's look at ultra-rapid acting Lispro. The new insulin that's come to the market in India, it's a novel Lispro formulation. There's two enabling excipients. One is a prostacyclin analog. The second is citrate. The citrate provides an increase in vascular permeability. The prostacyclin analog, what it does is it sort of gives a local vasodilatation without causing the systemic vasodilatation. So what it does is allows the insulin to permeate the capillaries very quickly and gives you rapid absorption. This is a Lispro, which is a rapid-acting insulin that's made into an ultra-rapid-acting insulin by addition of these two excipients that hasten its absorption. Once it enters the bloodstream, because these are monomers, they become they dissociate into monomers and they act very quickly. Next slide. Let's look at the pharmacology. Next slide. You look at this. This is the pharmacokinetics, right? So it's 5.9 minutes faster than Fiasp, which is the ultra-short-acting insulin that Novo makes. It's 12.5 faster than Humalog, which is the rapid-acting insulin that Lilly makes. It's 13.9 minutes faster than Novo Rapid, which is the rapid-acting insulin that Novo makes. So this is an ultra-short-acting insulin. I haven't seen the Singh versus Glulysin, but it should be faster. Next slide. Now look at the postprandial profile. So one, it's more physiological. It closely matches the glucose profile of healthy subjects. Second, over the first 3 hours, they were comparable with healthy subjects. And also the most important is the lowest mean glucose excursion during the last meal versus Fiasp, Humalog, and Novorapid. So it's a true ultra-short-acting insulin, is more physiological, and a numerically greater glucose lowering versus all insulin. Remember, that's not statistically significant. On the other hand, in the first 5 hours, it is statistically significant versus Humalog and Novorapid. Next slide. So just to sort of summarize, it shows the fastest insulin absorption, significantly greater early insulin exposure, meaning closer to your glycemic index. Okay, reduced late insulin exposure, which means lower hyperglycemia, and a shorter duration of insulin action versus all the other comparators. A numerically greater glucose lowering versus the other comparators, and significant reduction in glucose excursions over 5 hours, right? The early postprandial profile of the ultra-rapid-acting Lispro, right, more closely matched with healthy subjects than other tested insulin. So clearly, it's sort of achieving what it was set to do. Next slide. But let's look at the data. Next slide. Next slide. In type 2 diabetes, you will find that it was non-inferior to Lispro. And you'll see this data in all the ultra-fast acting that they are non-inferior in terms of A1C. In type 1, they are superior. In type 2, they are non-inferior. Next slide. But importantly, you look at the postprandial excursions at week 26, significant control of postprandial glucose excursions versus Lispro, which is the rapid-acting insulin that Lilly makes, right? From 30 minutes to 4 hours after a meal. Next slide. And you look at the hyperglycemia, you will find no significant differences in terms of severe documented or nocturnal hypoglycemia. Next slide. The safety, very, very safe, overall comparable to Lispro. Next slide. So, one, ultra rapid in type 2 diabetes as opposed to type 1, which we saw before, non-inferior to Lispro for A1C over 26 weeks, no significant difference in the relevant categories of hyperglycemia, lower postprandial excursion, and safety profiles were similar. Next slide. Let's look at type 1 with the same lens. Next slide. The A1C here, you will notice that the A1C was non-inferior to Lispro at week 26, and you can see the difference here. Next slide. Numerically better, non-significant. Next slide. And look at the postprandial, you see the big difference that is happening. Earlier, starting at 15 minutes, you can see how different it is. And remember, type 1 is where these drugs really matter because that's where the risk of hyperglycemia is even more. Next slide. Safety and severe documented, similar incidence of hyperglycemia, right, including nocturnal, including random. Remember, we are comparing to already very good insulins. Next slide. And safety is pretty much the same. Next slide. This is the Pronto type 1 diabetes CGM study. They looked at blinded CGM to a subgroup of patients. Next slide. And the time in range, you see the time in range is increased by 44 minutes when compared to Lispro. No difference in lowering of daytime TAR and TBR. Importantly, the post-meal time spent in hypoglycemia is much lower with Guarana. This is exactly what you want from a drug. So where does it fit in? It fits in patients who need the convenience of postprandial dosing, who needs to eat and dose, who need better control postprandial, who need greater TIR, who can't be bothered to wait and then dose. And certainly in type 1, and a lot of difference. Next slide. So to summarize, next slide. 1. Prandial insulins match the physiologic glucose control, and the ultra short acting or the ultra rapid acting Lispro is one of them. Glycemic control throughout the postprandial site is necessary. These have faster absorption, more rapid onset, more importantly, provide mealtime flexibility to working people. Physiological that matches the early physiological glucose better than the other insulin, matches the same as healthy subjects. The PK profile shows that it is accelerated glucose absorption. Remember the two catalysts that do this. The PK profiles in other A1C, numerically better A1C control in type 1, greater mealtime flexibility, postprandial control slightly better, lower postprandial glucose excursions, and TIR seems to be better, especially in type 1. Safety is the same in type 1 and type 2. With this, let me stop. Happy to take any questions, and I'm grateful for this opportunity. I understand this is the last talk of the day, but thank you for having me in this.
With that, thank you so much. With that, we come to the end of another session of India. Thank you, all of you, for being here. Thank you, Vishal and company, for arranging this.
Can you hear me?
Thank you, sponsors who helped to fund this issue. Have a very enjoyable time in this conference. Thank you all. Thank you.
done already. What? No.